Hello, welcome back. The second day of live surgery. I have with me good friend Puya Degani Mobaraki. He's a rhinologist from Perugia, Italy. He was there with us hosting the first day. So today we're joining Prof. Rick Kara and Prof. Daniel Pravedella in Wexner Medical Center, Columbus, Ohio. And they have already started their case with craniopharyngioma, very interesting case. So the plan is to lift the left-sided nasopharyngeal septal flap, right-sided reverse flap, and approach the craniopharyngioma. So without further ado, let's go over to Ohio.
My name is Dr. Abib Agbatova. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant syncytial formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and syncytial formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draft tube B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening.
So we're just connecting the signal then. So what's your thoughts, Sophia? I think you're muted. Yeah.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble, and that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons.
This was the blind part of that incident.
And they're pretty
because
accurate.
I didn't get to very often, something that commonly happens. Take the photo. Okay. That seems to be disattached. Let's see what we have. We'll take the suction. There's the 2 meters that I did before. Just follow it way back. And if you excuse me for a second, it's Dr. I gotta give the scope and dissection to Dr. Callejas on a 10th page. Okay. I'll take the cuddle. At this point where you feel that the flap is sort of getting on the way of your position, we can always push it back into the disappearing a little bit. Take a blade. And I grab it the superior corner and push it straight back. I can see them touch here. Suction. caudal. Go ahead and do it. I'll take scissors. Go ahead and do it. Okay. Caudal. Suction. Profs, remove the sphenoid, move the flap as lateral as I can. And now we put in the nasopharynx. As you will see later, we do not leave the flap in the nasopharynx. We'll put it in the lateral nasal wall. Take the plate, please. This is something
Rick, can I check?
last few years.
Can I check with you?
And the flap is happier at the end of the surgery because it's completely flat, as opposed to being the nasopharynx forming a roll. So now the flap is out of the way. The next step, and this is going to be done by Dr. Callejas, is we're going to incise the septum, remove the bony septum, and form the reverse flap. So to make sure that we leave enough septum to support the nasal pyramid, could I have a caudal? One, you can palpate on the floor of the nose, and when it dips, that's your piriform aperture. You have premaxilla, so the septum has to be resting over the premaxilla. So this junction here is kind of perfect. Usually corresponds to the head of the inferior turbinate to make your transfixion and remove the bone on the other side, remove the bone of the septum. You can also confirm with the navigation system. So let's confirm it. Can we show them the navigation? Yep. Okay. So you see on the sagittal view, you see that the septum that I'm leaving is resting on the premaxilla, and it has enough support for the nasal pyramid. There have been reports of saddle nose. I have never had a saddle nose in a patient that I have been able to leave that much septum. So it was surprising to me that there was a report with 15% saddle nose formation. I think that if you do pay attention to these details, it's very unlikely that you're going to have a saddle nose. So with that, I'm going to leave Dr. Callejas leaving the reverse flap. I apologize, but I'm juggling many commitments today, so he will be able to answer any questions you may have, and I'll come back in about 45 minutes or so. Any questions?
Thank you, Rick. That was excellent. Yes, a question for you. It's how do you decide the width of the flap that you're going to require?
Is the length of the flap there? The length of the flap, sorry, is the question the length of the flap?
The width of the flap, sir.
Oh, the side of the flap. For the most part, 90% of the time, we do it on the right side, because that's the side that we remove the middle turbinate and do the ethmoidectomy, and we have a lot of space. And now, exceptions to that is septums like today, that you have a big spur to the other side. You don't want to have a tear in the middle of the flap. Or if you're doing a transpterygoid approach, where the blood supply of the flap is going to be, or is potentially compromised, then I would do it from the other side.
Okay, thank you. And how wide do you plan the flap?
So the width is, most of our flaps are going to be from the olfactory strip to the junction of the columella and to the junction of the septum and the nasal floor. So something like a transplantar approach that's very wide is much wider than the planum.
Okay.
There are some exceptions where, for example, some of the transclival approaches and combined approaches and the anterior cranial fossa, you may want to do it a little bit wider, and we extend it to the floor of the nose. If you are doing a olfactory groove meningioma where the patient is anosmic, then you don't have to worry about preserving the olfactory strip. You can go to the very top of the septum and also include that paddle in the flap.
Thank you.
You're very welcome. All right, we'll be back in 45 minutes, and you can watch Dr. Callejas here. If he fails to do it right, let me know.
Thank you.
Thanks, Dr. Rao. Good morning, everyone. A pleasure.
Hi, good morning, Claudia. Welcome. Thanks for joining us. Claudia, I have Puya with me. Puya is my co-host today.
Good morning, everyone. Good morning, Prof.
Hi.
Good morning, Ricardo.
Can I have the scissors? So there's a little bit there still. Could I have the action script? So I'm finishing the last part of the flap here, joining it to the nose. That will allow me to push it more into the nasopharynx to pull it away. So now we'll continue with our posteriors or our spectrum.
So you always preserve the flap in the nasopharynx, or
I will
do you consider keeping it in the maxillary antrum as well?
This is as I part, this is the form aperture. So I will set a little more posterior, just in case. We might have a tear in the other side because there's burr. Can I have action? Can I have some root part of the cartilage step, and I would do heavy like so I will possibly in the bone. That was can have a placely. So basically, I'm going to revolve the posterior part of the septum, and we will the incisions to the mucosa of the right side of the septum covering the left side of the septum covering the right side covering the septum.
So Claudia, do you always do the reverse flap?
Have both. Be a little because a big.
Hello, Claudia, can you hear us?
I might have here.
Hello, Claudia, can you hear us?
So far, so suction. Briefly. Can I have the Prof? Thanks. I'm making sure of all of the pieces of bone in order to be able to the incision, if not the bone will prevent. This. Thanks. Could you please? Perfect. So I think I have enough bone. I'm going to check. I want you to do the real incision of the reverse flap at the height of the nostril in the right. Just checking. Should be fine. So to make sure I'm the right side, I will start the right side. Can I have the brachial side? Need to section from the side.
Hello, can you hear us from the studio?
Fine.
Hello, Claudia, can you hear us from the studio?
Okay. Thanks. I was this is the height of the also I was a little higher to have more mucosa to cover the other side. Thanks. Can I have? Could you read it? Okay. So that's our superior cat. And now the inferior one. Mm-hmm. So a left leg there. Can I have? Let's go. Can I have it? And now we have to connect both incisions posteriorly. I will use the cautery instead of cut for this because I will make the posterior nasal artery deep. Right. Thanks. Okay, can I have the GoPro? So now I can rotate this cosa, cover the card. I might need to remove a little bit more of bone. Check. Yeah, I will remove a little bit more of cartilage here and bone to be able to reach the anterior incision of the nasal septum. Can I have the maybe? Lexley? I have the I have the okay. Let's see. Can I have the GoPro? Have the back. This is the headband. Hook. So now I'm extending my vision in order to extend the reach of the rescue flap of the reverse. Sorry. Okay. Can I have the both? Forget you? Both? And now we can future this reverse to the anterior of the septal flap. You can see that we will have mucosa instead of exposed cartilage. So this is a little bit of a difficult feature. Can we have a photograph? Can you? And that's this. This is my less favorite part of the case. I will need light. Thank you. Okay. So I'm using Macquarie to do this here. Scissors. Thanks. You can do separate stitches. I will do it around it to do that knot. And it's like
Can you hear us from the studio? Hello, Claudia.
one more and done.
So it looks like there's no connection with the audio with the theater. Okay, just to recap, we have joined Wexner Medical Center in Columbus in Ohio. This is Prof. Rickara and Prof. Daniel Provedella. They are demonstrating case of craniopharyngioma. So they made a start. On the right side, they've done a ethmoidectomy and a splenectomy. The reconstruction has been planned with the left-sided nasoseptal flap, that is reverse, with the reverse flap, which has been sutured in place now on the screen. They chose to do the nasoseptal flap on the left side because there was a septal deviation on the right. And then because we need a bilateral splenectomy and a septal window, the reverse flap also suits well in this situation. So can I check with you, Puya? what is your practice? Do you always do the reverse flap, or only when necessary?
The use of the reverse flap, I barely use it. It's just because I don't have the amount of cases to work with the neurosurgeon. But I think that is pretty useful in extensive cases. I remember back then when I was working with a neurosurgeon for advanced cases, they were actually asking us to perform that initially as performed by our colleagues in Ohio. And it was quite satisfying seeing how much faster the restore of the mucosa will happen when you're using the reverse flap. And I completely agree with the colleagues in the fact of recognizing the importance of the support of the nasal septum will prevent the saddle nose, as previously said by Ricardo. The aesthetic now cannot be complained anymore because we know how to prevent those events, and the reason for that is also not only for primary cases, but also in case you need support in future consideration. If you have to, reuse nasal septum cartilage, it will also be useful for that.
Yep, very right. And you've seen all the nuances of the technique that Prof. Kara demonstrated. It's about how to preserve the olfaction. The transition zone between the yellow olfactory mucosa and the rest of the nasal mucosa. So he's making the superior cut along that transition zone.
So it never looked very beautiful at the end after suturing this part, but in the post-op at 5 to 7 days, it heals very nicely. We also have to do a quilting suture of that reverse flap, but in interest of time, I will do that at the end of the case. So now we will continue exposing our sphenoids, and we'll connect them and do a wide sphenoidotomy. Can I have the Harrison? So now we have a big corridor. You can see to work very comfortable. Can I have better the Jensen Miller?
So while on Monday, we saw Prof. Paolo Battaglia. He raised a unilateral nasal flap for the reconstruction of the CSF leak. And they did not do the reverse flap because they used the silastic sheet to encourage the mucosal regeneration of the... And it probably takes a little longer time, but it does if it allows. So it's really based on the demand of the case. You can modify your approach.
And I will the sphenoid mucosa because we will put an isoseptal flap at the end. Can I have? Would you? So this is a right dominant. You can see that the left one is quite small. Can I have 3 or 4? Thanks. Extending my dichotomy. Harrison, down by. So now I'm definitely clearly. I'm going using the size of the heel, if not I won't be able to remove it through the nostrils. Let's wait. Can I have code? Okay. I will also raise this olfactory to have a better exposure of the planum. So we will open them like a 10 in each side to protect action and to have a view of the planum. Okay. Now I will ask Dr. Lee to drive for me, and I will start drilling in interest of time. Okay. Let me get it first. Can I have both? Did we get?
You start seeing some of the landmarks there.
Then Costa here. I will require a bolt. No.
You see, Ashok, how much importance nowadays it's referred to decrease morbidity, and how much importance has been, attention is placed for olfaction to drop morbidity as much as possible. Something that 15 years ago was quite not relevant, but now we're giving that much importance to such morbidity, to dropping the morbidity. I love, how much importance for olfaction, exposure, but preserving olfaction is quite impressive.
Absolutely. The quality of life is important, and also the long-term consequences with the cosmesis. Being careful about all the structural nasal supports, like the 2-point fixation, like making sure that the cartilage is rested well on the maxillary spine, anterior septal, anteronasal spine, and also the keystone area. Keystone area is vital, and we saw how Prof was very careful of the keystone area, not disrupting that, and that's how you're going to prevent the saddles in future. It's impressive that they have not had any saddling, despite of such a huge practice, and that goes on to show that being careful with this structural support is so important.
Okay.
So we're seeing here is a right dominant sphenoid. The left sphenoid is smaller. So they've already done the ethmoidectomy, and it's probably now reducing the sphenoid floor.
So I the pedal of the nasoseptal flap, and I will use my suction to pull it away from my drill.
The bone tends to be quite thick sometimes, and you can't often take it away with the rongers or the punches. So you need a drill to reduce all this, to reduce the sphenoid floor on the rostrum.
We'll take this all the way to the floor this time. This is getting origin, but can we have that? Thanks. What if you press what happened? Can I press? Can I have the Pro in there?
And Puya, as you know, that when you're dealing with the sphenoid septums, one need to be very careful not to very aggressively avulse the septum, because some of the septa, especially lateral septa, can be going to the carotid. So you need to be careful with it, and that's where the drill again helps, thinning down the sphenoid septum. And very carefully, you're almost like through biting the septum rather than avulsing it.
I think that the importance of the preoperative scanning is also to understand the variation that you have. Of course, sometimes, as you already said, septation can attach to vital structure. We've seen a lot of patients having, for example, the attachment of the rostrum and some septae to the optical carotid recess, and that's the importance of using both cutting instruments, drills, to avoid important fractures that will lead to consequences.
Yeah. Shall we put that? Can I have the skeleton in the meantime? We're having some issues with the drill. In the meantime, we just the carry.
You see how with the septum, under using the punches, it's a very crisp bite of the punch rather than avulsing the septum.
Can I have an? This is not good. Now should work. No, it works. Yes. Of course. Could you closer? Okay. I'm very careful not to fracture stations, just by them. Actually, this septum goes straight to the carotid. You can see it there. I think it was working for. No, maybe the other pedal. Do you have the other pedal? The black. Where is? Because now it's working. Right. Yes, perfect. Much. Can I have a toolkit? Being very careful to push the pedal of the flap laterally with my suction. This is really hot. So can I have flap? So when I'm doing, I'm pushing this lateral. I don't want to injure the pedal. Can we try? I need to alternate like this. Okay. Section can have a 12 ratio. Much.
As Claudia is reducing the septum, some of the structures in the sphenoid are becoming apparent now. You can see the sella, the suction is in intracellular recess. You got a glimpse of the optic nerves on the
Really hot.
both sides.
Is that a optic?
So, in the meantime, I will show you a little bit of the anatomy. Can you do it, Johnson? So here we have our olfactory strip that has been pushed laterally across the plant. Here you can see the plant sphenoidal. Actually here. That's the sella.
Nice
You can see the
carotid
carotid there. Optic nerve. Lateral carotid pieces. Carotid left side, you can see how the septations go to the carotid. So it's very important not to fracture these septations, but to bite them, glue them. Here you can see the paraclival carotid in each side. So I'm waiting for the new.
So the bone over the carotid is very thin.
We are almost there at the plant. Maybe we should call Dr. Perel also in the room. Yeah. So in the meantime, while I'm waiting, I'm going to put the nasal flap in the lateral nasal wall. Can I have a good idea though? Can I have a take sleep? Thank you. And I will need the switcher for the stop.
I think this might be a good time to take a short break. We're waiting for Prof. to arrive. So maybe you can have a look at some of the informational videos from Medtronic, Dinesh.
After completion of the Draft 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour propel stent in both the left and right neofrontal ostium.
Yeah.
However, given our increased access to in-office use of the propel device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulent, and less bleeding. At the patient's second postoperative visit, the patient was known to have minimal edema, no synechiae formation, and minimal crusting. The contour propel stents were found to be in excellent position. This is a very interesting case in light of the patient missing multiple postoperative visits secondary to both the COVID pandemic and the patient himself contracting COVID. I truly believe this is an unforeseen advantage. The 2-in-1 mechanism allowing for mechanical spacing and localized drug delivery, I believe, may have prevented restenosis, synechiae formation, and the need for potential additional surgeries. At the patient's third postoperative visit, 1 month removed from the surgical date, the patient was noted to have very minimal tissue edema, no crusting, and again, no synechiae formation. There was no signs of any stenosis, and again, the contour propel stents were found to be in excellent position with minimal adjacent crusting. At the patient's fourth postoperative visit, now 3 months removed from the surgical date, the neofrontal ostium bilaterally were found to be widely patent. No evidence of mucosal edema, synechiae formation, or evidence of restenosis. The contour propel stents themselves have been degraded and or debrided. Chronic sinusitis is a chronic inflammatory disorder. Steroids are immensely helpful. So the idea of us placing an implant that will release steroids over a period of 4 to 6 weeks, but minimizing the side effects of systemic steroids, I think is a significant advantage for patients. At this 3-month follow-up, the patient reported resolution of his sinus headaches, postnasal drainage, as well as his nasal congestion. For patients with chronic sinusitis, with true chronic rhinosinusitis, there are so many different variables in place. We all know it's a very heterogeneous disorder. And so trying to predict how one patient may heal versus another can be very, very difficult. Even in patients with nasal polyps, there's a wide spectrum. So I really like the idea of an implant, a steroid-releasing implant, as insurance in many cases. Anytime I'm doing any type of formal frontal sinus dissection, when feasible, I like placing the contour propel stent because you never know what patient is going to be prone to synechii formation or stenosis. Some patients may have moderate disease, but may have a propensity for scar formation, whereas others may have very severe disease, but may do very well without placement. And so trying to decide who to place it in can be very, very tough. One of the advantages of now being able to place it post-operatively is that if you don't feel comfortable or if you feel like you would like to avoid placing it in the operating room, you now have the advantage of placing it in the office setting. If you see someone who has increased edema in the frontal recess or increased edema in the ethmoid cavity, or maybe their middle meatus is becoming a little bit more narrow and their middle turbinate is somewhat lateralizing, now you have the option of placing a propel stent in the office so that we can combat the edema, we can combat the inflammation, and then we can allow for mechanical spacing of the delivery device or of the propel stent. Tissue and wound healing can be very unpredictable in this patient population. We all know that the sinus cavity that's most likely to stenose is that frontal recess and that frontal neosteum. So for me personally, any type of formal dissection involving the frontal sinus, I am most likely going to place a contour propel stent. Whether that's in the OR or in the in-office setting will be patient dependent.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use that a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, and especially in patients with severe polyps and Samson's trial. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
We start the other part. I might start in the plan. Can I have the can we put the in rhino? In right. Could you go a little higher? Yeah, that's okay.
So we're back to the OR after a small break. So you can see Claudia is drilling over the cellar, drilling of the cellar bone. So this is a case of craniopharyngioma. It's being operated in Wexner Medical Center in Columbus, Ohio. Prof. Ritkara, he has just raised the nasoseptal flap, the reverse flap, and now Claudia is drilling the cellar, widening the sphenoid. And soon Prof. Danny Provedello will be joining us to continue further with the surgery. So this is the second day of Spring Grace Live 2024. So we had a fantastic first day. Great surgeries from Italy and Spain with Prof. Manuel Barnes Speckelson and Prof. Paulo Casanova.
We're waiting.
And after this,
Now for the other and continue the rest. Shall I start doing the plan? No? Does this okay. Can I have navigation? Can we show the navigation? Thanks. So that's
Yes.
it vertical up there? Okay. You can see the sagittal deletion. So that's like live carotid. I guess carotid. I think we have enough or not. Can you? Yeah. So now Dr. Lucas and Dr. Provedello join us for the next part case. Can I have a got this. think I need a bigger.
So, Claudio, can you hear us from the studio? Can you tell us more about these stylistic roles that we are using? What is the purpose, and do you use it on both sides? I can see I've got that on both sides.
Okay, let's have a look here. You want to have a look here? Can I have the rear? Pretty good. Would be good. I think good. So remember the nasal plus is in the left side of.
I think they're probably not hearing us, but sounds like the stylistic sheet is there to protect the endoscope getting smeared with the blood and protecting the mucosa.
I was thinking the same, but also for the passages of the endoscope when it goes out and goes inside, probably to avoid injuries to the septum.
Correct, yeah.
Microphone.
Plus also prevents a lot of drying because remember it's long surgeries. It can easily, because it can get dry, the blood clots and all that. So it's a very good idea to protect the mucosa and also to have a clear view on the endoscope. Yes, we can. Hello.
Can you hear me okay there? This is Danny Prof here.
Yes, we can hear you, Danny. Welcome, and thank you for planning this lovely surgery today for us.
Thank you. Thank you. Thank you guys for organizing this. What we're doing now, drilling the cellar here. As you saw, this is a cystic lesion located behind the pituitary stalk. So it's a little challenge to get there. It does go posteriorly, but I don't know if it was discussed earlier, but interestingly, it actually doesn't enter the third ventricle per se. It goes posteriorly, kind of creating a cyst in the right hypothalamic area. And so when I debate in terms of approaches for this, the option of coming with an endoscope interventricular that we always consider. I know the audience is mainly ENTs there, but for the neurosurgeons that are watching, and this is it will be an option to come endoscopically from the top when it is inside the third ventricle. But this actually, it goes into from below, it kind of creates a cystic. Maybe we can share here, I can show what I'm talking about. If you see there. Hold on. All right, let's go. If you look at here, it really kind of goes, this is not in the third ventricle, and it's really just dilating the undersurface of the right hypothalamus. So it's very different type of lesion here. We believe this is a craniopharyngioma, but we don't know for sure. As you can see here on the axial as well, it kind of it insinuates into the ventricle, but really is coming on the undersurface of the hypothalamus. So we'll see. It will be a little bit of a blocked view because there will be a narrow space. Once we open the dura, the optic chiasm is going to be anterior, and we're going to probably see a little bit of the stalk, as you can see here. And I'm hoping that there is this ballooning here on the left side of the stalk that we can reach, and maybe on the right as well, that we can reach and go work below the chiasm. We told the patient we're not sure if we're going to be able to remove this capsule, but definitely the idea of fenestration is the goal, and some diagnosis as well. This could be a papillary craniopharyngioma, so we change our approaches over the years. If this proves to be a papillary craniopharyngioma, it may be a tumor that will melt with BRAF inhibitors. That's why you will see We may not be very aggressive with the resection here. It's really the compression of the hypothalamus is the number one goal of the surgery. And the diagnosis is as important because, like I said, if it is a papillary craniopharyngioma, it's a different entity, and that can respond with utilization of BRAF inhibitors these days. So we just want to try to keep his function still viable. He has normal pituitary gland function, so that's another challenge here for us because, you know, this is on the stalk and high chance of diabetes insipidus and all that. So right now we can go back to the endoscopic view here. Well, we're drilling the sella, and we'll drill that tuberculum sella. There's no need for planum resection because, as you saw earlier, if we open the planum, we'll have a visualization of the undersurface of the frontal lobes, and that's not the goal here. The tuberculum will allow us to get a full visualization of the front of the chiasm, and we're going to then work below that chiasm, in between the pituitary gland and the chiasm. We're going to drill that septation on the left side as well, and drill the part of that tuberculum. And if this was a meningioma, we expose the medial aspect of the internal carotid artery as it goes through the annul of the ring, the distal ring. But for craniopharyngiomas, we don't really need to expose the carotid laterally. We can open the bone all the way up to the carotid arteries. Doesn't really require a full exposure, skeletonization. So we do drill at the base of the optics laterally to get a little space in between the tuberculum sella to get expanded there, up just above the carotid arteries. So that's basically what we're doing. We'll take our time here and keep going. I'm not sure if you have other centers to broadcast, but we can.
We plan to stay with you, Danny, and it will be great to start through the surgery. We're having Professor Richard Harvey from Sydney joining us in around 3.5 hours. So we almost have a solo run until then. So that will be great to continue with the surgery. So we are still historically not sure what the definitive craniopharyngiomas would be. Are you planning to send any frozen sections, and will they really help in your strategy, even if you get any answer from that? Will that change your plan?
Question. We typically don't send anything since the likelihood of craniopharyngoma is very high. And it may not change our plan and what we do here, because they are typically not able to tell us if it is a papillary versus adamantinomatous right away. They can favor one or the other. The fact that there's no calcification on the preoperative CT here increases the chance that this is really papillary. But they can also, if we have a small specimen, we'll send it for frozen, but it's not something that will really change much of our decision here and what to do. More important is really to look at the interface between the cyst wall and the hypothalamus, see how adherent it is, and that's what we can tailor the resection and make our decisions based on that. So we'll see if we can get a little specimen that we've sent to them.
Looking for the superior intercavernous sinus now and reducing the tuberculum, right?
Good morning, Danny. It's me, Puya. I'm sorry. I have a question. Just for the younger, not neuroradiologist or neurosurgeon, would you please explain what's the difference when you explained the distal ring? What is the difference between the distal ring and internal ring?
So the distal ring of the carotid artery, if you see there, medial to where we're drilling right now, that's where the distal ring ends there. The distal ring is that's carotid right there. The distal ring is It's like a dura attachment where the internal carotid artery is traveling from cavernous sinus, and the paraclinoid segment is diving from that space to the intracranial space. That's called the distal ring. It's basically that where it pierces the dura to become subarachnoid next to the optic nerves. And proximal ring, it's more like a cavernous sinus structure that is proximally located just below the optic carotid recess that we don't expose on the surgeons. More like more important for surgeons performing inside the cavernous sinus. This, yeah, flat down. So here, what we're taking this bar and part of the tuberculum transitioning with the planum. That part we're going to remove, and we will drill in the direction of the optic nerve on both sides, because that way we are above the carotid arteries, and we will do that before taking the tuberculum sellae. That helps us safety there. We'll remove that mucosa, whatever it is, as well on the left. Yeah. Give a better visualization. We're going to optimize here visualization of the left optic nerve, because that's the part we want to take a little bit of that mucosa. Now you can see the optic nerve a little better there on the left. And we're going to drill like from just the height of the optic nerve to be at the level of the chiasm. We don't need to be more anterior than that or more to the planum, but that area we should expose as well. That is a safe drilling because you're above the carotid when we do this drilling here.
Do you want the mic? We have more. Okay, yes. Thanks. On the left, yes. Yeah, I had to put that because. Okay. Because it was getting very dirty.
Okay. Perfect.
Yeah, so you can follow the position of the optic nerve. That helps us to optimize the drill out of the tuberculum here. So drilling it, just making a little bit of a flatten of the planus sphenoidale, just to give us a space. And then the resection of the bone will be really focused at the level of the optic canals. We're lucky here because this is relatively well pneumatized, so sometimes we do need to rely more on navigation to find the structures. When you have those situations, typically what we do first is to identify the sella, and then from the cella identify the clival recess, and then the tuberculum and planum afterwards. But very important to find the cella first is very helpful. And here we do need to drill from carotid to carotid to get decent space in the suprasellar area. But like I said, we're not dealing with a meningioma that has lateral implantation. So when there is lateral implantation, then we need to remove more and expose that distal ring of the carotid. Today here we can get up to the distal ring medially on both sides, and that will be hopefully good enough to get us a good exposure of the region there. What you see now that we expose here in between the planum and tuberculum, you see the ligament. We call that the medial extension of the falciform ligament. And that once you find that bar is also another landmark, very important, because it shows us the roof of the optic canals. It extends with the roof of the optic canal. Can we have the traditional drill? It could be a 3 millimeter. No, the traditional one, extended. Yeah. Yeah, you can. Yeah. We always expose this cella that allows us to have more freedom of movement, and when we retract the dura down, so we like to take the bone of the cella, optimize our freedom of movement. Did he?
That probably also will help if you need a pituitary transposition.
Do you have any other case
I
in
think
parallel happening now?
This is the
or
only case,
what,
Danny, at the moment.
what else is happening?
So they're having parallel.
Oh, okay.
3 hours.
I know you.
Yes, correct. Yeah.
Previously, we have several at the same time.
I think there was a demand from our viewers that they wanted to.
See, we make the bone thin, and then we elevate with a carousel like this. We feel that's a very safe maneuver. Yes. Instead of like biting the bone, we go until it's very nice and thin, and then we crack the little flakes of bone away from the carotid and optic nerves. If we really need to expose the optic canal, then we go from anterior to posterior by finding lamina papyritia and then cracking the bone from medial to lateral. Here today, we just need the very medial aspect. So this is why we're just proceeding with this angle. We don't really need to expose all the optic canal, but definitely the tuberculum, we're taking it out, the rest of the tuberculum cella here. And we're gonna work on that bone medial to the optic canal, as you see, like we call the medial OCR. That will be the only last part here that we gotta drill to get more optimization of space in the suprasellar space. So this is the rest of the tuberculum. You can see a little transitioning from cella to the tuberculum dura. And there's a little more of a bone we may need to drill. We're just gonna see how thin it is right now.
You want to go closer? Or?
We may need to drill a little more of the medial portion of the optic canals on both sides and then connect.
Do they have that? Did he? I will have to.
This is a very interesting concept that it's new for us as well. I think we have only 3 patients in our series where we perform a conservative surgery for craniopharyngioma to confirm it's papillary. And then once confirmed it's papillary, then we go more on the medical treatment. So this is, we're in the future where we stop doing more radical. Like we used to get these cysts and really like force them out. And back in the day, people had the hypothalamic issues and obesity. And so with this concept of possibility of a papillary, it changes completely because our goal really is diagnostic and decompression today. It's very important to emphasize that because I do think some places around the world are not familiar with that concept and may still be doing a more radical resection, which is not necessary or not in the best interest of the patient here. So we just really need to get more exposure
Yeah, I
to
think that's
biopsy
a
decompress.
great advancement, isn't it? So otherwise, these patients are at a very high risk of morbidities of vascular injuries or hypothalamic injuries, and it's really great for them. So, what is the medical management? You want to elaborate on that, Ravi? Okay.
Yeah, BRAF inhibitors as the main portion of the the oncologists, they associate some other treatment as well. But the BRAF inhibitors, this is started with the work with melanomas, and they identified a BRAF mutation on the melanomas, and the use of BRAF inhibitors made a huge change in shrinking lots of melanoma systemically. And I think it was Priscilla Brastianos from and her team from Boston. They were the first ones that presented a case where they confirmed papillary craniopharyngioma as their recurrent ones. We been using in a way that we even avoid radiation, like we are doing resection partially just for diagnosis, and then we complement with the BRAF inhibitor therapy. It's controversial if you carry that for 6 months or a year. We've done for a year in our patients. We have one doctor patient who has been 2 or 3 years out and no recurrence after that type of treatment. Is quite impressive. There is some side effects. It's not free of side effects, but better for the patient than cause upon hypopituitarism and other issues. So that's why we're being very conservative with these cases these days. This cyst grew fast. Like this patient was observing a suprasellar cyst less than a year ago, and then in less than a year, it grew in size probably 4 times the size of the cyst. That's why we indicate the surgery initially, because his pituitary function is normal, and his vision is being affected slightly right now. But go ahead. Yeah, good. Yeah, so different concept.
That's a great message to have. You mentioned about preoperatively indication is the calcification is one of the indicator for towards the papillary carcinoma, correct? So towards papillary craniopharyngioma.
Can you?
Sorry, we seem to have lost the audio connection from the OR. Yeah, we're back. Thank you. Oh, okay.
I was unmuted before, yeah, sorry.
Okay.
Yeah, that was just a transient. We're back. Okay, good. Can you could just for Yeah. Yeah. So I was talking to Rick here, well, just to mention some of in terms of strategy. You know, as you know, this case, we did the flap on the left side because of the spur that was present on the right, but it does create some difficulties for us. And some of the aspects is like, we typically prefer to have the flap on the right, because as right-hand surgeons, we use the drill on the patient's left. If the flap is there, it does use some of the space. The other issue is if you have a drill that is not protected, you may be touching the spinning part of the drill shaft on the pedicle of the flap on the left. So you have to really pay attention that anytime you're drilling on the same side of the flap. If you're a left-hand surgeon and you have a flap on the right, that may be the same issue. So those are important considerations every time we're drilling. The other thing here is because we do have the ethmoidal cells is still on the left, and then the turbinate and lateralize, and the flap is on the left. It does create a little bulky space there for us to maneuver the drill. So they have to have that in mind as well when you're considering. I think if this was more involved, like it needed really extra space, if this was a meningioma, for instance, that we need to lateralize more the exposure, probably one option is to do a little more aggressive ethmoidectomies on the left side if you really need to get your flap on the left in order to get the flap more lateralized against the wall of the orbit there and the maxillary sinus. We felt that for this case, since it's we really just need that space in the inter-optic space in the suprasellar. Hopefully this, what we have here will be good enough. Once again, we drilled and tried to make it thin, and then we elevate the bone. And these beaks that you see, that we call the medial OCR, basically the encounter between the optic and the carotid arteries, as this is very close to the distal ring that we talked about. We just got to work a little more here to get more space and freedom of movement in between the two carotid arteries here. So we'll make it thinner a little more. We always experiment with the carats and see how thick it is, and this seems a little thick. So we'll go back to drill, and we do this exercise several times. We drill and try. If it's thick, we'll go back and drill a little more until we were able to rotate that piece of bone away from the medial optic canals and as close as we get from the carotid. As I mentioned earlier, without really the need of exposing the carotid artery on this case, but we want to optimize the space. If you leave too much bone there, then you end up with difficulties to move your instruments once in the subarachnoid space. You see that we watch that ligament in the midline, and by staying at that level, we know we're at the level of the optic canal above the carotid. You can see better on the right side, where you can see a better pneumatization of the lateral optic carotid recess. You can see if you drill at the level of the optic, you're above the carotid artery there. We got to focus on that optic recess medially then to expose the bone just medial to the carotid artery. You can have sometimes some meconal arteries in this region, branches of the carotid artery that go to the dura of this region here in the medial optic, and they are usually hypertrophic in tuberculum cellular but not so much in craniopharyngioma like this one, because the normal anatomy here at the skull base versus the meningioma that actually creates development changes as hypertrophic, like hyperostosis, and vessels can get dilated in this area to give nutrition to tuberculum cellular meningiomas that we don't see much in craniopharyngioma. So because all the disease is basically centered on the pituitary stalk and not on the skull base itself, like as you see in a meningioma.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G-meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons.
I went down to a 3 millimeter here. It's a little slower process, but it's safer when you're drilling closer to the carotid artery. And this is really just to optimize our freedom of movement once we open the dura there. Let me see the Kerrison. So like I said, we'll I was experimenting and checking the how it feels there. It feels a little, that will do it. You can see the area where the osteotomy helped. Here may need a little more, because when I move, I see everything moving, so this part needs a little more work. So we'll do a little more on that corner. It's getting closer to what we need here. I'm just gonna take this piece of triangular shape next to the carotid here. And then we'll do the same thing on the other side. And after that, we should be able to be ready to open dura. Once again, we have a little bit of plano, but we were not going to open the dura all the way there. We remove the bone more for avoiding constriction. Now I'm focusing here really in creating an osteotomy where when I lift the bone, it will fold right there. Let's see a Carrison. Exactly what we needed. Precise. And maybe a little bit on this corner here as well. Now I'm getting close to the carotid artery, as you can see. Just trim this. I think this will do it. Let me just optimize above. I was getting a nice square here from the distal ring. The distal ring is about to be exposed here. But like I said, we just got to get closer in this case. Maybe a little more here. Trimming there. I think this is not bad. I think it's right at the carotid. Now we're going to do the same on the other side. Here looks like the carotid is already very close. Let's go to the 3 curved, protected. Say it again.
Do you want me to push the ethmoid laterally?
Let's try a little bit, yeah.
Can I have the clear?
Then you open the door. Then you Things okay? Should be good, right? More. Should I open more?
It's hard, it's a long thing.
Yeah.
You have to drill now the skin is open, but
Okay. Now we're gonna open a little more here on patient's left. It should be good. You see the carotid coming inferiorly right there. You see the collar. So this side we already optimized, almost there. We'll just take a little more here above the carotid. Yeah, that is on the carotid. This drill I changed. This is a protected drill because I didn't want to touch the pedicle of the flap, but you can see here the carotid is right there. You see the pulsations, but it aims this way, kind of comes medially there. You can see the pulsations. There's just maybe a millimeter that we could remove here if you want to stay medial to the entrance of the carotid artery. So I'm just going to make a little thinner there, and you see the kerosene. And once again, we try not to bite here because you can not realize and go under that curvature of the carotid. So how about 1 millimeter, a little more delicate. So you can see that on the right side, we open all the way here. Here it still has bone, so we're just going to make it symmetrical. And like I said, we don't expect major micro dissection in this case, maybe a little bit, but not major due to the goals that we talked about. So that's why I think this here is hopefully a good opening, enough for us to triangulate the instruments in the subarachnoid space. For meningioma will be more aggressive here, exposing the carotid, as the tumor can implant on top of the carotid as well. And it's like skull-based. Almost symmetrical. Could you decrease the SSCP's intensity a little bit, please? Everything is shaking. They there though? What? Where are they? Is it this gentleman? Could you decrease the intensity of the SSCPs, please? Yes. It's a little shaky. The world's going to think that I...
Could we get paralyzed?
Say it again?
Could we paralyze the patient?
Patient can be paralyzed, no problem. We're not monitoring cranial nerve.
Yeah, that's what I think. Thank you.
Yeah. I think that's pretty good there. What do you think? Good space? Should be good enough. We got an ultrasound now. Like, do you have the camera on the ultrasound? We need to make sure the name is covered, though. You can see the bubbles there. Can you put water? Fill up with water. Here we go. It's interesting. It's cystic, but it looks like denser on the ultrasound. Yeah. Video, please. Nice. Oh, it went up. Oh. Do you have the camera there? Yeah. That one? Perfect. Could you record for us? So you can see the ultrasound here. Like, you see those spheres deeper located. Surprisingly, looks much denser than fluid. So if you see the water here, it will be dark and is hyperechoic, the cystic structures. I'm a little surprised. I thought we will see less of density there, but that is what it is. So you can see, and if I put it vertically there, you can see this structures going south and then going a little further superiorly there. If you see, this is the posterior gland, that little shape, maybe you can see closer to the surface, that's pituitary gland. This is at the level of the gland now, and you see the posterior gland, that little dark oval lentil shape. Ashley, maybe you put your finger there, maybe so they can see go put your finger on the imaging, so because they're looking at the imaging, or their arrow a little further superior. Go up. There. This is posterior gland. And in front of it, which is just a little further up, that's the normal gland. And now if I go up here, now you're seeing the cyst. Now all that structure below the arrow, it's all cystic. Okay, we're ready. We're going to open the dura now. Could you, yeah. Good. Could you remove the overview?
So then at what point do you open the dura, or are you looking for any landmarks or any? Sorry, we lost the sound.
Good. Here, so what we're going to do, open the dura, go ahead. I think for our goals of the surgery, this opening is pretty good. We're going to open like a Y shape. So we're going to start, we can start with we're going to start with a linear midline from the level of the falciform ligament or the medial extension of the falciform ligament there, as we discussed, all the way down to the superior intercavernous sinus. So for this case, we don't want to enter the superior intercavernous sinus for now, unless there's a need, like a limitant of exposure. We may need to go there and sacrifice that area.
So it's
most of the time for craniopharyngiomas, we do expose the pituitary gland as well. So there is if we feel that we landed too high on the stalk, close to the optic, we may need to open that.
So staying above the sinus, right?
You know what? Let's go ahead and let's. The sala and superior above it, and then we'll cut the superior intercavernous sinus. I think for this case, we'll need that space. Here we go. Is it 2? Oh, it is 100, yeah. Or 40. Just do 40. Go ahead and give me sound. Yeah, so change my mind here. I think this is going to be better to control the superior intercavernous sinus now than once the dura is open. So we're going to go ahead and show you a little technique that we use. We actually going to expose below the superior intercavernous sinus to expose the gland. And we're going to make a little cut vertically in the middle here in the superior cavernous sinus intentionally, so we can then inject a flow seal or Surgiflow or any of these hemostatic agents, almost like obliterating that, which makes easier to control, less bleeding then eventually there. Okay, go ahead and cut the vertical, cut superior intercavernous sinus. Yeah, from midway down. right there. We're going to make this vertical cut here intentionally. It's going to just so it bleeds venous there. Move high a little bit. That will allow us to push hemostatic agent inside. We used to just bipolar. We do both these days. This is makes it faster. So you will see this is an intentional venous exposure, and then we push a little bit of a hemostatic agent under pressure, and you will see it kind of filling up that segment of the superior intercavernous sinus right there. There, you see it obliterated. And that allows us to continue here with less of a venous bleeding. So we're going to expose the pituitary gland a little bit with the dura below the superior intercavernous sinus, and then we're going to go above it. And then when we cut, it bleeds less. We're going to push a little more. There's another channel. And it's better to bleed now before opening the dura. Here we go. Now it's nice and filled up. Sometimes when we touch the suction, we kind of bring some of that hemostatic out, and it bleeds again. So that we just got to do this sometimes 2 or 3 times. We're going to open the cell a little more just to really visualize. We don't need to go all the way down, but really maybe with the ball probe here, we will expose we put it down a little further down. Yeah. And then with this now is a cellular level here, so then we know we're exactly on top of the gland. That will allow us to be as low as possible. That's why I changed my mind here, because if we landed too high, we may not have space between the gland and the optics there. And it's common to find more of these channels. As I said, we'll push a little more of this hemostatic agent in a little bit. I think we're inside the intercavernous sinus. There's a channel there. Push more. We're going to put a little more of the hemostatic, and then you can see there's one more layer of dura posteriorly there. We're going to cut a little deeper. Yeah. This is the way we can control the exposure of the gland. Once again, this function is normal, so. You see the layer deeper. We will cut that as the deeper portion of the superior intercavernous sinus there. So the gland will be just underneath there. We'll just cut it in the midline there. Go a little further south. Perfect. Now you see the gland, and we're going to extend it to see the superiorly as well. Now we'll do a little subdural dissection with a ball probe, exposing the gland and the sella. And then we're going to extend the cuts of the supracellular and get into the CSF space. These maneuvers we did here really just so we are low enough and we have full control of the superior intercavernous sinus. Yeah, we need to make sure it go all the way posterior to that gland. Is beautiful. And we're getting into the subarachnoid space, it looks like, very soon there. We need to make sure that's maybe the posterior dura. That will, yeah. So what we're going to do now, we're going to do a horizontal cut above the superior intercavernous sinus. That will allow us to get to the CSF. Now the superior intercavernous sinus is controlled. We'll do this cut just above where you can see There we go. Beautiful. Then you can see the arachnoid now. Now we can connect the dots here where we perform the original cut. So this cut now will cut not only the dura here, but the upper part of the superior intercavernous sinus. And you can see with these maneuvers, you cannot really, you don't need to just rely on bipolar. It's sometimes hard here. Now we're going to cut that, basically got us some CSF decompression. Beautiful. That's what the ENTs don't want to see, but that's what we need to go. This, by definition, is going to be a high flow leak, and we can use the straight scissors now to cut that bar. And now you understand why I want to go low, because you can see how the superior intercavernous sinus is 1 millimeter that we gain by taking it, and as to be closer to the pituitary gland. So this dura we're going to bite with kerosene. That's why we elevate the arachnoid from it. And we prefer a 90-degree kerosene. So we use these kerosenes to open the dura. We most of the time keep the 90-degree kerosenes away from bone and just to use for the dura. They tend to be sharper that way. And we're just gonna bite here and create that little more space. Try not to bite the arachnoid. We just stay at the dura there, and we open now from the base of the optic nerve to the other optic nerve, from carotid to carotid, and that would allow us to visualize the structures intracranially. You're seeing more of the arachnoid, and once we open here nice and lateral, we may take a little more superior as well to see well the chiasm. You're already seeing the chiasm in the depth there. It's looking good. We of course don't want to open too much, because of course every time you open more of the issues with the reconstruction. This is a deep lesion, so we're going to just open to the superior, to that ligament that we mentioned earlier at the level of the optics. I think what we have now is more than enough, because you see well the optics there. And now we're going to go with the dissector, the Angelina dissector. I like this to really remove the rest of the diaphragm here. So if you see here, the gland is well exposed, and this is the posterior wall of the superior intercavernous sinus. I'm just going to sneak in here above the gland, under that space, and that will put us in the direction of the stalk. And basically we dissect that gland from the roof here, and we're going to use a straight Giardino to open that space. Can I have a ball probe before? I want to make sure the arachnoid superiorly here is not too attached as well. We're going to expose that stalk. And here's the curvature. Let me see the Angelina dissector one more time. And as you can see, because the lesion is deep, we don't need a whole lot of exposure. I may take just a little more on the left side here. But see, the arachnoid attaches just in front of the stalk. So we'll elevate that. You can see this is not a lot of space as we predicted. So you can see I designed this instrument so it doesn't fight with the endoscope. See that there's an internal bayonet. So that's why here Dr. Corral can get very close with his team, with Dr. Cajeras. And here we can get all the way to the base. See, this is the curvature of the pituitary gland, and there is this dura that attaches in that direction. So now I can dissect that off and use the straight Giardinero, and we go here and bite that off. That would allow us to see well the curvature above the pituitary gland, and will put us in front of that area. As we predicted, a very small space. And that's why the goals here will be important to follow. But you can see the dilation of that stalk. So here, let me see, I'm gonna need to make sure you see, this is the stalk at the tip of my instrument, superior hypophyseal branches. The main superior hypophyseal branch is parallel to the optic, laterally there. But there is a diaphragmatic branch that comes down here, you can see on the right side there. That supposedly is a branch you could coagulate if needed, but the other ones, it should be preserved. Now here you see that the cyst, as we knew, insinuated in this area, more on the left side. So here you can see this is abnormal, it's ballooning. Typically you see the stalk going straight all the way up to the floor of the behind the chiasm, to the floor of the third ventricle. So here we're gonna need to investigate a little more and see where we are gonna open up. I always look at the vessels here as very important. Typically we like to stay like midline. I knew these were more projecting on the left, so let's see if I may need to dissect this arachnoid a little more so it doesn't keep ballooning in front of us. Scissors left. I'm going to dissect a little bit of the arachnoid, and then we will need to enter between the stalk and the optic chiasm there to decompress the cyst and get some material. Here's a little opening, we did it earlier. We're just opening that arachnoid so it doesn't pulsate as much. Let's see if we can cut a little more. What size is this? Can I have a smaller now? I'm gonna change the suction to a smaller suction. One of the issues with this surgery is that the blood supply under the chiasm can be reached there. And if the tumor or cyst has not expanded much, it can be tricky to find a vascular area to enter. You see here. Here is the arachnoid. I'm trying to get the arachnoid with my suction to present here to scissors. This is gonna dissect a little bit. To give us a more direct view of the superior hypophyseals and the area that we want to enter. So you see, we want to enter right there in that cystic formation. A lot of arachnoid. I just want to make sure I don't get any of those branches. And then let's get the navigation. We can clearly see where it's kind of extending down. And with the navigation here, we can perhaps you guys can see that I'm in front of the balloon there.
Yeah.
Are they seeing that? Yeah. So you can see precisely under the chiasm, above the gland, in front of the cyst. And look at the coronal. You can see that there's the bubble is more prominent inferiorly on the coronal, on the left side, sorry. And you can see on the coronal. So that's why I'm going to pick somewhere on that left side to perform an incision there. Let's see, scissors left one more time. Make sure I got all this arachnoid really out of the way. It is a little more vascular on the left, which is always.
So which are the main vessels, Danny, you would be preserving, or most of them?
You see the stalk goes really there. There's a major vessel there. I think if we stay more somewhere there, Rick, what do you think? I was thinking somewhere here. Rick agrees. I think if I go too lateral, I may have difficulties to maneuver instruments. So I think staying closer to the midline in that area, I think will be the best way. So let's get a straight feather blade. I'm not going to bipolar or anything, just going to try to get into a vascular area challenge, because it's basically this is an incision on the stalk per se, because we need to go up. Yeah, you're pushing me. I don't know, there's something. I'm feeling that, I guess, is the resistance of the. Go back, see what I'm touching. Like, go back to the other side. I think is the spireway itself here. Okay, go back there. Let's see. Just not. I don't feel like a free movement there. We're just because since this is a precise cut, I want to make sure that I'm not pushing on anything there. Yeah, not advanced. I cannot go.
From the other nostril?
Yeah, let's take it out the spyway. I cannot.
Yeah?
Yeah, just for now. I don't know what it does. I think it's on this thing here. It's creating friction.
But I will show you because it may start the flap.
Yeah. So I removed that spyway just because it was causing friction on the knife here, and okay, good. Like always close to the stalk and or on the stalk to be a vertical cut, as the function and the blood supply tend to be vertical as well. See, like a ball probe. Have something straight, like a dissector, Angelina. Well, we can maybe go back to the spyway again. Yeah.
Can I have the...
I removed for the knife. We're going to put it back again, the retractor for the nose. For the Dura. We're just putting that spyway back there. You can probably see on the scoping picture there where Dr. Callejas doing a good job here. And I'm going to explore now that opening. See, do you have the looking strap ready? Mm-hmm. Just in case we got some fluid out of there. It looked dense on the ultrasound, so I'm curious to see how the fluid is going to look like. And also curious to see if we're going to be able to get a biopsy of this, because it's really kind of hidden. So here's what it is. It's got a better view. Very good. And here's like that little incision that I created there. It's right there.
I think there's some blood out there. Maybe you can do some touching all around the opening.
Maybe superiorly here. Let's see if yeah, a little more. It came back there. Yeah, it's a dense material. If we can expand that opening a little more. It's a very small space. We change the curvature of this section, try to optimize here that we can see each other there. It's interesting because it's more like a dense, but it looks like the typical craniopharyngioma. Like, I'm gonna get straight scissors and spread that space now. See if that will work. I was able to spread some. Here we go. Now dissect her again. You can see some of the balloon is collapsed already, but we need a better view there. So far, not able really to get material here, so let's see if we can maybe avoid irrigating next. Let's see if we can get some material now. Weird. Looks almost like an epidermoid. More than craniopharyngioma. Yeah, it's an epidermoid. Huh. You're gonna need a little more opening there to really put a suction. See if 45 up scissors. Now it makes more sense why in the ultrasound was denser, huh? Let's see if I can cut superiorly there a little more. See the dissector. You clean the fuzz, please. Challenge with the normal gland function here because we do need more space, and this is to grow very fast. Here I'm going to cut superiorly a little more. Scissors 45 up again. Little membrane still present there that I think if I cut will help with the exposure. Scissors straight again. Let's see if I can. And dissect her one more time. Is there something in the curvature here? Or? We're getting a little better of exposure. Intracystic. A little bit of dissection internally there. And I want to see if I can get a small suction in my right hand. Actually, let's try to get specimen first. Cups, straight cups. Looks to me like an epidermoid. Somehow, yeah, I think it's the second of my career I've seen one like that. And one of my those former fellows, Tom Bowman, called me the other day that he had one like this too. Curious to see DWI, how it looked like. Maybe we didn't have that sequence because otherwise we'll think about it. Like this is cups here. It's going to help to spread, get a little more exposure as well. And then here.
Would that change your plan in any way?
I don't want to do large. I think most of the stock structure is still viable. It's just too small of a space for us right now to evacuate everything. We're going to need to dilate this space progressively.
Danny, could you hear me?
Yeah.
Hello?
Oh, it's interesting why it will have grown so fast as well. We're not going to use this here. This is different than what we thought. I just need the other suction. Let's see if I can go with 2 suctions there. I'm going to try to go with suction to see if I could evacuate. I think it's too small of a space.
Could you hear us, Danny? Hello, could you hear us in OR?
Then I need to dilate that space more. You see a small little curette, like a ring 45. Stock structure, I would say, for the most part, is still good. Let's see if I can take a flake, bring a flake of this here with a. This needs to go get more exposure superficially. Wondering if here I will just do a cut on that membrane to connect, scissors straight. We need more room. I'm just gonna communicate just a little piece here of may have a little, but it's very membranous. They bleed a little bit, but now we got more room. Dissector. For the ENTs watching, like this is like a cholesteatoma. The difference that it's inside the ventricle. This is extremely rare. And interesting, we thought was a craniopharyngioma cyst. It could turn out to be a very benign epidermoid.
Hello, can you hear us, Danny?
I called with a cut there, but
yeah, I wonder if this doesn't to change any surgical strategy having found the epidermoid.
Now, can I have the other suction? See if we can evacuate this cystic lesion now decompressing. It does? I think we probably got we got stuck with the most common, I guess. Right? Let me see that 45-degree you're at. Well, we have a nice door into the lesion. Now is the patient's process here to evacuate without causing damage around it. See the ball probe first? It's a little big. So this is the stalk. I'm going to try to create a plane there and bring from below here where it insinuates down so we can mobilize. Pituitary cups. It's a good learning here with the ultrasound, because clearly was not like water, and now we know why. This is not water, not fluid. It's just dense keratin. Just dense keratin. More of the ball probe. There's a lot of that inside, so we're going to need to get some patience here. Hopefully when we get this more superficial, we have a vision of the more posterior part. And we start bringing flakes out. Here we go, specimeno. One of the issues with this type of situation is the risk of infection. So these are a vascular protein media, basically. And one of the main risks here, particularly coming endonasal, is the risk of risk of infection, forming an abscess. So we got to stay here until we get all that protein out of there. I think we'll start being able to mobilize more posterior portions of it. Suction. It's a small window, but trying to get with this suction right in front of it and then bringing it out without touching the chiasm there. Let's see. They're larger pieces. I may need to break them a little bit with the ball probe. And we can try that curette again, like in a little bit. Let's see. No. Bravo. Here, this is the inferior portion. Maybe I can roll it. Start dancing more like inside.
Yes.
Nice pieces.
Yeah.
Interesting case, special for you guys, huh?
Yeah, definitely.
That's not every day, I'll tell you that. We didn't expect we'll be doing this. I thought we'll be just draining the system, biopsying the wall and saying bye-bye, but you guys get to watch a little more here. Is this video be available like in later on the internet, or?
Yes, it will be available. We'll have a recording playing straight away afterwards.
Yes.
Yes.
Like a YouTube channel?
It is on globalrhinology.org website, and it will be on the YouTube channel. So it will definitely be available, so you can watch.
Yep.
So straight after the event, it will be there.
Nice.
So Danny, my question was, having found this different pathology, does that change your surgical strategy?
What is the question? It does, because like I said earlier, my plan was to just drain the cyst, thinking that was fluid, and biopsy the wall with the perspective that could be a papillary craniopharyngioma. It was good that we talk about all that, which is important. Being an epidermoid, we do need to make sure that we get all these keratin out, and we're gonna need to take a look to see if we can find where it was born. You know, like a little we call the plaque where it was born. Here, I'm afraid, is born inside the third ventricle. We may not be able to really remove it. We'll see. Definitely, we gotta get all this out of there. Now it's coming a little more fluid in the back. I wonder if this got infected, because I don't know. It looks a little. It grew too fast. Yeah, look at that.
Yeah.
You guys can see the cavity. Look at the perforators on the left side, outside of the stalk. Beautiful, huh? So now here the challenge will be to really get a view deep there. That's why we do this as a team, because you know, can you imagine this with a holder? You can't do that. You need a skill, Dr. Corral, Dr. Callejas, you know, to be able to do this, guide us there dynamically. I really believe in the dynamic visualization here. Some of these, as you can see, may go to the subarachnoid space. It's not unusual to see a little bit of a protein going up on the spinal fluid. Some patients can have like a septic type of meningitis with this exposure to this type of material. Imagine if all that goes into the subarachnoid space, then you get irritation, and lymphocytes and macrophages in the CSF can go up, but not necessarily neutrophils, which it differentiates from a bacterial meningitis. Here, to me, it looks like it could be the plaque, very superficial. We'll take a look at the end. And because, we have imaging from this, when this tumor started, the cystic, and it was really just at the stalk initially, and then it grew up eventually. So here I'm getting a lot of the fluid. Let's take a look. Cavity is getting better. So that's the portion that deeply there went under the hypothalamus. Thank God there's more suckable, because we can also irrigate that cavity eventually. We need to make sure we got everything out though, because high chance of this getting infected. And then if it gets infected, that there's no other way there other than just repeat this surgery. And as you can imagine, we'll be challenged with the scar. I feel that may need it to open more, but I don't want to open because of the stalk, so I'm not sure. Yeah, we may need to use a 45 endoscope to look deep there. Do you want to try, Callejas?
Can I have the 45?
Professor Callejas is putting a 45 endoscope here.
Put it down.
And it's going to go look off to the right, yeah. I don't know if this may be too much. We may need to use a 30 degree, we'll see. Yeah, I like it so far. Nice. Look at that. Look at that, Professor Callejas. See, imagine that with the holder. Tell everybody to use a holder to quit. We need good ENTs. We need good teams.
That's a brilliant view.
Wow. What happened around the world, come back a little bit, is that with the 3D endoscope, a lot of the neurosurgeons felt like, well, we'll come back a little bit, just make sure it didn't touch the optic, or I saw a little bit of blood on the optic. I think it's coming from outside here. Yeah, under there, see? I think it's from outside. Okay. Yeah, just careful there as you go deep. Let's go. One more time. Look at that. Look to the left. Are you looking to the patient's right? Come out for a second. I felt I didn't have space. Not easy to look down there. Let's try one more time.
Nice.
Yeah, let me breathe. Optic is okay, right? I just see a little red, but I think that's from outside. Just under the arachnoid a little. I think it came from the opening. It's really vacuuming now, like it's coming nicely. We may need to irrigate the cavity as well. Take a look. I'm going to curve my suction a little more to try to get that deeper there. I have put an angle in my suction. Let's see if it works. As you can see, when I use this suction, it collapsed the walls. Not easy to get there. And I have a number 5 suction here, very tiny. And still, like you see the collapse of the walls. Let's try one more time. I think what we should do, Dr. Karlstrom, get an EVD that we can put it there to irrigate, you know, like something soft. Or I think it is maybe, let's see. Yeah, we're gonna try to irrigate that cavity a little bit just to, and I'm gonna keep this suction next to it, so I'm not sure though. It's smaller. We have a smaller one here, let's see. Maybe 30 degree. Let's get it 30 degree.
Have a 30-degree scope?
I think you're almost clean there, just a little more on the back, and then we need to inspect the walls to see if there's anything else to do. But at that hypothalamic and stalk area may be a challenge. So the problem I have is straight here, so maybe I'll irrigate from far here, maybe. Just irrigating the cavity a little bit. Not much comes out actually. Let's go back with the suction. Let's see if a 30 degree helps or if it's worse. Pushing me down a little bit. Yeah. Was it 40 better or? 40 was better, huh? There's still a lot there, yeah. We're gonna go back to the 45. The other thing I can use is the, it's deep, or the, what is the name of that?
Chilele.
Chilele, yeah, maybe a chilele. Let's see here first.
That would say that
Yeah, I need more curvature at the tip of this. I may have curved too much, let's see. I need more curvature. We have the shillelagh. I'll try a thinner suction here that may be helpful. Let's see. Too much curvature. Yeah, but to get there, may come from this side then. Pushing, yeah. It's too strong, I can it goes to the wall. It's not a Fukushima.
you can release the power there, no?
Make a hole on the...
No.
block the pinch.
When you release it, it's going to be very strong inside, so maybe we should decrease the power there also, no?
No, like I think he has a good idea. He's going to block my suction until I'm inside. No, then he pinches again. Then, right? Look.
I can even release a little area.
Where am I here? It's good for this angle. I don't know, I think we have a better view before. Let's try one more time with this. You're pushing me, it's too flimsy. Yeah, no, it's not much control. Yeah, no, this is too. Let me go back to the other one. Let's try it like we're doing. This I can control better.
Look at some block by the
Now look at down there. Is there more?
Almost done.
Look at it again. It's almost done, yeah. Let's irrigate one more time. Let's irrigate, then we can do this a few more times with patients here, but it looks cleaner. This is direct irrigation into the cavity, getting some flakes out. Do a little inspection, let's see. You want to do under the water? No. Oh, you're not, right? I can come with the suction here. Take a look. That looks clean. Wow. That's pretty cool. Now we need to look at this surface behind the stalk here. I'm worried that that's the plaque, the little plate. This, the matrix, actually, the correct name.
So, zero difficult or?
Let's go to zero now, because we'll see that surface better. You guys have any question from
Yes,
the
they
other
want to
side
know
of the world?
how
there?
we need to care. What about the patency, long-term patency? It's difficult to keep it open. So how is going to, what's going to be the natural history after, from here on?
Main concern I have is this to get infected. That's why we gotta look at this. The natural history, if the matrix is not removed, it can recur. That's why I want to look. See the little whitish part just up there? If that could be the source of the basically the piece of skin that he was born with it, right? So if you remove the matrix, the natural history is cure. Like they don't. But I'll tell you, like in neurosurgery, most of patients with epidermoid, I would say, they end up with a recurrence. Like most of the time, it's hard to really manage to take it out completely. Yes. See how this is a little firmer? Yeah, but it's at the same time right on the hypothalamus. See, so it may recur, and then what you do, then you got to do this surgery. Some patients with epidermoids, they end up with this surgery like 5 times in their lives. How old is he again? So he never...
51.
Yeah, took 51 years for this to grow for him. So you want to believe that you are giving another 51 years, we'll be fine. But the main risk is, like I said, if he gets infected. I don't want to boast this stock. I do think that this is the matrix because it's firmer. You know, we do a lot of epidermoids in other parts of the body. Here is probably my second time, third. Yeah, here's it seems adherent there, not something that you have something. Yeah, the straight Angelina. Let me see. The other problem with this matrix of epidermoids, they also get a little bit of blood supply that's shared with the normal structure, so you can cause ischemia of what's nearby.
This may be really great too, to kind of peel
Let me
backwards.
try. Let me
There's a
try.
bigger one and a smaller one.
Yeah, you may be very adherent. Not sure if we'll be able to. It's a little. Maybe a blur, yeah.
Don't you pick the photo?
Yeah. Before I force, I need to make sure that that's what it is, you know, that's the problem. You have a more delicate ball probe? This shape, I'm fighting with the gland a little bit here, superficial. It does seems to be abnormal here, you guys agree? You see the straight Angelina? Maybe if I go from the front. And if there's more of the skin inside, we're not going to be able to cure him. And then they can have, usually it takes several years though to have a recurrence. Yeah, see this feels like I don't know if it's worth, you know, to be honest.
Yeah.
It's fused with the hypothalamus there, and
There doesn't seem to be nothing loose there, is it, to come out?
yeah. See the thinnest ball probe? The which one? More inspecting here to see if there's any plane. It may be broader than what we think here. So there's. But I'm really afraid we take this out and maybe it'll cause hypopituitarism. What?
What about that on the floor?
From the floor?
Yeah.
Yeah. Maybe see a straight one without the Angelina shape like a disc. Inferiorly, right? You're saying. Let's look at it again. Go closer there, Claudia. Even on this side here, this is the smallest. See here, there's a little bit of a, see the ball probe again? Let's see if I separate this plane here. I don't know if it's possible. really attach it. Yeah. Let's look a little more, but I'm wondering if we should just leave it alone, you know. Does move in block a bit. Not good. You see this flat dissector? Just a straight, I guess. I don't know if this will work. The straight dissector. Touching the optic a little bit. I think it's not really progressing, and I think it might be all the way there. Yeah. And there's a touch to the hypothalamus as well. And yeah, we did. Let's show Rick one more time there. But most likely we'll just leave this alone. The downside, like I said, is the risk of recurrence. But I'm waiting here the risk of causing damage of pituitary gland and hypothalamus by rolling this. He was born with this, so it doesn't get more attached than that. If he was in the arachnoid, like different areas, I think it would be something to force, but here it looks really adherent there. So I think for him it would be better to just leave it this open. We'll leave it this, is not in communicate with the third ventricle. As I mentioned earlier, it's just like a cavity. We got a little bit of a...
Yeah, I agree with you, Danny. Its stakes are too high there.
Blood that came in. But
carry on. Yeah.
Just do a final inspection here. We'll probably just close. Not going to hurt him. Once again, he has normal pituitary function. And I think right now we're able to be gentle enough with the stalk. Most is still connected. That's the view now internally there. I think we got all the contents. See, I think the matrix may be bigger than what we think here, and being aggressive, I don't think will help him. It's one of those things, if he recurs, then I guess we can be more aggressive in a second time, but not right now. There's a chance he goes another 51 years without any problem here, so. Yeah. You want me to aspirate here? We'll irrigate the intracranial a little more. Yeah. Is it that I caused? We'll irrigate here the little bit of a, you see the dorsum sellae, the perforators, that's all external there on the left side. And I'm going to point to the other side now, or just here, we're just going to irrigate that cavity a little bit. So if you guys want to stay with us a little more, we're going to start reconstruction soon.
So what's the reconstruction plan? Apart from the nasal septal path?
Yeah, that's 0. Let's go back to the 0. Yeah. Decided not going to go for that. You know, this is not a neoplasia. It's basically just a skin. And the downside is it can produce keratin in the future again, and that happens, we need to come back and do this. like I said, but I think it's better to do that and come back in the future for him than cause a hypothalamic injury here.
So what will be the reconstruction plan now?
What did you say?
What will be the reconstruction plan?
Irrigation. Just want to make sure there's no bleeding deeper there. And we're going to need a Durajane. 2x2 will be good. Irrigation. You guys have any question, any other question there?
No, just wanted to know what is your reconstruction plan? I know you got a nasoseptal flap, but apart from that, what else are you going to use now?
What is it?
Repeat it? Sorry, your call.
Let me get the collagen matrix. Just make sure there's a little bit of blood under the arachnoid, but I guess we'll just leave it alone like this. Yeah, came from the top. One more irrigation time. Come back on. Yeah, a little bleeding is from outside here. See a flossil? Half by half. Irrigation one more time. So what we're going to do the reconstruction, we're going to use this technique we call the soft gasket seal. There's no bleeding there. I think it looks good. The bleeding was coming from outside. Agree, Luquinhas? Can I see the scissors? We're going to make it slightly smaller.
Can I have a blade, please?
In a pituitary. Wow. We have Jeannie with us here, the best. She just passed 2 instruments at the same time. You're not going to see that in other places. one with each hand.
I haven't even heard that before, so well done, Jenny.
So the way we do is put a collagen matrix first, and it's a combination of onlay and inlay here. So we advance into the cavity,
okay,
forming like a plug. Some people call the Privedilla flower. Can I have a gel foam? And we're gonna fill up with some of gel foam. And the gel foam goes intracranial, kind of forming the plug. We gently feed that. Very important not to get the edges to go internal, like to go intracranial. And you don't want to overpack as well, so a little bit of art here, like how to kind of making sure that goes intracranial there, but not. So I move it in a little bit to make sure it goes. And here, these edges, we keep it, making sure that don't go too deep. And I look at the plane of the dura here to make sure that that is going in, like going in. They put a couple more small ones. With this technique, we did decrease the CSF leak in our patients here. It does create like a plug. Probably one more on this corner here. So I go, the gel foam does reach the intracranial space here. When the DuraGen goes in, I bring it back, because otherwise that can be an area of leakage here. Let me see a ball probe. I'm going to organize a little better because the lower part is going in. So I'm going to bring it down, the superior part of the collagen. So this goes in better. And you don't want too much of redundancy on the collagen, not to cover too much of the bone for the nasoseptal flap. They're pushing in. This is going in, but I can see the edge is still here. Oh, a little more superiorly in this corner. I can just one more here, just a sec. This is why it's more challenging meningiomas where we open more dura. Here it looks like to me satisfactory right now. Happy, Rick?
That looks great. There is a question, Danny. Do you use cartilage anytime?
We just bring it back to like a dumpling, like to expose the dura and all the areas here. Let me make sure that we have a. This is intact dura there. And one thing that we can do is like a quick Valsalva as well to make sure that it's not going to unplug. So that's the plug, like a soft gasket. Let's just do a quick Valsalva. Could you Valsalva for us at 30? Yeah, so Valsalva, no leak that we can see here. Can breathe, looks good. And now Dr. Corral will put the flap back in.
Could we have the nasal port?
Cover it up.
One or two.
Yeah, I think it's right decision.
So, as you see, we have used this flyway to keep the flap in place. We're going to remove
Could you cut my?
flyway. I have these cut lengthwise, as you can see, both clearly and
It'd be nice to take it out.
the way we have strong
Start bleeding it.
flap.
I put the
Now you can see the flap has to be kept against the wall.
I'm good. I'm good. No. I want to confirm I'm out, right? I'm muted. Yeah, he confirmed.
I think it was a brilliant case, Ashok. What do you think?
Absolutely. Amazing display of anatomy. Everything very carefully dissected, and the main thing, how careful he was in preserving each and every vasculature, all the vessels, seeing that pituitary stalk, and then adapting to the surgical finding. So initially, we went with the idea of it being a craniopharyngioma, and then we found that it was more of a epidermoid. So changing the surgical strategy, and that gasket seal was a brilliant reconstruction. It's almost see it's all nicely sealed.
Very, very nice. I'm wondering if this can be used, if it's used for a high flow leak as this one. I think for anterior fossa, small leakage would be gorgeous as well.
Yep. We saw a gasket technique on Monday that Mario used for lateral sphenoid leak.
Oh, yeah, I remember that.
Instead of a gel foam, he used the facial letta and the cartilage.
Did he use the septal cartilage as a button?
Yes, correct. Yeah, he used instead of gel foam, he used that septal cartilage, and instead of a Duragel, used the facial letta. So, but essentially, it was a gasket technique.
Beautiful.
You can see now there's a septal flap nicely covering it. That really gives a robust reconstruction.
Yes.
And the flap is supported with a spongy strong. They made sure to remove all the mucosa, so the flap seeks the bone. So it's directly laid on the bone.
So what I'm trying to do is advance the nasoseptal flap in the back in a way that it conforms to all the geometry of the sphenoid. And obviously we want to cover the defect. I'm scooting the flap to the left side. Very deep sphenoid, so you see it in my flap. If I would fall short because of the depth of the sphenoid, I would fill the clival recess with fat.
Okay.
And that way the flap comes forward a little bit more. So I use these pieces of nasopore to help me conform it and keep it in place, especially at the curves. As you see here, take another one. That keeps it in place so I can keep accommodating. And I move from pedicle to the paddle at the top. So if you start working with the paddle, then you go to the pedicle, you will move the paddle out of the place. Here I'm happy with the way this is coming. Maybe, well, I hope that that's not a little hole. Let me move it a little bit this way, just in case. Just in case. Okay, I'll take another piece. Maybe we'll take one more nasopore. I have one more piece. And you can see that I try to put the nasal port in a way that I'm not sliding the flap out of position. So it's important to bring it, do not cause friction on the flap. Putting the olfactory strips more or less in anatomical position. We will need to put that turbinate also in its anatomical position.
You want a medicine?
Yeah. Could I have a Blakesley? A strong Blakesley. Could I have the Bowie? Give me the suction Bowie first. Actually, give me that one. I'm gonna make So what I'm doing is making vertical cuts in this remaining mucosa so it drapes over the maxillary crest a little bit better. Oh, there's a piece of bone. I'll take a Blakesley. Blakesley. I'll take a coral, maybe. Oh, never mind. I'll take, yeah, coral is good. I'll drape it over the best we can. We could have drilled the maxillary crest a little bit more, but that will cover it and we will avoid crossing. It will heal much faster. Let me know when we have the nasal pore. I'll take a suction Bowie. One more nasal pore. I'll take a Blakesley again. Never mind, it's coming with me. Okay, that's better. We'll take the nasal port. Make sure that the flap doesn't move. One more piece of nasal port. And I'll take the metocell next. Actually, give me the coral first. bring this turbinate back into position. I'll take a forceps flexor. Let's take this spyway out. I'll take the metal cell. Nope, just like that. So I'm gonna put it cross cord, and I'm gonna make sure that I put it on the flap again, not avoiding moving the flap. Go ahead and inflate it. I'll take a bayonet. And as it becomes soft, I push it back into position. I'll take another one of this. And I'm gonna put a second metal cell in front of that. I'm gonna wedge it against the septum. So that way, I put the pressure when I need it, and the patient can still breathe beneath it.
Ricardo, don't you think that after a few days while you're removing this will keep the flap also outside of the place?
The other side?
Yeah, it's fine. Yeah, the other side is good. I'll take the bayonet. Yeah.
Sorry, but I don't think
that's
they're
good there.
hearing us. Yeah.
Oh.
Right at the top. Again, wedge against the remaining septum. And that's that. We'll tie this at the end. We'll put doils in the front. And that's the end of our surgery.
Wow.
Any questions,
Wonderful.
comments?
Thank you. Thank you, Rick.
Remarks?
Yeah.
Thank you, Rick.
Priya, you have a question? Priya, you can ask.
Yes, Rick. I was thinking, aren't you afraid that this fungustan, this marrow cell, would be the cause of repositioning on the flap if you're removing them after a few days? It will like stitch to the fungustan or to the flap. Yeah.
Fungustan is nasopore.
Okay.
So it doesn't adhere. Okay. That's what that layer of nasopore, it prevents the adhesion of the metal cell to the flap. It's a great question, and it's something that we always have in mind. So that will avoid the adhesion. So when we take it out, basically that metal cell turns into, the nasopore turns into a material that looks like watery mashed potatoes, and we can aspirate it in the office. But it avoids any adhesion. Excellent. Thank you so much.
Thank you. It was really great. Really enjoyed the surgery. And thank you, Rick, Danny, also Claudio, and all the theater team, the technical team, your anesthetists. So it was a fantastic, lovely feel during surgery, very minimal bleeding. So we really enjoyed the case. And thank you.
Thank you.
So this recording of the case will be available shortly.
Thank you. No, and our thanks to all the team today and the IT people that make this possible.
Thank you.
Thank you.
So we'll catch up in the studio. So any comments, Priya?
Well, as previously said, the field was perfect, minimal bleeding, perfect anatomy, and explanation was brilliant. I think that Daniel gave us, the step-by-step nuances for the surgery, the fact that it changed completely from the initial thoughts from a cranial to an epidermoid. It's also challenging, both for the surgeon and for the patients. But as he said, there are some limits that he needs to consider in mind. As he said, 50 years to growth might change. The only challenging by now would be the infectious. the infection. So we will see. We will keep updated, of course, and yeah, basically and predominantly the use of reverse flap, the use of nasoseptal flap, how to cover the defect, how to avoid miscarriage of the flap after removal of the marrow cell. Everything is perfect, and I think that the Ohio department give us a complete nuances of how the surgery should be performed.
Yeah, absolutely. And even the further finer details, how careful Rick was initially, even choosing which side you're going to use the flap. They want to be careful there are no tears in the flap is intact. So avoiding the side of a deviation, and then very meticulously dissecting it out with all the planes. We talked about preserving the olfaction. We talked about preserving the structural support of the nose. So all these little things need to be kept in mind.
Yeah.
On the right side, you need additional space for the endoscope. You need a good space. You need to be all along the roof so you get a good view. And he was very thorough on ethmoid clearance, middle turbinate excision, so that they got a right end on view with the endoscope. Also, small things like using that, I quite like that idea, that
yes.
Little round sleeve to pass the instruments, so that minimizes the trauma, less bleeding during the surgery. So all these little details really made a huge difference to the outcome.
And I think that the fantastic and these the power of this live surgery events. It's basically providing tips and tricks around the world from the best out in the field, which you can use it. Something that was impossible probably 10 years ago, and now because of these live surgery events, you can see and have an idea of how to bring your surgery on a 3.0 level. It's wonderful, as you said. I've also learned a lot from those tips and tricks that can literally change the way that you approach the visual field, how to have space. That's what's brilliant.
Yeah, right. And again, the major complications we talk about, the main things we were at: optic nerve, the carotid artery. Right. So during the surgery, if you have noticed that when he was removing very close to the carotid, it was could be very tempting sometimes just to get a bigger bite and remove the bone. But he completely avoided that temptation. Again, carefully checked everything, how things are moving. Is there any risk to the carotid? Went back again, thinned that bone further down, and then little bites at a time. So all this care you have to exercise during surgery. Then talking about the optic nerve, at one point he felt that is there bleeding around the optic nerve. So again, another pause, he went back and checked everything, whether am I causing any undue pressure on the optic nerve, any movement of the optic nerve, any severance of blood supply to the optic nerve. So again, taking a pause, stopping, and then ascertaining that everything is fine, and then going further. The same thing about the hypothalamus. When you're checking on the hypothalamus, that's the judgment call, isn't it? One could get carried away, and you want to dissect everything out, remove everything out. But then keeping that in mind, the stakes are quite high. If it causes any hypothalamic injury, it's not high. It's quite dangerous. So balancing that out, what is the risk of recurrence? It's a long-term risk. So which way you go is a trade-off. And he is very rightly stopped at that point and then came back.
Amazing.
Yeah. So overall, a great surgery. And so watching this surgery, what practice will change for you? Yeah.
I think that as I said, my practice will change in understanding that visual field is important, ergonomics is important, meticulously analyzing and understanding the anatomy preoperatively is important. The use of instruments is important. How do you use those instruments important? We've seen the struggle that Danny has when it comes inside to the retrochiasmatic and to avoid any lesion to the superior hypophyseal arteries, and the use of those instruments. How much importance do you have on these suctions and all these instruments curved are in your practice? So whenever you approach into such cases, you need to be prepared. Your staff, theaters should be prepared. Your instruments should be tailored, and not trying to do such surgery without those instruments, without the right equipment. To understand now, because of this, I think that the educational program will bring the surgeon to another level in the next 10 years. And that's the beauty of having live surgery events. Yesterday, on the 25th, we have two different cases. Manuel Bernard Perkinsell having, this extensive surgery where you have those visual fields that are completely full of blood. How do you recognize and how do you recorrect yourself, and how do you recognize anatomical details by using the right instruments? Then Paolo Castelnuovo and the team reconstructing details and defects by using different material, different instruments. So I think that by now what I will expect from myself is that whenever I'm having troubles and struggles, talk to the colleagues that are more, advanced from me. Talk to whoever is in carriage of the right instruments that I will need. For example, angle instruments. The important to have angle instruments that we can reach to places where we cannot reach normally. Those are the important stuff that we will have. And I think that also, the importance on how to cover defects. And in this particular case, the soft gasket seal was something that was useful and the right, the right choice.
Yeah, absolutely. All the great points you have picked up. And technology, absolutely right. Unless you have all this technology, it's probably you can't really perform these high-end surgeries with the good outcomes for patients. So, for example, they had this intra-op ultrasound. So you had predicted that this is not something normal that we're dealing with it. Of course, navigation is almost becoming a norm now if you're doing these type of surgeries. So navigation, and then they're not reliant on the navigation, but every now and then they were checking that where we are and confirming the location. Again, all this having this hemostatic material, the flow seals, the duragens, and sponges drawn. Important when they did the soft gasket. I really love that technique, soft gasket seal. Did you see that even with the Valsalva, with such a knee, it was tight.
Exactly.
Absolutely spot on. And while using that, he was so careful that you're not doing in excess. We're not covering more bone than necessary because you need the exposed bone for the flap to pick up. So ultimately, you're relying on the nasoseptal flap to provide that robust, vascularized reconstruction. So all these minor details and attention to them is so critical. The nasal packing, they were not really packing it very tightly, were they? No, they're just enough to hold everything in place. So they had a great belief and the trust in the layers of reconstruction, the nasoseptal flap and all that. Otherwise, you could end up very tightly packing the nose. So there's hardly any packing. There was still a breathing passage for the nose, despite that extensive surgery. That was really great. I mean, he's going to wake up with nose not so blocked. So that was really great. And after all that long hours, Prof. Kara was still very mindful that he has to cover the nasal floor. No, he didn't leave that nasal floor open. No? All these little mucosal flaps. So more area covered, the mucosa is going to be less crusting, post-operative healing will be better, and the mucosalization will occur quickly. So that was great again. So right from start to finish, there was a attention to details. And that was a great lesson. Even at their stage in career, they were so particular about it.
Completely agree. So, how's the other room? How is Richard Harvey going?
Yes, I think Professor Richard Harvey, he will be soon joining us, and we really look forward to it. This is a probably different spectrum of sinus surgery today we're going to witness. So can't really wait. He will be joining in around 45 minutes. The theaters are getting ready, and then he will carry on into the night. It's a night for us, but the morning is a Thursday morning in Sydney, Australia.
Yes.
And then once they finish, we'll be moving eastwards, joining Dr. Satish Jain from Jaipur in India. And he's lined up great cases for us. Okay, there'll be angiofibroma, then there'll be lots of the GR-ESS, the complex phases, revision phases, then the whole range of it. So it will be fantastic. So we'll have a little bit of break now. Then in around 45 minutes time, so that's 6 p.m. In the UK, 7 p.m. for you, Priya, and it will be 7 a.m. for Prof. Harvey in Sydney. So they will be starting the surgery. So in the meantime, just to remind our viewers that all the recording of the event is now available, even the recording for our Monday cases from Spain and from Italy. It is available. And if you want to watch the case that was performed today, in case you have missed it because of time zones, so many people would have missed it because the working time in some places, and that in some places it's not so social hour. So they can catch up with the recording. It will be on the website available, and soon it will be added to the YouTube channel. Okay, so we play some informational videos from Medtronic while we wait for Professor Harvey to come back and join us. So thank you.
Thank you, everyone. I'll see you in 45 minutes.
See you.
Bye.
See you. See you. Bye.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems, so a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly, or certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
from the aviation perspective, just before I left the front line, we started to get pre-flight planning systems that would allow us to overlay our route onto a topographical map of terrain around us. So what that meant as a strike pilot, I could get a visual perspective during planning of what I'd expect to see in the flight. And these were very critical phases of flight where you needed to be pinpoint accurate to get weapons in the right place. And having this memory of what things should look like in the heat of the moment was a massive help, and meant that you were much more likely to have mission success as a result. So getting back to, in the air, as I said, it was all about managing workload before. And if I have a navigation system, then I can delegate a lot of that aviate, navigate, communicate task to the navigation system. So much like having a GPS in a car, in aircraft these days, you've got a similar display, which is your aircraft in the middle and the route ahead of you. And depending if it's an airliner or a fighter, obviously the displays will be tailored accordingly. But it really reduces my workload. It means I can spend more time looking out of the window, not just at the pretty pictures, but looking for other aircraft that might be trying to do me harm, or looking for weather that might affect my ability to carry out the mission. One thing we need to guard against is complacency. So the people who assumed that the navigation system was correct all the time, very occasionally were caught out. For example, when I was at low level in my Harrier, I updated my navigation system on the wrong lake and put myself 3 miles out. So that was a bit of a newbie mistake to make, but those are very salient lessons that stay with you throughout your flying career. These days, of course, there's a lot more resilience in the navigation solution, and this is where the GPS input comes in to bring things back on track. So particularly in things like airline flying, there's still a bit of complacency to guard against, because everything runs on rails for 99% of the time. It's just a 1% of the time when it doesn't that you need to be very focused and sharp all of a sudden in amongst this potential 8-hour flight where you suffer naturally from low arousal. I guess that's very different in surgery. So navigation very much helps your mental reserve. Need to guard against complacency, but by and large, we wouldn't be without it these days, with very few exceptions.
I agree. It does reduce your mental workload and also your physiological stress quite a bit. And again, there's a lot of research behind that. When you've got navigation, you know you're going to do a better operation. You know you can constantly recheck if you come across something that's you're not quite sure, you're a bit confused, you just want to double check as you're moving through. And you know if you've got navigation, that workload is reduced. And it has been shown, particularly in skull-based surgery, it will reduce the time of the surgery and you'll do a more complete operation. So knowing that also reduces your mental workload because you're going to get a better outcome with less complications, particularly in skull base. The other thing I was listening to with Jim is the complacency, and I agree. The thing about surgeries, we haven't had it for as long as you have in aviation. And so we haven't quite become as dependent upon it yet, but I can certainly see that becoming a problem. For us, because it can be an additional expense, we often have to justify the use of navigation. And so by doing that, you've already thought through why you need it and how you're going to use it and whether you can do without it or not. But complacency, you can certainly see becoming a problem. But even though you can put a probe in and see where you are, you still need to be able to interpret what that is. And so for us, even though you're putting a probe in and seeing where you need to know what that is and what you need to avoid and what's next and where certain structures are. So just using navigation on its own is certainly not enough. You need that anatomic knowledge. The other thing about navigation is you can actually use it then to confer with someone if you are not 100% sure. You can use it as like a conference tool. And the good thing about it these days is we've also got sort of virtual options to share things with somebody else. And so in a way, you can always return back to your anatomy as your anatomic knowledge as a backup, but you can also use navigation to confer with somebody else. It's always been thought that the navigation could prove a distraction. And potentially when you're first starting, like anything, that could be the case. But as you become more familiar with it and more comfortable with it, it's actually the complete opposite. It's it's an adjunct but not a distraction. And it also just improves the workflow. You routinely check it. It's often attached to the tool that you're using, so you're not having to change tools, and you're just checking a screen regularly as you go through. And as you find that, as you become more and more comfortable with that, it actually makes the whole procedure more efficient, I find. Definitely navigation is needed in certain circumstances. As I was saying before, if it's a revision case or if it's a tumour that has destroyed key anatomic landmarks, having navigation is vital. It's a great teaching tool, but again, you have to justify its use. But I think also if you've got some unusual anatomy, or when you're going to be changing that anatomy and it puts other structures at risk, in ENT, the main, or in skull base and rhinology, the main structures we're worried about is the brain and the eye and the carotid artery. And if those structures are unusual, have been changed, or where the pathology puts them at risk, that's when you would certainly use it. When you don't need to use it, if you've got a case where the anatomy is relatively routine, you're not doing a big operation, and there's nothing really abnormal or concerning with the surgery, then you could say it's potentially not justified. When I worked in the US, they used it for every single case, and for numerous reasons, one of which was teaching, one of which was medico-legal. In Australia, it's not such the case. In Australia, we tend to need to justify when we use it and why. So that's when I use navigation.
I'd echo Raywin's comments there. There are times when navigation isn't required. So, for example, if I'm a private pilot just exercising my aeroplane on a Sunday morning and I'm just flying around the local area, then I probably won't use it. But that said, even these days, or particularly these days, I can put my mobile phone on the aircraft instrument panel, and for $100 a year, I can get a navigation app on there. And for another maybe $300, I can get a little black box I can put in my airplane that can pick up other aircraft that are squawking, that have a transponder code around me. So that is a massive enhancement to flight safety, even if I'm just doing my Sunday pilot lap of the block. And it means I'm much less likely to hit other aircraft or scare myself by getting closer to them. So even for the low tariff trips, I think navigation is still very useful. And for the high tariff trips, that's when the workload leveling really becomes a game changer. And it means I can spend more time as an airline pilot monitoring the systems or thinking about the destination, as a fighter pilot monitoring the tactical system and making sure that no one's getting the upper hand on me. And in terms of how it affects my assessment of a situation, it just gives me that extra capacity to be able to carry out those more challenging tasks.
My name is Dr. Abib Agbatoba. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant synechiae formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and synechiae formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draft 2B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening. After completion of the draft 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour propel stent in both the left and right neofrontal ostium. However, given our increased access to in-office use for the Propel device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulence, and less bleeding. At the patient's second postoperative visit, the patient was known to have minimal edema, no synechiae formation, and minimal crusting. The contour propel stents were found to be in excellent position. This was a very interesting case in light of the patient missing multiple postoperative visits secondary to both the COVID pandemic and the patient himself contracting COVID. I truly believe this was an unforeseen advantage. The 2-in-1 mechanism allowing for mechanical spacing and localized drug delivery, I believe may have prevented restenosis, synechiae formation, and the need for potential additional surgeries. At the patient's third postoperative visit, 1 month removed from the surgical date, the patient was noted to have very minimal tissue edema, no crusting, and again, no synechiae formation. There was no signs of any stenosis, and again, the contour propel stents were found to be in excellent position with minimal adjacent crusting. At the patient's fourth postoperative visit, now 3 months removed from the surgical date, the neofrontal ostium bilaterally were found to be widely patent. No evidence of mucosal edema, synechiae formation, or evidence of restenosis. The contour propel stents themselves have been degraded and or debrided. Chronic sinusitis is a chronic inflammatory disorder. Steroids are immensely helpful. So the idea of us placing an implant that will release steroids over a period of 4 to 6 weeks, but minimizing the side effects of systemic steroids, I think is a significant advantage for patients. At this 3-month follow-up, the patient reported resolution of his sinus headaches, postnasal drainage, as well as his nasal congestion. For patients with chronic sinusitis, with true chronic rhinosinusitis, there are so many different variables in place. We all know it's a very heterogeneous disorder, and so trying to predict how one patient may heal versus another can be very, very difficult. Even in patients with nasal polyps, there's a wide spectrum. So I really like the idea of an implant, a steroid-releasing implant, as insurance in many cases. Anytime I'm doing any type of formal frontal sinus dissection, when feasible, I like placing the contour propel stent because you never know what patient is going to be prone to synechiae formation or stenosis. Some patients may have moderate disease, but may have a propensity for scar formation, whereas others may have very severe disease, but may do very well without placement. And so trying to decide who to place it in can be very, very tough. One of the advantages of now being able to place it postoperatively is that if you don't feel comfortable or if you feel like you would like to avoid placing it in the operating room, you now have the advantage of placing it in the office setting. If you see someone who has increased edema in the frontal recess or increased edema in the ethmoid cavity, or maybe their middle meatus is becoming a little bit more narrowing, their middle turbinate is somewhat lateralizing, now you have the option of placing a propel stent in the office so that we can combat the edema, we can combat the inflammation, and then we can allow for mechanical spacing of the delivery device or of the propel stent. Tissue and wound healing can be very unpredictable in this patient population. We all know that the sinus cavity that's most likely to stenose is that frontal recess and that frontal neo-ostium. So for me personally, any type of formal dissection involving the frontal sinus, I am most likely going to place a contour propel stent. Whether that's in the OR or in the in-office setting will be patient dependent.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and sample-striate. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour delivery system has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly for, certainly they used to, less so these days, they used to fly from one radio beacon to another. And
Start. You are on a mute, sir. Just unmute yourself. Ashok sir, you are on a mute.
Hello, it's a great pleasure to welcome colleagues from around the world who are joining us today from different continents and from different time zones. So it's a scientific committee of a global rhinology network, and I have with my colleague host here. On my right is Louise Melia from Bath, UK. Louise is a rhinologist and a skull-base surgeon. Then welcome Puya. Puya is joining us on a hosting panel for the first time. Puya Degani. He is from Perugia in Italy. He also is very passionate about surgical training in rhinology and runs his own foundation. And it's a great privilege to have Professor Claire Hopkins. So Claire is on my left, and she hardly needs any introduction. So Claire is from King's College London and Guy's Hospital. So she's a clinician, academic, and heavily involved in research. She was our past president of British Rhinological Society, and she was also a past president of Rhinology section of Royal Society of Medicine, and is currently General Secretary of the European Rhinology Society. So welcome, Claire. And maybe see you a long association with GRN. So essentially, GRN is a not-for-profit organization. Our mission is to foster education free for colleagues in rhinology and skull-base surgery. So we like-minded surgeons have come together and formed this organization. And it's quite a milestone event today because we're completing our 10 years since our first broadcast in 2014. So it was started as a collaboration with the Lion Foundation, Mr. John Oates, Dr. Robbie Wonsa from Basic Clinic, and Professor Wilco Grolman from Utrecht, now is at Basic Clinic. They were initial supporters, so they provided guidance to establish the organization. Then around COVID time, it was formally established as a not-for-profit organization. Since then, we have run various live surgical events. I'll just speak of the numbers with the most conservative estimates. Around 50,000 delegates have been benefited from our various events. Around 100 rhinology faculty have contributed to these events from around the world. So that gives a scale of it. Then today's event really spans 3 days. And there is another milestone that so far we ran a single channel and visited various operating theaters at the important stages of surgery. But there was a popular demand from everybody that they wanted to be involved in the whole surgery. So today we are going to broadcast 2 channels. So we have an option of joining one center or the other. So thank you very much for our surgeons who have very kindly agreed to operate and demonstrate surgical procedures today. So we have 2 centers. It's a Lake Como Hospital, which is attached to the University of Insabria in Italy. So Professor Paolo Castelnuovo, it doesn't need an introduction. He's a stalwart in the field. He will be guiding Associate Professor Mario Turizinoni and Professor Paolo Battaglia. So these are our 3 surgeons from Italy. And we have Professor Manuel Bernal-Speckelsen and Irene Perez Delgado. They're operating from Valencia in Spain. So they have chosen a very interesting cases, and there'll be lots of discussions with our hosts and interaction. So if you have any questions, please do ask them. And we'll try and pass on your questions to the faculty. There is a chat box for sending your questions, and we'll keep an eye on it. So event of this magnitude is just not possible without our supporters. And Medtronic and Carl Stolz are very heavily invested into academics, and they have always been a supporter of GRN. And we will be playing some of their informational material throughout this broadcast. So without further ado, we will now be moving on to Valencia, Spain, where Professor Manuel Bernal-Speckelsen will discuss the case, and they will start the broadcast. So initially, we will be in the same studio, but then afterwards, we'll have option of going to Spain or Italy. So thank you, everybody. Thanks, Claire. Thanks, Priya. And thanks, Luis. Is there anything else you want to add at this stage? Claire?
No, just it's a great pleasure to be here with you all this morning.
Thank you. So we'll play some informational video from Medtronic, and then we'll move over to Spain.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble, and that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G-meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly, or certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity, so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is, so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes. Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And this is the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and sample-striate. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Hello, welcome back to the studio again. So we will now move on to Valencia in Spain. Thank you. Hello, good morning, Manuel. So we have got Italy on the screen. So maybe you can check with them. Hello, Mario.
Ashok, I think you're showing very nicely that this is definitely live. This is like every morning in my theatre trying to get started.
Absolutely, yeah. They're just getting ready. I think you can see the patient is being put to sleep. Anesthetist and the theatre team is all warming up. Okay. So can we connect to Spain, please, Dinesh? If they're ready. So you can see one screen, we got Italy, and the other screen, we got Spain getting ready.
Sir, Spain is not connected.
Okay, so I think they're sorting out their connections or getting ready. So in the meantime, we can join the Italy Center, please.
¿Podemos poner el volumen de la retransmisión? Sí.
Hello, looks like we're connected now. Hello, good morning, Manuel.
Ya está, al principio ahora le tienen que oír.
Morning, Ashok.
Hi,
Morning,
welcome,
Lisa.
and thank you very much. Thank you to you, to Irene, and your theatre team, your technical team, for making all those great efforts to join us today. So can you hear us, Manuel? You can see the CT.
I can hear you not that well, but I can hear you, yes.
Excellent, good.
To arrange my glasses with the micro. So good morning, everybody.
Good morning.
I'd like to introduce the first patient, if that is fine with you.
This is the car.
Yes, please. Yeah.
Hello, morning. So the first case is a 21-year-old young lady, and she has a polyposis grade 99, I would say. The left Macquarie score on both sides is around 11 out of 12, and she has hyposmia, rhinorrhea, and you will see that all sinuses are pretty much occupied with the polyps and mucus. Interestingly enough, she had asthma when she was a child, not currently. So we'll see what happens when she gets around 40 something, whether the asthma is coming back or not. Otherwise, no intolerance to aspirin derivatives so far, and well, no other important medical conditions to name. The nose is being blocked since 4 or 5 years now, and she cannot breathe. So the lady is intubated. I will now try to show you the CT scan, and we will need someone to scroll. Irene? Thank you. So you will see now the CT and the coronal section, and you see that both nasal fossae are fully occupied. Can we scroll? I cannot do it. Ahora está compartido. Can you see the CT scan, Ashok?
Yes, we can see a coronal section there, but yeah, I guess you're just starting the.
Okay, let's scroll. Aquí yo no veo la actualizado.
Yeah.
Oye, Ashok, ahí tiene otra imagen que la que tenemos aquí. We only have one slice here, and while Irene has been scrolling through the CT, here on the laptop, I cannot see any change. You probably seeing the now?
Yes,
Can
we
you
can
see that?
Yes, we
Great.
can
Now,
see.
now we can see. Great. So this you see that both maxillary sinuses are full, that the ethmoidal sinuses are also fully occupied. You see that the lady has a Keros type 3, while the Keros is not that important from my point of view. It's more the lateral lamella, the inclination, that is more important to me. You see the maxillary sinus again, full, posterior ethmoid full, and then the sphenoid sinus almost occupied, a little bit more aeration, and you see that this is going to be a nice case. There's no septal deviation. There is no septal deviation. Currently, can we go anteriorly in order to see the notch of both ethmoidal arteries? Okay, scroll backwards, scroll backwards, scroll backwards. I'm going to show you that. This is an important landmark to me. Go, scroll backwards, backwards, backwards. Yes. No, this is anteriorly, backwards. Yes, to the sphenoid. Now go, 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 go. Stop. Almost a little bit more anteriorly. We'll start to see here the notch of the both anterior ethmoidal arteries. Go a little bit anteriorly, a little bit more, a little bit more. No, I had them initially. The problem is the synchronization of the CT scan here and our laptop. So there we see the notch of the anterior ethmoidal arteries there and there. Usually I use this when I have a meningocele or meningoencephalocele of the cribriform plate, because usually the meningoencephaloceles or seals are anteriorly to the anterior ethmoidal artery. So this is a very good landmark. In any case, it's there. You see that both anterior ethmoidal cells are fully occupied. The maxillary sinuses are occupied. So it's going to be a pleasure to aerate and clean all these sinuses currently. So said this, will introduce a couple of cottonoids before I start, in order to have a little bit of vasoconstriction. Usually, vasoconstriction should take for about 10 to 15 minutes. That's the time the adrenaline starts to work, and I think this is an important step before starting. Also, during surgery, when one side is starting to bleed, you can fill the nose with cottonoids soaked in topical adrenaline and anesthesia, and then go to the other side. So give me a minute to introduce the cottonoid, and I'll be back with you.
Okay, thank you, Manuel. I think we will be joining Italy now to discuss their case. So this is interesting case of severe nasal polyposis. So it will be available on our second channel. So we'll go back to the studio now, and those who want to follow this case, click on the second channel. So we'll be going out to the breakout rooms. Thank you. So back to Italy, please, in the studio.
Italy, kindly on your camera and audio.
Can you get back to studio, please, Dinesh?
Yeah, we are in the studio, sir.
Okay. So let's go back to now Italy. We'll keep the studio as it is now. Okay. Thank you. Hello, can you connect to Mario? So Mario Turi Zanoni, he is the operating surgeon along with Professor Paolo Battaglia, and Prof. Paolo Castanova is also there to help with the surgery.
Yeah. Hello to everybody. Ashok, can you hear us? Yeah?
Yes, we can hear you well. Good morning, Mario. And thank you to you and your colleagues and your team, theater team, and your technical team for making this possible.
Good morning. Okay. It's really a pleasure for us to be here with you. Greetings from our institution, our university hospital, which is the Lecom Hospital in the north part of Italy. Greetings also from our university, the University of Insubria, and from our scientific group, which is called Rhino Edu Scientific Group, that you can follow us, also our activities on the social media. So, we are almost ready to start surgery. I'm gonna show you the clinical case of today. The clinical case of today is a 69-year-old female patient. She started complaining left clear rhinorrhea over last year, and he has no previous head trauma, no history of trauma, and also she complained loss of smell, complete loss of smell since her COVID infection in 2021. The patient is a female patient. She has obesity and so very high BMI, 36.2 BMI, and also in menopause, and she has benign intracranial hypertension. So the patient underwent also some ophthalmological evaluation for intracranial hypertension, especially the fundus oculi and the fluoroangiography, and allergy to fluorescein has been during such ophthalmological evaluation. The patient also underwent CT scan and MR scan in order to go in deep in the diagnosis of a left clear rhinorrhea. And as you can see on the CT scan, we understand that there is a presence of multiple sites of skull-base defects. First of all, we can examine and we can explore the olfactory groove, and there is a expansion of a dimension of olfactory groove, especially on the right side. You can see that there is a sort of meningocele in the right side olfactory groove, but also you can see that also in the left side olfactory groove there is no bone, and so there is a bilateral defect at the level of the olfactory groove. But as you know very well, usually in patients with intracranial hypertension, we have sometimes multiple sites of skull-base defects. That's why it's so important to rule out the presence of other additional defects of skull-base.
Hello, Mario. I think we lost your sound a bit, so I think your headphone must have moved away.
You can hear me now?
Yes, we can hear you now. Yes, please. Yeah.
Okay. So, apart from the olfactory groove,
Hello, Mario. We lost your voice again. Can you? Hello, Mario. Hello, Mario. We can't hear you. So if you can complete the case and then case description, and then we can move with the others, sir. No, we can't. I think.
Can you hear me now?
Yes, we can. Yeah, there is a lot of ambient noise from theater, so if you can reduce that noise, yes, we can hear you better. Thank you. Yeah.
We go very fast with the case, okay?
Yeah. Okay. Yeah. So we gathered about this defect. So, and you were mentioning about another defect. So.
Exactly. Not only one defect, but multiple defects. And so this is so common in patients with intracranial hypertension. And so olfactory group, both sides, and left side lateral recess of a sphenoid in the region of a standard canal. So also with MR scan, we can see these features. And so this is the T2 Waketon sequences, and this is the flyer sequences. And you can see that there is the signal of liquor that disappear on the flyer. And this is the fusion between flyer and T2. And you can see that here stay the signal of a liquor. And so this is a CSF leak. Similar things happens also on the level of a less sphenoid. T2 Waketon sequences, and in the fusion, the white signal, hyperintense signal on the less sphenoid stay, which means that this is CSF. Okay, once again, this signal at the level of the left sphenoid, also in the fusion. This is the endoscopic appearance, but there is no specific sign in the endoscopic appearance. Also, you can see that there is some drop of CSF, but no meningocele are evident. So, we are in presence of a bilateral olfactory cleft defect associated with a left lateral sphenoid recess CSF leak. And so we can discuss about possibility for treatment. The patient already start diuretic therapy with acetazolamide since 1 month in order to decrease the intracranial hypertension. But now we can discuss how to perform the skull-base reconstruction. Ashok, can you hear us? Yes?
Yes, very well. We can hear you very well. That's a very good quality audio. Thank you.
With Professor Castelnuovo, now we can discuss about possibility for surgical strategy in this case.
Hi, Ashok.
Hello, morning, Prof. Thank you. So welcome to GRN. So it's quite an interesting case and quite a challenging case as well, I would say.
Yes,
so,
it is. It's a challenging case.
So what is the surgical strategy, Prof?
Yes, because with the benign hypertension, intracranial hypertension, the future of this patient is very tricky. So for the skull base, for the bilateral olfactory defect, we think that the approach is with a right Haddad flap with a resection of the superior portion of the septum. So with the right Haddad flap, we can cover both the olfactory groove. And this is enough to resurface the anterior skull base. On the other side, for the left sphenoid defect, we can approach with a multi-layer reconstruction. That means that the first layer will be fascia lata, connective tissue. Then we perform a gasket with a fragment of septal cartilage and resurface as a third layer with a free graft of a middle turbinate mucoperiosteum. So we have a different approach for the olfactory groove and overlay reconstruction with a single flap and with the vascularized flap, and we will use Haddad. For the sphenoid sinus, to perform multi-layer reconstruction with the fascia lata, cartilage, will be a very interesting surgery for everybody.
Good morning, Paolo. Can I ask a couple of questions?
Yes, please.
How do you think you'll approach that lateral extension of the sphenoid? Will you go transsphenoidally or transpterygoid plate, or will you be able to access the lateral wing easily?
Yes, of course, for the sphenoid we do perform a transethmoid pterygoid approach. That it means that we make a trimming of a middle turbinate and do perform posterior ethmoidectomy and a sphenoidotomy. And we drill a little bit the pterygoid roof to approach, have more room to approach the lateral recess of sphenoid. Yes.
And for the olfactory cleft defect, is the fact that she has already lost her sense of smell one of the reasons for putting the Haddad flap up there, because you feel that she won't regain sense of smell anyway?
Well, I think that with such a bilateral defect, the olfaction will come in any case. Of course, there is she lost olfaction after COVID, but I think that the progression of the disease makes a loss of olfaction in any case. And Haddad is very convenient flap to reconstruct the anterior skull base, and we do perform a bilateral reconstruction because you can make a resection of the superior portion of the septum in such a way we will use the right Haddad, but we will able to resurface both the side of the olfactory.
And finally, what will you do post-operatively to manage her benign intracranial hypertension? She'll stay on the acetazolamide, or?
Yes, acetazolamide we already start since 1 month and we go ahead. The challenge of this case is the long-term follow-up, because we have to take into account to consider a magnetic resonance after 4 months and then every 6 months for 2 years at least. And we have to consider the different sign of benign intracranial hypertension, like the tortuosity, ophthalmic nerve, and the enlargement of the liquoral space around the nerve, the flattering of the posterior part of the globe, ophthalmic globe, and then the enlargement of the ventricle, and the stenosis of the transverse sinus. So all these magnetic resonance signs we have to follow the follow-up. Another decision that we have to take in the future if the patient needs a peritoneal very critical cases in the past. We have a very good result with the ventricular peritoneal shunt.
Interesting case. Look forward to seeing what you do.
Hello, have you heard my answer?
Thank you, Paolo.
Thank you to you. So, I think for Paolo Battaglia, we'll start the surgery.
Vado là.
La cassa gliela possiamo portare. Con questa camera che vi devo far vedere. La persona copia. Ok? No.
Whenever you want, ready.
Hi, everybody.
If I'm ready, I can start. If you're ready. Perfect.
Hello, Mario. Can you hear me? Hi, Paolo. Hi. Morning.
Hi.
Can you show us your theater setup?
Yeah, I'll show you the patient. We put our cotonoids to get more space. As you saw, the problem is also here we have not good spaces because we have a septal spar on the right side. And I will remove the cotonoid so I'll show you better. So we are on the right side here. And you can see here the spar, the posterior spar, reducing the space, and also here in the upper space, in the upper part, we have a septal deviation. So we have to think what we have to do. Professor Castelnuovo and Dr. Turri told you yet that we will use the right ADAD flap in order to reconstruct both the olfactory area. So now I will start with the anterior incision of the ADAD. I'll try to get it as large as I can, but first of all, anterior incision, try to correct the posterior spar and the upper part of the deviation. So then we will move towards the ethmoidectomy. We will remove the middle terminate bilaterally, ethmoidectomy, and we will expose the olfactory cleft. So we will start from the olfactory cleft now. So can I have infiltration?
Paolo, there is a question for you.
Yeah.
How do you choose which side you're going to raise the flap from? I mean, this is a reasonably central defect. So, what are the factors in deciding?
Yeah. I'll start with the right side because also if I will have, and it's probably I will have a small perforation, we will have the contralateral side still intact. Instead, if I will do the left side, then it's probably that I will have the perforation on the right side, so it will be I will have a hole, permanent hole. So we'll start from the side where there is perforation, where there is the septal spar, in order to avoid to have a persistent hole after surgery. Did you understand?
Yes, the septal spar and the deviation is one of the key factors in deciding, correct?
If I will have here a small perforation, doesn't matter. It will not influence my reconstruction. Of course, a small perforation. I will have on the left side the pterygoid that I have to drill. So it's better to get on the right side where there will not the CSF leaf at the meningocele. Okay? Because we will have to drill the pterygoid on the left side for a transethmoidal pterygoidal approach in order to get to the Stenberg canal defect.
Thank you.
Because
I think that's an important factor because in drilling, there's a chance of damaging the vessel that supplies the flap.
Yeah. And also, they told you this is a very rare case of Stenberg. You see, the herniation is above V2, not between V2 and the median nerve. So this is the incidence is 1 every 1 million almost. So it's very rare. It's very rare. It's a clear and Stenberg canal defect.
Yeah, that's interesting because usually we find the lateral sphenoid defects are lateral to the V2. So they're not really the true Stenberg canal defects. There is a debate about it. Yeah, but this looks like a very classic medial to V2, the classic Sternberg canal defect.
Yeah.
Would you agree, Claire?
Yeah, absolutely. It is very unusual. They're always described as Sternberg, but as you say, they're lateral. But this one is one of those rare ones, so it's nice to see.
So I take my time to make infiltration.
I think, and that's the key. It's very beautifully demonstrated by Paolo that getting a good vasoconstriction, spending your time in infiltration with cotonides, a good hydrodissection, it all adds to flap integrity.
Yeah. It's better to take some minutes more, but to have then a dissection much more bloodless as we can. Okay. Then a cotonoid again, and then we'll start.
Thank you.
Okay.
Is that just adrenaline on the cotonoids?
Yeah, there is a xylometazoline, 10 ml, and there is a adrenaline 1.200,000, 10 ml. So we mix xylometazoline with adrenaline. Okay. So we start with the anterior incision of the Haddad flap. So we can use the beaver or a scalpel as you want, scalpel or beaver, okay? So here we start in the upper part, okay? I stay very anterior because then I will have to reconstruct the skull base bilaterally, so here, very anterior, the incision, then a little bit down. We use beaver, as you know, you can use, there are different kind of instrument you can use. One is the diode laser, the other one is the monopolar. We prefer to use or the diode laser or
I think the picture is a bit frozen from Italy. So that's Professor Paolo Castronovo, along with Mario Tirizanoni and Paolo Battaglia. So the main surgeon we saw was Prof. Paolo Battaglia. So they're in the Lake Como Hospital, which is a part of the University of Insabria. So it's a very interesting case, isn't it, Claire? So intracranial hypertension with multiple defects, and we're going to see surgical strategies with the flap and multi-layer reconstruction.
Yeah, they've certainly not chosen an easy case for themselves. I think both areas, the olfactory cleft, it's often quite difficult to get an underlay. It'll be interesting to see how they approach that, but certainly coming from both sides will give them a much wider access to get that underlay in and get a more watertight repair. And then access to the lateral wing of the sphenoid is always the challenge. So in both cases, technically quite difficult, and also then the peri and post-operative management of these patients is really difficult. We have a really good setup for our benign intracranial hypertension patients with our neuro-ophthalmology team, and they undergo quite aggressive weight management before surgery, previously with bariatric surgery, but now with things like Ozempic to try and bring the pressures down to help with the repair. We use acetazolamide just like the team in Italy, and sometimes shunting, but we try to avoid that as much as possible. Patients are quite resistant to shunting, but there's an increased risk of failure, so you really need your repair to be sound.
Yeah, absolutely. I mean, it's not about the surgery and the immediate reconstruction. It's about addressing the root cause of it. That's the key. Otherwise, over a period of times, they can recur, or the defects or the leaks occur at another site. So even after the reconstruction, we need to keep working with these patients and working on the weight, controlling the BMI, and monitoring them further. That's key. I mean, do you use, I can understand in this case that the patient had a allergy to fluorescein, so they could not use the fluorescein. What is your practice? Do you use fluorescein routinely?
So that makes it really challenging. For these cases, I think fluorescein is helpful. We will use paragen-free fluorescein. We'll do a patch test preoperatively to exclude allergies, and then use it intrathecally. We get our anaesthetist to help with a lumbar puncture, and then we dilute it down, put it back in. And I think that helps identify these patients with potentially multiple sites. And there are 2 obvious sites on the scan, but you can really have a look to make sure there's no other areas. But also it helps you when you're doing your repair to give you the reassurance that you have got that watertight seal, because you can see that you've adequately closed it on the table. So this is likely a case that I would use the fluorescein, not so much to identify where the leak is, because we can see that from the imaging, but to help me understand that my repair has been sufficient. Would you do the same?
Yeah, absolutely. I agree with you, because fluorescein, when possible, then it helps you to identify the other leaks. Although in this case, the 2 leaks are quite obvious. And with the new now IGS and all that, it really helps. Would you use the navigation in this case?
I would probably set it up, but I'm not sure that it's a case that really needs the navigation. Again, you can see the leaks quite clearly.
Correct. Yeah. So you just probably to confirm what we already know.
Yeah.
Exactly. So we're back on the screen. Hello, Paolo. We're back to you. We had a bit of a break in transmission in between, but I can see that you've gone forward and you raised the flap on the cartilage.
Yeah, raise the flap and going posteriorly, trying to remove this posterior spar. I expect a small perforation because of the spar you see. It's very large. But I'm not scared about this. We can use the flap anyway, no problem.
Yeah. I mean, it's quite a robust flap, isn't it? 1 or 2 perforations here or there. It doesn't make much difference to the grand picture.
Difference. Yeah.
Wonderful. And I quite liked your idea of using the beaver knife, because it's important to know that if you use a monopolar cautery here, it's kind of easy to go through the septal cartilage and cause a perforation at the very anteriorly. So using the beaver knife gives probably a better control, finding your flap and finding your planes and elevate the flap correctly without damaging the cartilage. And anteriorly, the cartilage is also a structural support for the nodes. So to be mindful about the structural supports to the nose. So
anteriorly, we'll try not to remove too much cartilage here, in order because here I will have to reduce this superior deviation, but I will not too anterior in order not to have a sedage of the nose afterward. Then here I'm trying to be very careful not to make a perforation of the left side, because I don't want to have a persistent perforation also in the posterior part. If I try not to have it. So maxillary sinus probe, seeker da macellare. Lava, wash, please. Okay. So I frequently use this small probe that we use for the maxillary sinus under the crest, so that I can, you see, better detach the inferior part of the septum. Right? Wash.
That's a really nice trick because that's one of the toughest
Yeah.
areas to get around without tearing.
I mean, the ligaments are very strong in that area, isn't it? So going
Yeah,
through
the anterior
them,
part.
you need a combination of a sharp and blunt dissection. And you can see Paolo is very beautifully showing that. He's been very careful with using the olive-ended tip, which is protecting the flap in a way. If something sharp in this area can easily cause another perforation to the flap.
Sì, probe ancora. Yeah, it takes some time, but I want to reduce the enlarging of the defect as much as I can. So here are some fibers. Okay, can detach easily in such a way. Till the floor.
So that's a classic Cotton's inferior tunnel, isn't it, Claire? It is going on the nasal floor. So, Paolo, how wide are you going to take this flap?
I'm sorry. I will try to go. Come on. Then I will go towards the nasal fossa floor, so I can enlarge much more because I need.
Yep, I can hear you loud and clear. I can't hear the Professor Paolo. Oh, okay. So, okay, well, we're here. Nobody else is. We don't expect anyone else here for another 40 minutes, but everything appears to be working. There's our endocam, and there's us. Okay, thank you. That's Dinesh, is it? Thanks, Dinesh. I'll mute.
What? No. Dammi ancora la ball, il probe. I need help. Okay, yeah. Thank you. So before removing the crest, I want to be sure to have detached well the contralateral side. Okay. Now it's better. Whoosh. Okay. Here in the upper part. Okay. Now I'm quite sure not to have a contralateral perforation, so I can remove the spar. Let me see in the upper part on the right side. Okay. Okay. I almost exposed the crest. Inferior part, it's okay. Let me check better the inferior part. No, here it's still attached a little bit. Vailina? Cotton? as I can of the flap. Okay. Vai Lina. Then chisel, scalpello e martello.
So Claire, as you can see on the screen, it gets quite challenging, isn't it, with these septal spurs and deviation often. So it's very tactfully he's dealing with that.
Yeah, it's time spending, but it's fundamental to move on towards the site of the defect. Go. Go. Okay. Then vial grossa. Non so big. Okay. So this is the spar. Try to see if there is some more deviation. Take here. Modulami un attimo questo. So here again, let's say if there is something remaining here. Yeah, it's a big spar. Apri. Apri.
I think what the team are already showing really clearly is how well they work together with this sort of four-handed approach, and how you can swap between 2, 3 and 4 hands almost without us noticing. It's really impressive. It's nice to see the handwork screen.
Yes, absolutely.
Okay. Yeah, it's very helpful to have a surgical partner that helps you such a well way. So let me see if we manage the posterior crest. Okay. The hole, it's not small, but will not be a problem. Okay. Okay, now we get some space. I will have to remove again some more bone here in the upper part, and of course here in the anterior portion. So. Yeah.
For those delegates who have joined a little late today, so we are operating from Lake Como Hospital in the University of Insabria in Italy. So Prof. Paolo Battaglia, who is the primary surgeon at the moment, is assisted by Mario Turozonani and guided by Prof. Paolo Costanovo. So it is a very interesting case with benign intracranial hypertension, multiple skull-base defects, 2 large defects, one on the right side with olfactory cleft, one lateral sphenoid on the left side. And the plan is to raise the right-sided nasoseptal flap, that is the Haddad flap. And that's what we're dealing with the flap at the moment on the right-hand side. And then use a multi-layer reconstruction on the left side.
Okay. Okay, now I want to correct also the anterior portion, so cotton. So here is the perpendicular part of ethmoid, the passage between bone and cartilage I have the incision here. Okay. Anterior incision.
I think this is another important area, isn't it, Paolo? How high do you go at keeping the keystone area in mind?
What? Sorry.
No, this is a very important area for the structural support of the nodes.
How high I go?
The keystone.
Okay.
Yes. Yeah.
Yeah. Sorry. As much as I can here, detaching. Now I'm detaching the cartilago from the bone posteriorly. When if I will remove only the bone, not the cartilage, because I don't want that the sedge of the nose, so I can detach till the upper part. No problem. The only thing is not to remove this 1 centimeter in the upper part of the cartilage in order to avoid the sedging. But if I have bone, now here I'm touching bone, I'm safe, and I will not have this kind of problem. Okay.
Thank you.
Here cartilage, so I will preserve. Here I will go till the upper part, you see here, and this is bone. Now, in order to correct, you see this bulging here in the upper part, I will remove the bone easily and safely. In such a way, if I remove the bone, I will not have any problems post-operatively. Do you agree?
Yes, sir. Thank you. I think so.
You're underneath the nasal bones in the bony plate, aren't you? So they're all protected.
Yeah. So here, again, try not to make any hole on the other side. Again, probe, maxillary probe. I love this instrument, sicata macellare. Okay, because I can go behind the board, the corner, with the ball, the touching safely. Okay. Now I can remove this part. Or Castelnuovo also likes to drill this part, but anyway, or drill or remove vial. Oh, prala. So, this is bone. See, it's quite thin. And then let's check. Also in the inferior part here we have still remaining cotton. You know, it will have been a dream to not to have a hole, but in such a case I expected. Okay, now check if we have space in the upper part or if we need to remove more bone. Okay, vai, aspira. You see, we gain some space. Now we can check better the olfactory clefts, but I think get some more spaces in the upper part because I need to have a very clear field to better then work on the olfactory. Cotton. It's something you cannot do after. Wash, please. So here we use mainly cleaning system if we approach the cell and paracella. In such a way, you see, my assistant is with the syringe, you see. He helps me. And if you are trained, it's quite better than washing a cleaning system. I prefer.
I agree.
So,
the cleaning systems I always find a little frustrating.
Yeah, because it's not easy also to wash because you have to pull to orientate the water towards the tip of the endoscope. And at the beginning, it will not be very clear, and we have to train and train. But then, when you are trained, you have a perfect, cheap cleaning system. Okay. Now we are almost satisfied about our closure. Something still posteriorly, there is some probably, no, there was blood. Here some, let's check posteriorly. Anyway, the pedicle of the flap is preserved. Here, with this small hole, this small, not so small, but this hole, then we'll put near the two parts of the flap, and will not reduce the guarantee of closure of our flap. So a little bit here again, superiorly. We are almost okay. Okay, a little bit more again. Ok. Aspiratore scollatore. This small part. Yeah. Ancora vial.
Iris, Stin. Hi, John. Manish.
Marina.
Yeah. Thank you. And one a little bit more here.
Okay.
Vial. Ancora. Okay. Okay. Remove the blood. Then position again. Okay. Now we can check the olfactory cleft. You see here the superior turbinate over there. Olfactory cleft. As Mario told you before, we could not use fluorescein. We try to use in every case, but the patient had a problem during the ophthalmologic evaluation with the fluorescein, with some reaction. So we have to. We did not feel comfortable to put the fluorescein inside the brain. So let's check better the anatomy. Here is the middle turbinate, the head. Then we have the bulla over here, an accessory ostium here on the right side, and the free border of the uncinate process. Now we remove the middle turbinate as first things, and we will preserve it in the physiologic water, because we can use this middle turbinate for the mucoperiosteum as a third layer for the Stenberg canal, and the bone for a sort of gasket seal later on, or the cartilago, of course. But first things, we need to get space and better and expose the olfactory cleft. So, uno tagliente, piccolina, one cutting straight instrumentation. The small one, please, the piccolina. Any questions? So, my landmark, in order to remove the middle turbinate, please push a little bit here. Thank you. Great. Now is you see, axilla of the middle turbinate, then till the axilla of the superior turbinate. You see here? Can you see clearly?
Yes.
Perfect. So I will go from the axilla of the middle till the axilla of the superior, because I need to have this landmark, because if I go straight, instead of going down, you know that the skull base and a maca shape, I will go inside the brain, inside the olfactory cleft, sorry. So you have to take in mind this important rule. So starting from the axilla, then you will have to correct your cutting inferiorly. You don't have to go straight. Thank you. Okay. Then down, down, down. Okay, a little bit of blood. It's life. Okay. Let me see the axilla there. Okay. Okay. Then, when I arrive to the axilla of the superior, I can get a small curette, and I can pull it down without breaking the common lamella. So now, you see, I can, wash please, I can pull it down. Okay. Then I want to see better. We can, if you can reduce the blood pressure, it's okay. I ask the anesthesiologist so that will be more.
Are they using TIVA or what sort of anaesthetic to give you the best?
Yeah, sure, of course, yeah. Yeah, we'll always use TIVA. Okay. So bulla in here will go down. Uno tagliente.
And you use tranexamic acid or anything else to help with bleeding?
Yeah, I can reduce bleeding. First, I ask, then I can have untreatable position if it's too much. So I can put the head up a little bit of the patient. So we can try. Can you put the head a little bit up? And then, if not, I use cottonoid. Stop, please, okay? The head came up. Let's see if something changed. Yeah, quite better. I can see a little bit more. Yeah, the second surgeon helps me a lot. So, cutting instrument, uno tagliente piccola. Sorry, sometimes there is some Italian for the instruments. Wash. And warm water we can use, so I ask them to give me warm water in order to reduce the bleeding, okay? Let me show me the posterior part. Okay. Now it's done. I can remove the middle turbinate. So vial, small one, please. Okay, thank you. So you see, this is the middle turbinate. I can see it, okay. So later on, we can use this detaching from the bone from one side and the other side, leaving the joining here in the inferior part of the middle turbinate for the Stenberg canal defect. So please put this piece inside, you see, physiologic water, store it and don't send in the hashtag. Okay, now we get space. So the other thing we do, we always perform ethmoidectomy. Of course, we have to expose the olfactory cleft. So we need to know where the ethmoidal roof is. Okay, so we perform now anteroposterior ethmoidectomy. So backbiting, we need the landmarks. We need the maxillary sinus landmark, the sphenoidal landmark, and the frontal one to expose the skull base. So here, floor of the bulla, we insert our backbiting. This is not the natural ostium, it's an accessory one. You see the uncinate process moving, so we can remove the passage between the vertical and the horizontal part of the uncinate process, and then ball probe for its own way of usage. So now this is what was built for. So we can put it down and better identify. You see, Marco, can you show? Okay. you see, now this is the natural ostium with the biscotto with the straight cutting instrument. We remove this posterior part and then basket.
We lost your picture, Paolo, a bit.
Oh, okay. Without spar, it's better. Okay, you use this instrument to remove the inferior part of the uncinate process. It's called basket. We call basket. Okay. Now I'm quite happy. Now we will remove the uncinate process. So G-curette, we will go in the hiatus semilunaris. Then we will prepare the number 2 cutting small instrument. So between the space between the bulla and the uncinate process, we will frontalize the uncinate process in such a way. Okay, I like to leave it in such a way before cutting, straight adjacent to the papyracea. So adjacent to the papyracea, I will go up and up and up till the axilla, and then I will move a little bit medially. Small vial.
I think this is a classic swing door technique, which is the safest way to remove uncinate. Would you agree, Claire?
Yeah, nothing exceptional.
Yeah.
I do this in all my cases now. I've really moved away from doing an anti-grade uncinectomy, and this is safe and reliable in every patient. Absolutely,
because the superior part of the vertical segment of the uncinate is closest to the orbit, and there is a risk of a perforation into it. So you're safe as long as you're using this retrograde swing door technique.
Yep. G-curette. Now we will open the bulla. Okay. So inferomedial angle of the bulla. We will pull, you see the bulla in front of us, such a way. Number 2, big cutting instrument. There is a little bit of bleeding. Then for the frontal, perhaps we can put a cottonoid and try to wash with hot water. But now I go in order to spare some time. Vial, remove the anterior wall of the bulla. Small vial. Okay. Now we will remove the floor of the bulla. It comes from the anterior ethmoid, so taken in such a way, biscotto, straight. Okay, removing the floor of the bulla. Okay. Okay, now, of course, in normal phase, with the preserving the middle turbinate, we will go towards the frontal sinus, but here it's better probably to get the sphenoid and then come anterior towards the frontal. We remove the head, the middle turbinate. So, debrider. Non funziona? Oh, no. Ok, G-curette. Okay, does it work now? Let's open the posterior ethmoid.
So what Paolo shows really elegantly is a really safe approach to your endoscopic sinus surgery, a retrograde uncinectomy, finding fixed bony landmarks, finding the space with the curette in the bulla, and then moving into posterior ethmoids, using the sphenoid as a landmark. And so this will apply to any sinus surgery, let alone CSF. It's really nice.
Yeah. So we put the curette behind the uncinate process, and between the uncinate process, the free border, and the bullite moidalis. Now we could go following here the Agarnasi towards the frontal sinus, but you know, it's better to to get the sphenoid, so will be easiest apriqua. To get the sphenoid here, we will follow the superior turbinate, so uno tagliente grossa o biscotto. Follow the superior turbinate over here. Okay. Push. Okay. Hot water because it's bleeding enough.
This often is a challenge in these cases, isn't it? With this benign intracranial hypertension with high BMI, anesthetically, they are not easy to control.
Yeah, it's not easy.
That classic hypotension, low pulse rate is always not possible. And it's quite a challenge, not for the surgeons, for the anesthetists as well, maintaining it. And,
both.
As Paolo is very diligently demonstrating, taking his own time in trying everything possible to get the hemostasis, finding the landmarks.
Cutting instruments. Yeah, and trying with uno tagliente. When it bleeds so much, I need the landmark as much as I can. So now I want to see the sphenoid. So it's one more landmark. You see, this is the posterior ethmoid. In order to get the sphenoid, I have to follow the superior turbinate. This is my main landmark nowadays. So wash. Clean, please. Okay. Now I follow the superior turbinate, and I'm almost inside the sphenoid, I think, here. Okay. This is sphenoid, you see?
Yes, yeah. Nice one.
So try to put some cotonoid inside them because it's quite bleeding. Remove this, then I will get more space. Then I will put some cotonoid to have a bleedless field. Okay. So, biscotto. We call this biscuit because it has the shape of a biscuit in the morning. So, we get some space now. We know that there is the sphenoid, so we can get more space.
And even in a difficult field, those fixed bony landmarks, the sphenoid gives you depth. You've got the roof of the maxillary sinus as another guide. So you show how you're navigating by all of the fixed landmarks rather than relying on instrumentation. It's great.
Funghetto, mushroom. Yeah, it's very important here to get the posterior landmark because before going on, because you know the risk of damage of big vascular structure. So then, of course, I know there is my sphenoid, and anteriorly can do almost what I want, but it's a very important landmark, mainly when there are scars and there is a bleeding, such in this case. So I want to enlarge my sphenoid. Okay, perfect. You see, now I'm not going down in enlarging the sphenoid because, as you know, I need to preserve my Haddad flap. So if I need to remove the basis sphenoid, I can have a rescue flap now and detach the mucosa from the bone. Okay. So I enlarge, but now I want to focus in the upper part on the ethmoid, the roof, and the olfactory cleft. So I will enlarge only lateral and superior. Okay. Here, perhaps I have some more space. Okay. Now I know where my sphenoid is, and I will come anteriorly, removing the ethmoidal cells, curette. Whoosh. So I know here I have my sphenoid, here are the cells of the posterior ethmoid, so I can, you know, remove without risk. Okay.
I really like the back to front approach to the ethmoids. I think it's so much safer.
Absolutely. For the junior delegates, it's important to notice that how carefully is dealing with these cells with the back to front approach, using the J-curate, breaking the cell particles and all the cell partitions, and then removing them carefully. The curate also gives a good tactile feel. You can feel the sudden transition between those thin cells to the very strong skull base.
Okay.
And again, it's a through cutting forceps. So you're not really pulling too much down. Rather, you're cutting sharp and then removing the cell partitions. So
Quant'è la pressione? Okay, I have here the papyracia, so another landmark. Now I can remove this small cell over here, and then I will reduce again here my biscotto. Bush. Can reduce a little bit my turbinate, middle turbinate here, whoosh. Let me see. Here somewhere, I think I will try the meningo cell that can be perhaps here, you see? Some meningeal tissue. Over here. Here. Bipolar, so I can coagulate. You see the pressure? Pulsating. Okay, perhaps the meningocele went inside the pneumatization of the superior turbinate here. Tieni, bipolar, bipolare. Go. Go.
For our delegates, if you have any questions for the surgeons, please put it in the chat box so we can ask the questions to the surgeons. Thank you.
Yeah.
So feel free to put your questions in the chat box.
Vai. Vediamo se si... Vai qua. Vediamo se si riduce un po'. Vai. 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 Try to reduce the bleeding. Okay. Va. Okay, now I want to better expose the frontal to get all the landmarks, and then we will move on towards the olfactory cleft and the ethmoidal roof. So we are fighting with this blood.
It's challenging.
It's so. Sometimes it happens. Okay.
Yeah.
Push.
That's the beauty of life surgery, isn't it? You get to see the real life scenarios. And these are the challenges you'll be facing in your own practice.
So I will move to 45 degrees to get the frontal, but before I want to put a cotonoid, trying to reduce. Cotonino? Tieni.
I think I'm going to rename all my instruments in Italian. It sounds so much better. I like biscotto and cotonino.
Cotonoid. Again, other cotonoids.
Sounds much better than the patties, isn't it, Claire?
It does.
Ok. 45 gradi. I move to 45 degrees, looking for the frontal. Okay. I'll also check if there are some area that bleeds. Okay, olfactory cleft.
It is a minor point. In a way, we take this for granted, but we have surgeons logging in from different continents and different areas, different countries. So I think it is important that whatever the cotinoids, the patties you are using, if you notice they're all radio labeled, then they have a string attached to it, and they should be all counted to as a part of the self-surgical practice, because not really leaving anything there. So is that a routine following the surgery, that once the surgery is done, then you count and confirm that all the patties and the packs have been removed?
This should be the agar nazi here, olfactory cleft, agar nazi. So I'll try to remove this to get in the frontal. Currette da frontale. So, middle turbinate, axilla. Here there was the uncinate, middle turbinate. I've still this small cell. You see how it bleeds. It's like a hell. So now wash. Wash. So okay, I'm in the frontal, but believe me, because I know almost where it is, because we cannot see too much. So, funghetto da frontale. I hope that then we will expose everything, reduce also the loss of liquor and removing almost the mucosa. It will reduce this kind of bleeding. We don't have to lose our patient. Pazienza in inglese più che patient. To keep calm, okay. Okay, towards the frontal seems to be the supraorbital recess. So frontal sinus over there. Ok, funghetto da frontale. Dove?
So using a 45-degree angled scope now, right?
Oh, see, this small, let's see this small artery. Let's see if I coagulate it, if I can reduce. You see, okay. Bipolar. Okay. Hopefully, perhaps we can reduce this kind of bleeding. We use this, bipolar forceps that opens at the tip here. You see, it's closed. Let's see. Let's try to reduce in such a way. So stay in such a way. Usually these arteries does not bleed so much at this level, but here, wash. Vai. Wash. Go. Go. Vai. 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 Go. Go. Vai. Okay. Vai. Vai. Go. Go. Okay. Now try to expose the ethmoidal roof and then we will be back. There is some bleeding that comes from this middle turbinate, but I want before checking for the frontal. Then 0 degree, we will move there in a larger space. So I will be back later on that posterior area. So funghetto, wash. Ok, funghetto. Let's open. A little bit more anterior.
That's the Hosman punch, which is such a useful instrument in the frontal sinus.
Yeah, I'm in the side of frontal. With the punch, I try to enlarge, but that's frontal, of course, here. Okay. Posterior wall of the frontal. There. Oh, here. Oh. Can be the anterior ethmoidal that goes inside, and then some branches towards the dura, where there is the meningocele. You see here?
Yes.
Okay.
Yeah.
Bipolar.
Interesting. Yeah.
Yeah. Bipolar.
As you can see, there's a frontal ostium, and usually the anterior ethmoid lies one cell behind the ostium. So this probably is one of the branches coming from that.
Yeah. Usually it does
very
not
close
bleed
to that.
to so much, but
Yeah.
okay.
But Paolo, that's excellent. Really very well done in finding that frontal with so much of a bleeding around.
Right? Right? Oh. Let me see if I can get there. Okay, go. Go. Okay. Go. 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 Okay. Go. Go. Okay, go. Okay. Okay. Not free of blood, but it's better. Okay. Yeah. Castelnuovo, Professor Castelnuovo told me to show you how we manage to deal with this kind of bleeding. The problem is that you need to have this instrument. Give me, please. You see, you have to have an instrument that opens, the tip at the end. You cannot use the classical bipolar, the Bionet one. You see, if you have such a way bipolar, this is a Bionet, but it reproduces the shape of a normal bipolar. You see, when you go inside, tira via sti cosi. When you go inside, you have to go at the roof of the ethmoid. Take here, please, Marco. You see, if I want to go there with the bipolar, it becomes quite difficult because you see, it crosses the tips. You don't have space if you have a normal bipolar. So it's better to use these instruments with the tip, because you can put the 45-degree scope under, then with the tip of the instrument you can get at the level of the skull base. So.
Yeah, it's a very handy bipolar. Call it a daisy bipolar. So.
Yeah, it's very
handy.
So, wash. Now I will move towards 0 degree. You know, here we have frontal over here, frontal sinus, perfect. Then sphenoid here posteriorly, sphenoid posteriorly there. Then here I will have to remove this kind of mucosa medially, and all the olfactory cleft that we have to better expose and reduce the middle turbinate. Now the bleeding seems to be reduced, so we can focus our attention, you see here, on the olfactory cleft. This is, I think, that is reduced in the bone. It's quite eroded here in the posterior part, you see. This mucosa, it's not normal. This is the meningo cell that went inside the superior turbinate. Here, the anterior part seems to be better, but I need here to remove all the insertion of the middle turbinate. So now it seems to be better. 0 gradi.
So Paolo, there is a question from the audience. It may not be
Yes.
so relevant in this case because patient has already lost a sense of smell. But when you're developing this Haddad flap, how do you plan it to protect the olfaction?
Yeah, usually when we perform that flap, in order to reduce the loss of olfaction, we preserve the upper part of the Haddad. Oh, quite good. Now it's better. So what does it mean? Cotton. That we follow here, you see anterior incision, that in the upper part, our landmark is the axilla of the middle turbinate, and then we have the incision of the upper part of the Haddad, here joining the axilla of the middle turbinate towards the axilla of the superior. So we spare this upper part of the mucosa, that is where there is the olfactory tissue. And then we will go back here. So from the axilla of the superior, that is here, we join with the axilla of the middle turbinate here, and we preserve this upper portion of the mucosa. Then we can go up till we want in order to get our flap. So the secret is to not to damage this part of the mucosa. But in this case, we need to cover the olfactory cleft with the flap and to have the fenestration exactly here where there is the olfactory cleft. So later on, we will start from here. We will have our incision posteriorly and can start doing it till the axilla of the superior and down. This is our superior limit of the Haddad. Then we will drill the septum over here in order to put the Haddad flap bilaterally to cover both the olfactory cleft. It's clear? So usually this is the way to reduce the damage of the olfactory tissue. But in this case, of course, we have to sacrifice the upper part of the olfactory cleft. So the patient is anosmic yet, so we will not preserve that mucosa. Is it clear?
Right. Yeah, yes, absolutely. Thank you. That's great. And we can almost see the transition zone between the change in color. You can see the yellow olfactory cleft mucosa. It has a bit of a yellowish tinge compared to the rest of the normal nasal mucosa.
Yeah,
and Paolo, you haven't completed raising your flap yet. Rather than do it at the beginning and put the flap down into the postnasal space or the maxillary sinus, you leave it in place to give you better access?
I prefer to leave it in place as much as I can, because if I put it in the rhinopharynx, you see here the bleeding, it will be a mess. So I cannot, or in the maxillary sinus, I will have to detach from the pedicle, put inside, make maxillectomy, and it will be in front of me anyway. In such a way, it will get some space. So if I can, if I don't need, I leave it in place till I can, and then I will use for reconstruction. So Now I will leave it again. I will reduce the bleeding. In fact, it's due to the fact that this patient bleeding a lot. Then, so I will expose now the olfactory cleft. I will reduce the meningocele that it's almost here. You see this one till the upper part. I will remove all the upper part of the middle turbinate and expose and remove all the cell and mucosa of the ethmoid. And I will leave the flap in place. Then I will move contralaterally. I will do the same. And then at the end, I will put the flap to cover the defect. If I can take it in place, I will take it in place. Of course, if I need instead to work on the rhinopharynx, to have a forehand technique, you can store, but remember that it will take some space anyway.
Thank you. That's excellent tip, Paolo. I think it's probably, may I take this opportunity to talk about Paolo. So Paolo is Professor Paolo Battaglia. He has been personally mentored by Prof. Paolo Castanova. He worked in a hospital in Varese for 20 years with Prof. Castanova. So then he has recently been transferred to Lake Como Hospital, where he's a chairman of the department. Paolo is also now the advisory board member for European Rhinological Society.
Yeah. Bipolare. If you want, Professor Castelnuovo can have the microphone. If you want to ask something, we have the lucky to have him with us. So.
Yeah, thank you, Prof. I mean, Prof. Paolo Castanova is always there as an operating surgeon right from our first GRN live surgical webcast. He has almost performed very interesting cases, various skull base reconstructions, and large tumor excisions.
Biscotto. Biscotto. Let's go around the meningocele here. This is bone. Okay. Let's see the meningocele. Cottle. See here, this is the herniating part. You see, it went inside the middle turbinate, the superior turbinate. That's clean. I detach here. Ok. Aspira. Aspira qua sopra. Yeah, this is herniating brain, meningeal tissue. You see here? I'm going very slowly in order to better show you the herniation. Okay. Right, good, thank you. You see, Marco, it's helping me. Pushing, okay, good. Okay. Now remove the bone. Biscotto. Wash.
I think, Claire, it is interesting to note that Paolo didn't really rush to find the defect. He did all the other steps first, sorted all the sinuses, found his landmarks, controlled the bleeding, and then, without having to look for it, you almost land into the defect, isn't it? It seems so easy once the other things have been
Yeah,
sorted
and
out.
if you try and
Very
find
good.
it right from the outset, it's actually very difficult. You're working in a very narrow cleft, but as you can see, it's sort of herniating into the root of the superior middle turbinate. So by clearing and making all the space and resecting it takes you to the meningocele. You've got beautiful landmarks around with the skull base, the lamina, the sphenoid.
Yeah, absolutely.
Biscotto, you see, there is not only one herniation, but two seams in the same side. You see here anteriorly, see, one?
Yes, yeah.
And then here posteriorly. So that's why it's better to expose all the olfactory cleft when you try to repair this kind of CSF, because sometimes you cannot see perfectly in them are, and then you can find multiple defects on the same sides, and erosion, a reduction of the strength of all the olfactory cleft, such in this case. So try to reduce and remove all the major turbinate, exposing all the olfactory cleft. So here, try to take some space. Okay. Now it's much better. You see the bleed decreased, and now we can work much better. So, apri. Dai, uno di là, uno di qua, così se è chiuso possiamo usare l'altro per piacere. Tanto adesso il debrider, grazie mille. Ok, bipolar.
So this is precisely the scenario that Claire you're alluding to when we discussed this case beforehand, that the fluorescein that you use to find out if there are any other defects, because sometimes those become apparent with the fluorescein or more expression. So the Paolo didn't have that benefit of fluorescein, but he still mitigated that by having a wide exposure and keeping a mind open to the other possibilities. Yeah, if you keep that in mind, you notice those defects.
Yeah, in such a way we don't have fluorescein, so it's also much more important to see where are all, because are less clear than with the fluorescein. Totally agree. Takes time. Okay, it's not a problem. I will take my time, having a coagulation, exposing all the olfactory cleft. Here, I don't know if the meningocele involved also here medially, so now I want to remove this small, and I want to check if there is brain inside or.
But the tissue in a meningoencephalocele is usually non-functioning. Would you agree?
Yeah, totally agree. So we can coagulate without problem.
Yeah.
We cannot do if there is for example, if you make a craniectomy, an extended craniectomy, and if you have as a complication a brain herniation, I suggest you not to cut or coagulate because it's still functional. But here, if it grows slowly, it will be not functional tissue. Okay. So now I can coagulate here. Go. 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 Okay. I move to 45 degrees. Try to remove all the mucosa and to better understand the site of the defect. So. This is not the case of a small meningocele. Okay, debrider, where it's very isolated in one small piece. Here there is all the cleft that it's almost reduced in depth. So now we can use for the first time the shaver. Okay, getting more space here. I tried before not to use too much the shaver. When it bleeds too much, usually it increases. Okay. Now I can remove all the mucosa. Okay. Now I can go selectively on the mucosa. I know where is the meningocele. I know where are the cells, and removing selectively the mucosa. Perfect. Much better. Frontal sinus now, I can see it better. I know almost here there will be, you see, anterior ethmoidal artery over here. And here pulsating all the olfactory cleft. Still, I want to better understand here if it's only bone or if there is a meningocele here in the middle part. So, metti a fuoco.
And you're removing the mucosa so that your Haddad flap adheres better?
Yeah. Okay, now here, let me see. Still some bone. Curette. Wash. Okay. Good. Curette. You see, there is still some bone here. Okay. Okay. There was bone. Now anterior ethmoidal artery. Remove the bone and can coagulate this soft tissue. Okay, bipolar again now. So I put my bipolar inside, I go in, I see it from below. Now I can coagulate here, okay? Here we have the anterior ethmoidal artery. Go. Okay. Pulisci la punta, clear the tip, please.
Well, that looks like the area of the anterior ethmoid arteries. It's at the frontal ostium, and there's just a cell behind it.
Posterior ethmoidal artery. Probably a middle one here. Posterior, middle, and anterior.
Anterior, yeah.
Anterior ethmoidal artery. Probably a middle one here, and the posterior one here.
I think that middle ethmoid's much more common than the textbook suggests.
Yeah, 30%. So anterior.
Yeah, did Mario say 30%?
Right, yeah.
Yeah, I would agree with that, yeah.
One or two, this one, I don't know, a small, no, a small nerve, probably. So middle and posterior, great, okay. Sorry.
Paolo, there are messages for you from Dr. Muhammad from Amman and Dr. Lestari from Jakarta, Indonesia, and many others. They are saying thank you for such a wonderful demonstration so far. They're really enjoying the surgery.
Oh, thank you. Me too now.
Okay. Yes, as the bleeding is under good control.
Okay, go. Wash, please. Clear. Wash me the tube. Okay. Now, okay. Isolating all the olfactory cleft, right? Good. Here. So here, it's almost good. Go. Okay. Go. Go.
Ashok, can you hear me?
Yes, I can. Yeah.
Yeah. There is some
Mario?
comment from the side of Professor Castelnuovo.
Yes, sure. Yeah.
When you use bipolar close to the skull and on the dura, the power has to be no more than 30 watt. I think it's important. We have to reduce the power of the bipolar.
Okay. Thank you, Prof. That's
And there is mandatory the accuracy that Professor Battaglia has now to expose the defect of the skull base, because the exposure of the defect and the clearance of all the tissue around is mandatory for reconstruction.
Thank you, Paolo.
Okay. Now you see that I almost exposed, without entering inside the dura, the olfactory cleft, reducing the meningocele. So, see here. Here, it's olfactory cleft. The lamina lateralis, yes. Now it's almost exposed. I will reduce this tissue a little bit in the anterior part, but what I want to do now is to remove the mucosa of these cells, because then I will have to put the haddad on the ethmoidal roof, and I don't want to put the haddad on the mucosa. So, una 4 piccola vailina. So I try to remove the mucosa of all the ethmoidal roof. So I have to prepare my field. So the key points in skull base reconstruction are exposing the defect. So you see that we took a lot of time to perform, to get our landmarks against the bleeding and to expose the defect. Now, the second key point is undermining the borders, the margins. So you saw that I want to see perfectly where the defect is. So now I can check. This is the border. This is the border. Here the bone, it's not so hard, but here it's the border. I can expose a little bit better also here. Then, third thing, I have to prepare the bed for receiving the flap or the free graft. So always in my mind I have these 4 different things to do. So get the landmarks, expose the defect, undermining the margins, then remove the mucosa, and to prepare the bed for the flap. Okay? You have to say 1, 2, 3, done, okay, ready to put the flap on. So now I have to prepare the bed meticulously. All these 3 steps will influence the success of your reconstruction. You can expose very well, but if you leave the mucosa, you reduce the success of your reconstruction. So remove the mucosa here at the level of the anterior ethmoid and papyracea. Here you see anterior ethmoidal artery. It's quite risky, but I have to remove the mucosa and to remove this spar. So it takes time, no problem. Yes, drill cut, please. So okay. Okay, mucosa. away on the ethmoidal roof. This is what Professor Castelnuovo taught us in all his lectures. Do you want to say something more, Prof, please, from your experience? Weil?
The integration of the different tissue is very important. So to prepare the bed, accepting the Haddad, it's important because the mucoperiosteum of the Haddad has to lay on the bone of the skull base. So periosteum on the bone means a very good adhesion.
Thank you, Prof.
Okay. Mucosa, there is still mucosa posteriorly, probably. There, again, Weil. Okay, good. You see, removing the mucosa, you can better appreciate the bony borders. You see, now I have removed the mucosa here anteriorly. I will leave the mucosa on the frontal sinus because I will not cover this area. Then posteriorly here remove the mucosa. There is still some mucosa here in the posterior ethmoid and here, but I have to remove and drill this bone. So remove the mucosa still here. Sempre una 4.
Although I remember a few years back in one of our live transmission, Prof was operating on a different clinical situation. It was an inverted papilloma. And he demonstrated how to be careful in removing every bits and piece of the mucosa from the ethmoid, the maxillary sinus. That dissection, I mean, it's still in memory. And I mean, that case is still available. You're going to watch on our GRN channel. But that was absolute masterly, you know. And I can see now this you're approaching it very similarly in a different scenario, preparing the bed for the flap.
Yeah, the concept still repeats also in removing papillomas. You have to be careful. The most important things that Castelnuovo taught us is to be meticulous and to lose time to do things as much better as we can. It's not a question of who is the fastest in this room. It's you have to take time, to take landmark, to check for the borders here. Here we have a small fragment here of the bone. Okay, take time and we'll drill it. We need to take our time and to follow our rules to increase the success. So now I will drill and try to smooth. Another important thing is to smooth the field that will accept the flap. So we have to smooth the bony spars. So we can use this one. It's a curved, you saw, 35,000 drill endonasal with the curve shaped so that we can better drill the skull base. So let's check if it works. So ragazzi, 35.000 deve andare. 35. So we are going towards 35. Yeah, now it's good. 35,000. Okay, bipolar. Bipolar. Good. So go.
So Claire, looking at this nice field and lovely exposure now, it's so easy to forget the starting point,
Yeah.
isn't it? How crowded the space was, how bleeding, and how difficult it was.
But it just shows how,
Well,
as Paolo said, taking time and doing it in a very safe, stepwise approach gets you to this point, even from a very difficult start.
absolutely.
Okay. Okay. Good. Now, here, Castelnuovo, Prof, would you do something more in your experience here in exposing the defect? No.
I think now is very good.
Now it's good. So, I want to be more good than you think, so also this one. But then it's done. Okay, ready to put the flap on. We will have the fenestration, I think, after we expose the olfactory cleft on the other side. If not, it will beat more. So I expose all the olfactory cleft. I want to check the margins. I removed all the mucosa. Go, let's see all together. Let's check the mucosa of the olfactory cleft from the posterior part to the anterior. So go. So here, okay. Go. Here, almost okay. The borders, I can see. Wash. Here, we are at the limit. Perfect. Go. Let's see if there is some more herniation here. Go. Okay. Go. Perfect. Now here, go. We are okay. Here. Okay. Try not to opt too much, but okay. You can see the border, yeah, go. Here the borders, okay. Here, okay. Okay. Here anteriorly, go. Okay. Go. Okay. 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 Go. Okay, perfect. So now I'm happy, ready to get the flap. I will go to the contralateral side. I don't know, do you have other surgery? Do you want to skip the part of the ethmoidectomy and then we will be back as you want?
No, thank you, Paolo. I think maybe we'll take a very short break of a few minutes and then we will join back because we're running 2 channels and we would love to stay with you as long as we can. So and those who are interested in nasal polyps, sorry?
So you will not see the part that bleeds.
We're seeing the worst, isn't it? So I'm sure we'll deal with it. So we'll have a very short break. We'll play some informational videos. Just to remind our viewers that Prof. Manuel Bernas-Pickelson and Irina Perez, they are operating in Valencia in Spain. They are available on the 2nd channel. They also have a very interesting case with the severe nasal polyposis. And I'm watching through my corner of the eye on the other screen, and that seems to be equally challenging with the bleeding and everything. So you have an option of watching that space. And don't worry if you missed that case so far. The recordings will be available for you to view later on for both of these clinical cases. So thank you, and we'll be back again in a few minutes.
Okay, see you later. Thank you.
See you.
We're live too, Manjeet. They're all waiting for us. Let's have a little.
Hello, welcome back again. So we're having a fantastic second day of our 3-day live surgery event. And for Professor Richard Harvey in Australia, it's the third day. So it's 8 p.m. in the UK, and it's early morning in Sydney, Australia, where they're getting ready for surgery. So far, we have fantastic 2 days with surgeries from Spain. And today, we had Rick Carra and Professor Daniel Provedello performing craniopharyngioma from Wexner Medical Center, Ohio, in the USA. So I have with me my colleague, Louise Melia. She's a rhinologist from Bath in the UK. So how did you find the event so far, Louise? Do you enjoy it?
Yes, very much so. A shock. We've had great cases. So I was here for day one, and we had an excellent selection of cases.
Give me a towel clip.
Showed us how to deal with difficult cases, difficult fields to begin with. But then it was very interesting to see how the surgeons dealt with that. Gained a really good surgical field, and then obviously dealt with the pathology that was at hand. So been very interesting, and looking forward to the cases that we're about to see coming from Australia as well.
Yeah, great. And we have cases coming from Australia.
Let's go to the endoscope feed next.
Afterwards, we'll be joining eastwards.
Well, actually, leave the brain lab up. Leave the brain lab up.
Jaipur in India. So without further ado, I think we'll join the team in Sydney. And thank you the whole team for
just not
taking all these efforts to join us today. So Richard.
Okay.
Good morning, Richard.
Hey, good morning. Hold on 1 second. We'll just restart the endoscope machine. Just turn it off and on again. No, it's not clearing. So the white balance is not clearing. Just turn it off and on again. Yeah. Hey, so you should be able to see. Good morning. You should be able to see the scans up on the images. Let's get rid of any other feed other than just the brain lab scan, and hopefully you can see that.
Okay, correct. So we'll get the studio to connect to your feed, and then yes, we got your view. Fantastic. That looks interesting case.
Yeah, so this is a young 23-year-old girl. She's atopic and just has had progressive right-sided obstruction. And of course, all rhinologists and ENT surgeons will recognize this. She's got allergic fungal rhinosinusitis. And as it's typically forms with the hyperdensities on the soft tissue view, expansile unilateral bone changes, and typically a young person with an atopic predisposition. And so she's really absolutely barn door classic AFRS case. When she saw me initially, her symptoms have been obscured by the fact that she's had long-standing She's had long-standing symptoms of allergy, and she's not only sensitized to mold, but also to dust mite. And so, when I saw her a number of months ago, the first thing I did is I started her on dust mite immunotherapy, because she's actually got bilateral symptoms, this girl, but it is her right side that's worse, and the reason it's worse is because she's developed in an atopic individual a secondary condition, and that's the AFRS. And that's a really important concept to remember, that many patients with AFRS have an atopic predisposition to start with, and that's, often masks their presentation. Now, it's pretty straightforward on the scan. Are there any questions, Ashok, before we go to the endoscopic feed?
Yes, I think the question comes to mind that over the last few years, have you seen any rise in these cases of fungal, even AFRS, after COVID?
You know what? I'm not the best person to ask for that. Here in Australia, we had so little COVID that, there were less cases of COVID than there were the natural respiratory viral event, flu season. So I'm just, and even though COVID is more severe than that, it just in terms of prevalence, it's just not so common in Australia. So I really can't comment.
Okay. Yeah.
How about you? something you've seen?
Yeah, certainly I've seen more number of cases over last in the post-COVID era than I've seen before. But of course, that's my anecdotal personal experience. What do you think, Louise?
Yeah, so I think we've seen an increased number in the more concerning fungal sinusitis. So we've had several cases come in that have had invasive fungal sinusitis, and I think certainly in India they noticed a significant rise in the number of invasive sinusitis post-COVID.
Correct. Yeah. Okay, so what's the surgical strategy?
Let's go to the endoscope feed, guys.
Yeah, sure.
And we're about to start here. Artery clip, thanks. Thank you. And we're going to do a timeout, guys. Just mute the audio for a second, guys. Can we?
Sure.
Ashok, what's interesting about this case as well is that it's unilateral, because quite often we see allergic fungal rhinosinusitis in its bilateral disease.
Exactly.
I don't know what your
right,
experience has been with that.
Yeah, I know that's commonly seen bilaterally.
Mm-hmm. And it can be really quite severe. We've had a few cases referred as query malignancies because they've actually had mucoceles and they've had, they've presented with visual disturbance, and it's been secondary to AFRS.
Yes.
You got me back on?
Yes, we got your endoscopic view, and I'd like to know what is your preparation for this patient.
A couple of little things here.
Yeah.
Really important is to sort of acknowledge that the whole bed's at a sort of 15-degree angle.
Yes.
That's 15 degrees. And I think a lot of people, when they put their bed in reverse Trendelenburg, put it into 5 degrees and think it's the reverse. We're very comfortable. We usually operate at sort of 15 degrees reverse Trendelenburg. It's very common for us. And it's one of those things, like when you look at preparation for sinus cavities, there's little things you can do. If you use high-dose adrenaline, this is associated with about a half a Bozert score of field improvement in terms of bleeding. If you put someone in reverse Trendelenburg 15 degrees, this is another half a Bozert score. If you use bradycardic anesthesia, that's another half a Bozert score. And if you use tranexamic acid...
Sorry, Richard, I think your microphone is probably shifted away.
What's happened?
Yeah, so that's good. I think the sound quality has... Yeah, I can hear you well now, yeah. The sound was reducing.
Yes, I was saying, reverse Trendelenburg's half a Bozert score. Bradycardic anesthesia is half a Bozert score. Reverse Trendelenburg's half a Bozert score. And tranexamic acid given IV is half a Bozert score. And high-dose adrenaline's half a Bozert. So I think I named 4 things there. So, if you do all those little things, you get a lovely view, and I think we all know these things, but I don't, a lot of times when I see people practice, they don't put them into their daily routine, There's 12 RCT supporting tranexamic acid, numerous RCT supporting just simply using adrenaline or a simple non-selective alpha blocker. Very important for bradycardia rather than hypotension. So these are the sort of things that I use for the field. Now, look here. Here's the right-hand side. And you can see, very typical for AFS, right? It's got some polypoid degeneration coming. Now, to me, this is not the AFS here, right? That's the AFS, right? Can you see the sort of eosinophilic mucus?
Yes.
Yeah, so to me, this little thing here, which we're just going to shave up very quickly, is just allergic changes, in my opinion, coming off the bulla and uncinate. And here's some allergic change. That's not AFS coming off the middle turb. That's just an allergy change coming off that area. So now, when I'm going to approach a case like this, give me a ball probe, thanks. Look, sometimes I'll make an effort to see if I can see where the old uncinate is. But you know what? It often doesn't matter. And I'm intentionally going to go just to the back here. It's broken through here, so just give me a backbiter. I think a lot of us get fixated with the idea of wanting to find the natural ostium all the time. And it's so important sometimes just to not worry about that. And you want to find your anatomy. That's the most important thing. So the first thing we did there is just run along the superior edge of the inferior turbinate. So we've released the uncinate here. And then we'll take off the upper uncinate. Now, I always do the inferior uncinate first. Let's go an up through cut, thanks, Lenny. And then I'll up through cut, thanks. And then let's take off the upper uncinate. You know, it still reminds me that a lot of people go for the upper uncinate first, and even though they know it's going to bleed down onto them straight through cut, it's really not, you know, in my mind, that's always going to make your inferior uncinate worse. And we have this general rule in sinus surgery that if we're going to do something in the sinuses, that we do something in the superior and posterior part of the sinus first before something anterior and inferior. Yeah, we're just shutting the sucker up there. It was sort of rubbing out in this side there. Give me an up kerrison. So taking the inferior uncinate, take the superior uncinate. Now, it's really, I love the kerrisons. You know, I saw Stamberger operate in Graz and he used the circular punch, but he used it in the same way. It's a really easy tool just to sort of quickly sort of munch away. So then when you come in with a shaver, and you can see I've got that classic crunch and gobble technique, right? So here we are now. There we are. We're going to open this all up. Just get rid of the polypoid change that's there. Get rid of the uncinate that I've just munched up. I'm not really trying to remove tissue with my forceps. And I can tell you, here's a tip for anyone doing cases like this. Don't fiddle around with a fungus right yet, right? You can now spend 40 minutes if you wanted to try to get that fungus out. That's not going to be very rewarding, in my opinion. The bulla is almost collapsed here. So what we're going to do is we're just going to find, there's the edge of the bulla here. So give me the backbiter. Oh, no, give me a kerrison, my apologies. Whatever's left of the bulla here, we're just going to nibble it away. So it's almost like going into the retrobular area there. And once again, just sort of munching it up. There's a bit of mucus trapped in there. I just want to find the orbit. That's the only thing I'm interested in when I do a case like this. I don't really teach sinus surgery anymore about all the developmental anatomy. I really just teach it based on finding key landmarks. And one of the key landmarks here when you're doing an anterior fess is just to find the orbital floor. And sometimes can be a little tricky when it's a demotus. But there you go there. See that? That's orbital floor there. Yes. If that's orbital floor, then that has to be orbital wall. And if you're not sure that you're right, that's orbital floor for sure right over there. So give me the kerrison up. You can't quite see, in my mind, where the orbital floor becomes the medial orbital wall. And so I'll often then just nibble it a little bit more so you can really see, and I'll go with curette here in a moment. There you go. Perfect now, right? This is what I teach people to find. You see the floor of the orbit? That's medial orbital wall there. Cannot be anything else. So automatically as a surgeon, you know that that's the orbit right there. Let's go some patties, thanks. So now I'm going to stop here, right? Because I said to you, I'm not going to fiddle around taking this fungus out of the sinus cavity. Over the years, I've found that if you try to do limited ventilation type surgery for AFS and have a big maxillary sinus, you have a high chance that they'll have persistent mucus in their sinus cavity. In AFS, you really need to create a single cavity that they can wash out. And if you said to me as a researcher and scientist of the sinuses, if you said to me, why is the left side not affected? The left side's not affected because on that side, mucociliary clearance is occurring, and it prevents fungal elements from making any prolonged contact with the sinus lining. And if there's not prolonged contact, then you don't get a reaction. And if you have prolonged contact, you get a reaction. And so something happened here on this right-hand side in the maxillary sinus where she had some mucostasis. I mean, it could have been any event, like a viral event or something else. And that's what set off then a period where she had prolonged contact in someone immunologically predisposed. Because that's a question I get asked a lot by people. You know, why does AFS occur unilaterally? This is the sort of thinking about it. So, Lenny, let's go with a artery clip now. So now we're going to do artery clip. Now we're going to do a modified medial maxillectomy, you know, and this is really to make sure that we give this lady a really simple cavity. Now, things that you might want to see here, just as a way of interest, that we, let's shut that up. Peter Lee, do you want to grab that sucker and just sort that out? Thank you so much. So that's the nasolacrimal opening just there. See the little slit in the wall? Give me a sucker.
Yes.
Let's just have a clamp, guys. Just put a clamp on it.
That's the classic Hasner's valve.
Yeah, there it is there. So look, I'll try not to beat it up too much, but you can see what it is. So for most people, Hasner's valve is just this little slit opening in the side wall. It's not a hole in the top that people see. Give me the artery clip now. Yeah, maybe a second one, like a needle driver, just to clamp it. Yeah, put a needle driver on that. Okay, yeah, sure. Okay, here we go. So we're going to put an artery clip on. Now, I like to just crimp it here. Give me a curved iris, thanks, just to help with hemostasis. So this section of the middle of the inferior turbinate, we're going to remove so we can expose the rest of the medial maxillary wall. And I just simply will amputate this section, and then I'll show you about raising a small, I like to preserve the inferior meatal mucosa as a small flap. Now, as you come down here, you can see the whole wall is slightly medialized. Now, as you get towards the back, there's no point leaving a really big back stump. I think if you do, it doesn't often function properly, gets maximally dilated a lot, and I'll just try to cut it off. But you don't want to cut it off so flush with the wall that you end up with, almost stripping it from the bone. You want to leave it, let's go with the Metzenbaum, thanks. You want to almost leave a little stump so you can bipolar the little artery that's in there. And normally, you can see the very end of it here. Let's see if we can actually just get down here. I think I almost got through it. There it is. There you go. Blakesy, thanks. Now we'll take it away. Okay, let's go needle point now. Next, thanks. I'll get you to get a clamp and put that on it rather than doing that. Okay, so here we are. This is the floor now. Yep, and then I'll get you grab it now and we'll get you to... Now, when I do a medial maxillectomy, we want to feel for the hard palate, soft palate junction, somewhere along here. And then we're going to make an incision really at 90 degrees to the area that we want to divide. And just really make sure we're on the bone. Yeah, you want to be right down. We're right on the bony junction here. Great. Now, up here, though, I'll get you to swap for me. Give me a wipe. Give me the sucker. Let's go. I want to show you. There's our nasolacrimal area. I'm not going to look with an angled camera. I think we can sort of see the slit area. And then on this one here, this is why it's called modified medial maxillectomy, because we're going to preserve the valve area. And so this incision then is at a real 45-degree angle. Can you see that? It's very different to the back incision. You want to come at 45 degrees. Let's go Cottle dissector now. There you go, great. And then we'll just throw a clamp on that when we're not using the sucker. Now, because I've made the incision already, it's very easy to raise. Now, if the bone is very thin, actually it's good just to raise it on the floor first. So the floor is always a good one. If you're struggling to raise it, or the mucosa is thin or the bone's thin, just go to the floor first. And it should release entirely here, actually, because, if the surgeon had connected all my dots correctly, we should have no problems. And unfortunately, this surgeon almost did that. Not quite. There you go. And then we'll fold that flap up in this direction here. And you can see how the 45-degree anterior incision really helps us to fold that out of the way. Let's go curette now, thanks, guys. I love this maneuver. This we call Jessica's punch. I don't want to do all of this with the drill, so we just punch in. You got to punch somewhere comfortable. Don't be working really anterior and posterior in my mind. Kerrison up, thanks. And then we'll just come through now with a Kerrison, and then we'll use a straight through cut, thanks. So you want to come in, obviously the bone's really thin here in this patient. We'll come then through with a through cut. And it's exactly the same technique. Make sure we have a 12 sucker here when we eventually get this guy open. Yeah, not right now. A 12 though. Yeah. Minji, can we get a 12 Fraser? Thanks. Just disposable. Yeah, hopefully I'm going to reduce the pain of sucking fungal mucus out for everyone. I worked in the south of the US with Rod Schlosser, backbiter, thanks. And the amount of fungal material that I had to suck out during my fellowship was incredible. And I've really got an aversion now to sucking thick mucus out of sinuses. I don't like it to take too long. Here we go. So you can see how I'm going to remove that bone right up to our cut here. Now, I've seen lots of people describe this tuna saving, modified medial maxillectomy, nasolacrimal duct preserving. It's all of those things. That's why it's called modified. And how you do it doesn't really matter. But what you can't do in a modified medial maxillectomy, Ashok, in my opinion, it's not a big hole. One is not doing the drill, thanks. One is not doing this surgery for ventilatory reasons. Let's go 30,000 on the button, thanks, Minji. No, 30,000. Thank you. We'll just make sure our irrigation's working. Yep. And so the goal of the surgery is to create a sinus cavity that doesn't collect mucus. This is easy to wash out. And so we don't want any sumps to form. If you leave a sump or an area where mucus forms, this lady, unless she's on prednisone, will end up getting a reaction because she'll have a long contact time with the fungal elements. And I don't normally give fungal immunotherapy for these patients. They don't need it for most of the part. If you just restore their mucociliary clearance, the sinus will come good, like the other side. Now, they are a little bit at risk, Ashok, I think there's a few publications to show that you're a little bit at risk of getting it on the other side, even if at some point in time. But I must admit, I'm not one yet of doing the other side, prophylactically or anything, I just try to just get it right. What about you? I mean, you're probably over the course of your career have seen people who come back perfectly normal side one time and then a few years later they get it on the other.
Yeah, yes. And there is argument by some that you can do this mini phase type of procedure, uncinectomy, middle meatal antrostomy. But again, you said if it is not broken, why fix it? It seems perfectly normal on the other side in this case.
Yeah, I wouldn't even fiddle with it. If it's normal, I wouldn't even do. I don't believe doing a simple antrostomy in my mind protects you from sorting that out. And you'll see once again here, Ashok, I've really made a huge effort to not touch anything. Like I haven't touched haven't touched everything. I tell you, just as an efficiency as a surgeon, we'll just get rid of this little bit of posterior turbinate. It's much, much quicker if you just leave it all and get your opening right. And you can see I've almost got my opening right. To the point now, give me a ball probe, thanks. Let's take out the patty. And you'll see how much mucus is here, right? Mm-hmm. Look, from there, so imagine if you were a surgeon trying to remove this mucus plug from up here. Oh my gosh, I can tell you, Ashok, I've seen that, people do that, and it is the most painful thing to watch ever. So, I always promote the idea of get your opening right, then remove the mucus plug. Let's go a wash on a stick, Linny, on a long, thin curve, and we'll get our 12 sucker on. And you can see here that I'm still going to have to struggle. I'm sorry, I'm going to have to put everyone through mucus removal. But now, at least, give me another...
So you're almost going through the normal anatomy surrounding the whole disease, and then making it easier to remove.
Yeah, 100%. So let's give me another washout. So I find that a lot of the time you got to put a bit of a wash in to get the lump going. And I've even been known to take the 12 gauge sucker off the sucker and literally just put in the. Just want to pinch it for me. Go for it. Let it go. See, look, I got a 12 gauge sucker. And look at it, right? This is why, for all of those watching who thought I should have been removing mucus 5 minutes ago, and it goes to show, though, why we're doing this approach. If you did an antrostomy and spent half an hour trying to get rid of mucus, all you would have achieved is creating an empty mucus-containing cavity that's likely to recollect mucus in the next, little period after surgery, because they will sump and pocket mucus very, very easily. And this is, I think, why people used to, like I grew up in the days of Fred Kuhn, where he thought AFS was the worst condition ever and it was chronic. To me, AFS is the one condition that we can cure as sinus surgeons. It's eosinophilic, type 2, diffuse disease that we end up needing biologics for and everything else. Okay, I'm gonna do it. Pinch the sucker for me, please. Big Tilly Hankel. I have to resort to this sometimes. Doesn't always work, but let's have a look. Okay, hook us up, open up. Thanks, Lenny, open up. There you go. Hasn't put this 12 gauge back on. Oh my gosh. Alrighty, 12 gauge back on. Now, as I'm slowly removing this, the brain's trust of the panel, I'm open to any special techniques that people know of to remove mucus. I've never discovered one. My best one, I would say, is thick eosinophilic, a big hole, and make sure that you use the irrigation as much as you can, because irrigation sort of loosens up this tight attachment it has to the surface, I think. Let's go another irrigation. We might do a few more irrigations. I can see it coming loose here. And you can see with a nice big opening too, Ashok, I'm not struggling when it comes to, putting the sucker in and out. I see so many people sort of beat up the lining, when they're trying to suck something out and they're struggling. Have a nice big opening. You can suck it all out. It's a bit easier. Let's go that. Hey guys, don't worry about anything else here. Let's just go the wash and the stick, thanks.
Yeah, and with this technique, almost the whole of the mucus is coming out like a ball together. You can dissect out from the edges, rather keep aspirating it. So when it is out, it will come out in total.
Okay, give me another wash and stick. And you can see it. I've loosened up the back, but this front wall has got diabolical amount of mucus in it. Wonder if I can come along the front wall. Oh yeah, getting there. It's always satisfying when it comes out. Just quickly grab it. Don't mess around. Okay, here we go. Wash on the stick, thanks again. And I might try my little direct sucker approach again if I can loosen up this side wall. But once again, just a great demonstration of just needing to get your opening right first, Ashok, just so important. Yes. And this is also too, those of you in the audience who think, oh, can't you just get away with doing an antrostomy? This is the pathophysiologic process you're fighting. And this is why people who do little ventilatory surgery, on conditions like AFS, struggle sometimes, and they have patients who get recurrence or don't settle down even to begin with after the surgery. So I'll get you now to pinch the sucker for me.
And can I ask, so post-operatively, what regime would you put the patients on? Would you use oral steroids? Would you use steroid-impregnated rinses? Okay,
let's go. Yeah, so you have to use oral steroid for AFS. Yeah. You got to at least for some period of time suppress the condition, and I don't think you can do it with topical corticosteroid irrigations alone. And so they all go on oral steroids for a period of time, usually something like 3 weeks, but you don't need a big dose. 25 milligrams max dose is all you really need to suppress, eosinophilic inflammation of the airway. So you don't have to give them much. There's no role for antifungals, in my opinion. I wrote the chapter 6 in EPOS 2020, which was all about fungal sinus disease. And you know what? There were some fascinating things that when I had to do the review of that, and I did even a couple of meta-analysis plots for things to really show that, being on things like antifungals makes no difference. This is a hypersensitivity condition. Now, whether or not you believe it to be a type 1 hypersensitivity, and so it's IgE mediated, I'm not really convinced that's the case, but it's an hypersensitivity. I mean, there are other types of hypersensitivity reactions like type 4 or delayed type hypersensitivity reactions. So I do think it's probably a bit more than just IgE mediated, and that's why drugs like omalizumab have never been the the sort of panacea for AFS or controlling it. And certainly I've got patients on biologics who have been given everything from benralizumab to dupilumab with AFS, and unless they get their sinus cavity cleaned out of all the mucus, it doesn't really help them. They have ongoing problems. So if you don't get out the mucus plug, just make sure the suction's on maximum, isn't it? This is where I'd like 2 striker units to help me suck out this. You can see, look, this is what you're fighting, right? This is AFS at its truest. Let's go this here. So I might have to just break it up here. Just grab it. Just grab a sponge and just get rid of it. It's not a specimen or anything. Certainly not at this point. Alrighty, here we go. So actually, this one unusually is going to sort of. Let's get Lenny a sponge so she can really grab this properly from me. She's just struggling with a little Ratex. Yeah. Thanks. Yeah, so I will give them some steroid, but corticosteroid irrigation still play a big role here. So, but you should be able to normalize the sinus cavity. And if the patient comes back to you at 3 weeks and their sinus cavity isn't normalized, you've got to be worried. If you haven't normalized them early on after surgery, then you've either left a whole lot of mucus in their cavity, or you're not giving enough oral prednisone to suppress the reaction, and they're just getting mucostasis again. It's just really wipe it for me. Don't worry.
So for a patient like this, Richard, what will be your post-op oral prednisolone regime?
Yeah. So 25 milligrams, for 1 or 2 weeks, 12 and a half, and then 5, maybe, something like that. Sometimes, if it's very localized, I might just give 25 for 2 weeks with a cold stop. You don't need to taper doses less than 2 or 3 weeks. I don't give small doses. I don't give really high doses for 2 or 3 days and then like a 10-day taper. There's really a lot of evidence now that that's not really how we should be using anti-inflammatories like prednisone. It just ends up exposing patients to subtherapeutic doses, and they don't need it. 2 to 3 weeks is a totally fine period to have someone on oral corticosteroid without worrying about a taper.
And any preoperative prednisolone, do you consider that?
I do sometimes. It depends how inflamed they are, but not normally though, actually. And I tell you why, Ashok, is that although I agree a little bit of pre-op prednisone can help their surgical field, I don't like. Can you pinch it for me? Yeah. Give me 2 seconds to focus here. Okay, and release. To improve their surgical field, it doesn't really help their recovery, and I'd rather limit their overall systemic corticosteroid use to the post-op period to help with overcoming their AFS. Does that make sense?
Yes.
Yeah. Although I completely acknowledge that if you give it, it will make things better. See, that's the shot everyone wants to see. See, just to show you that after debulking it, and just make it clear, I've attached the striker suction machine directly to sinus to the mucus ball there. And let's go back. We can do the 12 then, and we'll have one last look now. But you know, that wasn't too painful. The pain was relatively minimal. Yeah. Let's go and do the rest of the sinus cavity then. You can send that piece off, Lenny. All formalin, thanks. Yeah, and that's a really important thing. Lenny just asked me, she said, do we send it off for formalin or for micro? Only formalin. Do never send AFS cases off for micro. You only totally confuse other doctors about what's going on. And so I think it's very important. Let's go to a 10, Fraser, thanks. This is not an infective condition. If you start sending off micro samples, you cloud the picture for everyone. And you know, you might think our infectious disease colleagues understand what we're doing here, but they don't. They really don't understand AFRS. The only doctors who really understand AFRS, in my opinion, Ashok, are ENT doctors. I mean, I'm sure you've had that feedback. You know, immunologists aren't sure what to do with them, and respiratory doctors don't quite understand it. Now, here's something we're going to do that I do, and every time I do a medial maxillectomy, is that I'll really make sure that I dig out all the pockets. See how there's like a little pocket of mucus there?
Yeah.
Yeah, give me a curve sucker, thanks. That's very anterior. And that is an area that would cause recurrence. And so in people who have a well-pneumatized maxillary sinus, and you can see here, there's still like a little punny pocket happening.
You just wouldn't be able to reach that with an antrostomy.
Oh, yeah.
You know, as you said, that
miles away.
Yeah.
And you would have probably spent an hour trying to get the mucus plug out. And then you would have thought you'd done a great job because you were trying to stare in with a 70 scope and looking at what you'd done. And then the patient would have had grumbling, ongoing inflammation in the sinus cavity. And the surgeon, very commonly, it's like 15 years ago, let's go the drill back on, would be dumbfounded by why it's not getting better. But that this sort of phenomenon, what we're staring at now, is what's going on. Now, one of the things I'll do then, and we publish about this in dysfunctional maxillary sinuses, is that we really it's not a ventilatory condition. We're here to reshape the sinus cavity. That's what we're doing. We're trying to reshape it. So I'll drill this little bit of bone here. See this bit of bone? We call this Snidbong's wedge. It's just a little triangular bone where if you don't remove it, you can never see the front aspect. And then I'll drill off this whole side wall. And then we're going to carefully strip out the mucosa from this little pocket, and we'll get rid of it, like an obliteration. And I'll show you how we set it up at the end. We'll have some Surgiflow, thanks.
Is that the angled burr you're using, Rich?
Say it again?
Is that the angled burr you're using?
It's not actually angled, nope.
No.
Like 15 degrees, yeah.
15 degrees, okay.
Anyone who knows me will know that I hate angled instruments and angled surgery, right? And you'll see here in a moment when we do the frontal, like what we do to make the frontal happen. Okay, look, we've got to go back to the smaller sucker, the 10, please. The 10 is what we need now. Let's stay with the 10. Big wash, thanks. Okay. Yeah, I only like the 12 when we need to do that really big area with all the mucus, and then let's not have a 12. 12's too big a sucker normally for sinus cavity. So here you go here, guys. Can you see this? So here's our little area. I've got a little bit more mucus here. And I'm not actually taking the mucus out now, guys. Can you see I'm taking the mucosa? I'm channeling my inner trainee and making sure I strip now, right? Okay, so this is here. This is the front wall. Let's go 90 curette, thanks. And this takes, if you take a bit of time to get the plane going, the stripping plane right, it makes it a whole lot easier. And you'd be surprised, look how deep some of these sinuses are, right? And I want to take it off so that I get rid of the very bottom sump. Let's go the curved long sucker on, thanks.
There's so many little nooks and corners, isn't it? It's not a flat cavity.
Mm-hmm. Yes, but it will be, Ashok. It will be at the end. Yeah. That's what we're going to turn it into. And we're going to make it a smooth bowl. There's a few little things we still need to do here. And this surprisingly is a big part of the surgery. A lot of people think medial maxillectomy is about making a big hole. It's not about making a hole. It's about creating a sinus cavity that has no area where mucus can collect and sump. What have we got on? Drill? Give me the drill and then we'll go to the shaver. And normally with a nice modified medial maxillectomy, you can do it all just with straight instruments. Make sure that there's no little areas. Okay. Give me the shaver, thanks. And now we'll shave that away. And at the end of the case, I'm going to leave it now, but at the end of the case, I'll show you how we fill it in order to actually make it smaller. Okay, here we go. And look, it doesn't take long. It's like a simple thing to do. It's really, what do we call it? An obliteration of the floor. If I can not suck up my flap, as you try to. Okay, give me 170-degree scope. This is for the audience, right? We'll show them the cavity. And you've got the curved sucker on. So I'll show you the cavity because we're going to finish there. But just for those of you who really want to see it. Now, you don't need to strip this mucosa any more than just the same level of the nasal floor. Anything higher than the nasal floor is sort of redundant in my mind as a concept. And we'll just make sure there is a little tiny bit of bone there. So we'll just make sure that that front wall is good. 70. Just for those of you who want to see, a few times I'll put a 70-degree scope on. There you go. See that front wall? Mm-hmm. And look how there's even a little bit of mucus getting caught there, right? Is there a bigger one? Nope, it's fine. And this is the thing with curve suckers. Curve suckers are always so fine. And this is why you need to give prednisone. Because even though I've maximally removed everything, give me the shaver. Just give me the shaver. Yep. All right. Now, I don't feel like this is blocked or something. Look at that. Look how there's like the remnants. Let's go the wash on a stick, thanks. I'll go the 90, the small 90 on the wash, yeah. Let's see if we can wash that last little bit out. And you know what? If I can't wash it out, I'll see if I can get something else to remove it. And here we are, right? Even with my modified medial maxillectomy. Give me the 90 curette. Just got another wash on a stick, thanks. There you go. Oh my gosh. Everyone's going to say I should have looked with this 70. It was worth looking. After poo-pooing the 70 scope, it showed me that I haven't got everything out. Give me the wash on a stick. And you know what? That's that very most zygomatic recess, you know, where that's sitting in. That's not generally up a big pocket. We'll get that now, I think, with that. So you've seen what I've done to the floor. That's really important. Look at that, and that's just the polypoid edema, and a bit of mucus sitting in there. There's our mucus. Oh my gosh, right? And then I think we're good. That might be a bit of, that's like, look at that, guys. Can you see that, Ashok? It's mucus in the mucosa. Can you see that?
Yeah.
Yes.
That's why you fail. Right there, right? And so, let's see if we can shave all that off, right? That's such a diabolical situation, you know, for patients to have. Shaver. Doesn't always work, guys, so. Look at that though, right? Totally worth getting all that out. Oh my gosh. Okay. I can't possibly better operate with a 70 any longer. Give me a 0. Give me straight sucker. 10, thanks. Let's go big wash, thanks. That's what you were doing before, Peter Lee, wasn't you? Fair enough. That's a good call. Oh my gosh. So, there you go, right? I've got all the tricks to sort out. I'm blocked again. Let's go 10. That's an 8. Can I go 10? Now, that is not how the sinus is going to be reformed. We're actually going to use some gelatin paste to try to obliterate the sinus, and I'll show you what that looks like here in a moment. Now, give me the bipolar, thanks. We've got to do a little tidy up back here. So often this back edge is often heavily expanded, as you would expect in this situation. You don't want to completely take it back. There'll be some vessels in here. Let's go a Blakeslee forceps first, and then we'll go bipolar. So here, though, you are going to have a few vessels in here, and what you don't want is a whole lot of raw bone at this back edge, right? So very commonly, not just in her, but in everyone, I'll actually make a little effort to take out the bone between the mucosal edges to try to really allow this area to come together as a mucosa to mucosa apposition. I don't mind if there's a little bit of raw bone elsewhere, but I don't want it right there. It tends to crust, takes a long time to remucosalize. And there, that's the vessel right there, right? So you can see the vessel. We're just using a standard bipolar force. It needs to be set at 25, guys, please. Minji? 25 on the bipolar, thanks, guys. Yeah, awesome. Big wash, thanks.
And I agree with you, Richard, that sometimes when that crusts fall off, there's a risk of bleeding there, as it can open up the blood vessel behind it.
And you know what? That's why you need a bit of soft tissue there too. You know, Ashok. See how there's a bit of bone flake in there? That's got to come out. But Blakeslee, thanks. So really important not to leave little bone flakes. See that bone flake? Really important. Give me a bipolar. Got to make sure there's no like little bone flakes and things. There you go. But you don't want to. You decide you don't want to strip that area. It's really important not to strip it. Okay. Give me some patties now. So there's our maxillary sinus done, and now we'll sort out the frontal, right? So we'll pack about 5 or 6 pads in here. We got our terrible mucus plug, as well as the intramucosal mucin, right? You saw it there live, right? You do see that sort of thing, you know, it's a crazy, and that's why you've really got to make sure that you've got a cavity. Like if you just washed out the sinus with angled scopes and angled suckers, and you'd never really picked up on that, that would have been a recurrence waiting to happen. You know, you just cannot expect submucosal mucus and fungus to be extracted from the sinus cavity. I think we get away with it in rhinology so often because we give them steroids, and during the steroid period, that helps to suppress, and then their own system kicks in, and we get away with it, you know? But if you said to me when it doesn't work, they're the sort of factors that are at play. Now, we're just going to open a frontal, and this is obviously, you know, something that we've promoted, a needle point diathermy. It's just doing a thing called a Carolyn's window, and it's really nothing fancy. It's just a version of what people have already described. Let's go 10 sucker, thanks, and just suck my smoke for me. So all it is just drilling off the front wall, right? So here we are here. We're just going to mark off this little point here. And we're just at about the level of the middle turbinate attachment. Then we'll come forward here. And then we'll drop down where we see the piriform. I'll swap you for a second. Give me a wipe. Now, Jared, I might get you to help me out here, Jared. We don't have enough head extension, so I might get you to take out the head ring here in a second. So you can see the piriform, guys? Then you've got to drop down right on the piriform to about the midpoint of the middle meatus. You don't need to be any lower than that. Now, if you've got a little funny swell body and things, you can always just shave it, but it's important to have a septal surgery if it's not straight up there. So Jared's just going to take the head ring out. Our patient's just slipped a little bit. We had them in a really head extended position. And it's really important to do that. If you're going to work with near 0 degree scopes, you have to have the patient in really quite a head extended position. And so otherwise your instruments are hitting the chest all the time. Very annoying. Okay, so here we go here. So it's a bit like a big DCR flap, right? Massive DCR flap, except it's based inferiorly. And I used to do this with little mini flaps. And then Ashok, one day I had Brad Woodworth was at our sinus course as an invited guest, and he just said, "Look, Richard, why don't you just take it all the way forward and make it inferiorly based?" And so I did what Brad suggested, and I actually even took it. I said, why even take it halfway towards the piriform? Let's just take it all the way to the piriform. And you know what? Ever since then, it heals much better. The bigger you make the flap, like in many other places in the body where you make flaps, if you just make it big, it actually heals better. It gets less venous congestion, it's got better blood supply, and it just totally clears the area ready for you to drill. Put the drill on, thanks. Now, the nice part about doing this is that we're going to now find our anatomy here. Now, if you wanted to, like say you were missing a middle turbinate and you wanted to do this technique, Ashok, you can always go down here and find the first olfactory neurone if you wanted to.
Yes.
And we'll see it's coming up almost. There it is there, right? Can you see it? The fascicle's going in?
Yeah.
Yeah, so I mean, that's how we described, when doing Lothrops about always finding the, the skull, some sort of landmark for the skull base, Now, so once you've got that, I've got like the world's, I think I've got some tissue stuck around my neck, Lenny. Can you see that? If I give it to you, you're able to get rid of it. It's sort of creating, we call it the whippersnipper approach. It's where you, big wash then while we're waiting. It's where you get a little bit of soft tissue around the neck of your drill. Weed whacker if you're an American. What do you call it? We call it a line trimmer. What do British people call that garden device used to trim the edges? Line trimmer, yeah. You get a line trimmer effect. So you can't have the line trimmer effect going on. It beats up all the water and irrigation. So what we're going to do now is just a version of what PJ used to talk about doing, taking a bit of bone. I love Jim Palmer. Jim Palmer had described the technique of just removing the whole anterior face of the Agenasi, and he used to be really aggressive with the kerosene, really come out as laterally as he possibly could. And just get the stylet ready because I'll block it up here. That's all right. We're not blocked yet. Now, down here, the first landmark you'll find is a bit of periosteum of the nasolacrimal sac, obviously. And it's quite amazing, the bone here is very different for different people. And even in one person, it can be very different. And the whole thing is designed to give you like a really nice, clear view of... Unblocked, thanks. I'm just going to unblock it. The line trim. Yep, thank you. Thank you very much. Very good. It's to give you a nice 0 degree view. Now, it's not just about doing the frontal sinus this way. It's also about leaving behind a sinus cavity that's really easily managed. Now, I look at the scans, and I actually think you could probably get away with anything here because I'm not convinced there's fungal elements in the frontal sinus. But you know what? Just like we did the maxillary sinus, Ashok, if there was fungus in the frontal sinus, we would not have much success with a little angled tiny opening, you know? It'd be the same as doing an antrostomy on that maxillary sinus, right? Would be really hard to remove, hard to see it. You wouldn't be sure whether you got it all. Blocked. Yeah, don't clamp the sucker anymore now for me, thanks. Just leave it down there.
Richard, you're flattening the bone on a quite wider front, correct?
Yeah. So that's what I'm doing. I'm saucerizing it.
Yeah.
Yeah, and you can see, I don't know if you can see, just have a stylet ready. Lenny, it just got blocked again. Leave the sucker where I left it last time, thanks. Yeah. No, just leave it for me. Yeah, and just don't fiddle with it when I put it down. And we'll leave it open now. So here, can you see this? Can you see this white structure here? There it is.
Yes.
There. Yeah. That's your periosteum, right?
Yes.
That there is your nasolacrimal. That over there is your first olfactory neuron. So you know, just leave the sucker, please, Lenny. Yeah, it's good. That this area here, we sometimes refer to in Lothrop drilling as called Ritter's triangle. It's this triangular bone that's in front of the frontal recess. And although I've been trying to drill with my drill with the side of it for most of the time, at this point now you do start to drill a little bit with the pole. And when you drill with the pole or the burr, you do block it a few times. You just have to have your assistant, Lenny's here, she's got a stylet ready to go. And when it blocks up, we'll swap. She'll give me a big wash so I can wash the field, and then she'll unblock the sucker. And then we'll just do that, and you'll see it doesn't take long here to develop. So you can see here we're in front of the frontal recess still, this triangular bone, we've got periosteum there. We know where the first olfactory neuron is. And as you can see, I'm blocked. And that's what happens a little bit when you start drilling with the pole of your burr. And you'll see in a heartbeat here, we'll take off this. I don't always find the first olfactory neuron. That's optional, guys, if you can always put it back. Leave the sucker down there. But if you think about where we are, and I think for surgeons who are really, most of their surgical orientation is about finding the sinus cavity, it is uncomfortable to do this for the first time because you really need to find the anatomy. You know, you have to understand where the periosteum is, where the middle turb or the first olfactory neuron is, and you need to understand that you're just in front of the frontal recess.
So for your draft trees or the Lothrops, do you follow the same technique but on the both sides, correct?
Yeah, 100%. Yeah. It's almost like the same principles, Ashok. And I sorry, I didn't get the introduction to your guest commentator.
Oh, so sorry. She's Louise Meliak. She's a consultant. She's a rhinologist, skull-base surgeon. She was in Glasgow, just moved to Bath in the UK.
Yeah, Louise, is it?
Louise,
yeah,
Louise, yes. Louise.
Nice to meet you. I don't think we've met Louise, so.
No, we haven't.
Yeah, so look, so you just and you can imagine where I am now. As a surgeon, I'm in front of the frontal recess. There's my frontal recess behind me. I'm actually medial to this area, and this is the frontal beak, you know. Now, when you see this finish, you'll think, oh my gosh, that's an amazing opening. But the reality is it's not really, right? It's actually still a very limited opening into the frontal sinus, and it's great for this sort of thing if you just want to wash out a sinus cavity. But because it's in a tall, vertical corridor, it's not a very good approach to do tumours and other things in the frontal sinus. So it's not as if this is a replacement for a Lothrop, because you're so vertically limited between, sort of medial-laterally, your ability to reach laterally is very limited, so I'm blocked here, and you can see my sinus about to open up. Yep, let's go. Almost there. And we're almost there. And then, can you see the nice part about this, though, Louise, is that I love opening up the posterior ethmoid and sphenoid to find the skull base, but you actually don't need to if you're doing something like this. You can actually... Yeah, I mean, I do it in a heartbeat. And I would say to any surgeon, if you're not sure where you are, you don't know where the skull base is, just, always open up the sphenoid, find the skull base, make sure you understand where the roof of the ethmoid is, if there's any sort of ambiguity. But the actual anatomy you need to do this type of Carolyn's window or sort of unilateral drill out is actually just all here with you anteriorly. You don't need to necessarily find it,
I think that, once you've found your first olfactory neuron, I think you know your posterior limit, don't you? And then you know anterior to that you're safe.
Well, the nice part about doing any sort of drilling from what we call outside in, and this is why we promoted it in Lothrop, is that it's really safe. You're always got the frontal recess or frontal sinus between you and the skull base, right? The only place you don't have it is right in the midline.
Yeah.
So right in the midline, you can see I'm getting that blue lining now. Right in the midline, of course, you've got your first olfactory neuron and the forward projection of the olfactory groove. So in that area there, that's where you might get into the skull base, especially if you were missing anatomy, like middle turbinates and things like that. So we almost always either stay entirely lateral to the middle turbinate if we're drilling, and if we are going to sneak across the midline like I have a little bit, it's actually one of the reasons why I found the first olfactory neuron. I didn't find it just to show you guys. I wanted to know what was my depth. And you can imagine, that's frontal recess mucosa there. Here's frontal recess mucosa, and I've got a little bit of a bridge here left over. Can you see that?
Yes.
So we'll get that up. And it's like, I don't do anything else in sinus work, but I can always remember I've got some fantastic ear colleagues, and they used to do canalplasty, and I used to always be impressed how in a canalplasty, because in Australia we have lots of exostosis, they would open up the canal, and at the very end of the procedure you would see the epithelium, and they'd flick it out. And I sort of feel like that's what this is like a little bit. It's a bit like a canalplasty. You drill with, it seems like solid bone for ages, and then all of a sudden you're into the frontal sinus and the whole thing's open and you're done. And the nice part about it is you saw how inflamed everything is. When you do this sort of surgery, there's our frontal sinus. You open it up maximally. Is that? I'm thinking that is that a little? That's like a little lip, isn't it? I have to have a look. And you see almost through here, right? It's so thin. I've left it so thin. I'm going to come back with hand instruments here. Yeah, here. And see, I've got a little lip here. Look how this little lip is coming forward. That'd be, nigh impossible through a 70-degree to get rid of, right? But look how quickly you can just get rid of it now, right? We don't like the lip. We can maybe even open up to the other side a little bit, which I'm going to have to do here. Inner sinus septum slightly on my side, so I'm not going to leave it. I'm going to open everything up so I maximize the opening that I've created. I'm blocked again. Big wash, thanks. And we're almost there, and we're in a moment. I'll just do a little bit more drilling, and then we'll put our shaver on, and we'll turn our suction down when we put our shaver on. Not yet, though. So can you see that, guys? Frontal sinus, contralateral side. But you don't want to leave bone, right? Here, this is an opportunity where we can drill more and expose less, right? So we will intentionally drill to remove raw bone. So by opening it all up, can you see that?
Yes.
And,
yeah.
and I do like sometimes the baby Hoseman here just to reach around the corner. She might, yeah, I can see Linny's got it already. She knows us too well. You haven't lost your touch, Linny. You remember it. Our senior nursing scrub has joined us today. She's on admin duty most of the time, but she remembers. Here we go. So really, I mean, it's really a contractual side opening now, right? But it just means, can you see how by drilling more, I've exposed less bone? You get that concept? And that's so important, I think, when you do this surgery. I think some people do it from inside out and they've spent 2 hours drilling. They're just so exhausted and tired at the end of the drilling of that little bit of bone that they just, you know, they're just thankful that they've found the sinus and open it is. You know, when in fact, actually, you really need to get in there quickly and then spend most of your time finessing it and getting the shape and everything else perfect. Liddy, did we get some surgery flow? Yeah, fantastic. Now, I'll take 2 silastic sheets and I'll get Peter Lee to make a 3/4 spacer, thanks. And I'll take 1 pure region here at the end. Just do a 3/4 spacer, single spacer, 3/4. And you can see I'm just drilling the intersinus partition. And
Richard, you can see that how the mucosa differs with the right and the left.
Yeah, yeah.
The left, it is entirely normal mucosa. You can see the edematous
it's all inflamed, right. Yeah. Let's go to shaver. Thanks, Lenny. Now, so let's and I'll get a wash on a stick. But let's have a look at that, right? Because I don't think there's fungal elements up there. Louise and Ashok, I think it's I think it's just
quite clear.
It's a secondarily obstructed sinus, probably. But you know what? To me, it's heavily inflamed and could become AFS. So look at that. That's a bit of mucostasis. That's AFS waiting to happen. That's how AFS starts. You get mucostasis. All you need is a bit of fungal elements up here, and then away you go. Okay, so let's go now to. We've got our shaver back on. Let's go down on the suction, guys, to 120. Let's go kerosene up, thanks. Yeah. And so here now, we'll just take off the front wall, right? Remember I said to you, I've been leaving the front wall to do here. And so this is why in an outside-in approach, you can leave the delicate frontal sinus mucosa, and you're almost working out of the field here. Can you see how we're, you know, I've got her head really extended, so my kerosene's trying not to hit her chest too much, because you can imagine the shape of a kerosene handle. Yeah, that'll do. And suction's down, guys, is it? Thank you. Thank you. Now, this Ashok is the joy of Carolyn's window that you then get to do. You get to do your frontal recess surgery with a quad cut. This is why I love it. You know, not sitting there with articulating giraffes and everything else. And when you do it with a quad cut like this, almost slightly staggered out of the lining like this, it's just easy to do. It's simple. You preserve the mucosa. You can chase all the partitions and get it perfect. Anterior ethmoidal arteries in the skull base, so we don't have to worry about it. That was right, Peter Lee, wasn't it? Mostly. It's not exactly, it's not sitting out. There's a little ridge here.
It's a lovely opening.
You get such a clear view of all the cells, don't you? So, you know, you've opened everything up.
It's just like doing an ethmoid cavity, Louise. Yeah.
Yeah.
How easy is that? And we call it running the ridge. If you said to me, you know, what am I doing? I run the ridge. I follow the ridge of this following up and follow it from we want to see it go from ethmoid across to the skull base. You can see there's a little lip here. Why is there a lip? There has to be a little cell or something in here. It's not a big cell, just a little one, right? There you go. Okay, and I don't like this. That looks ugly. Give me a drill, thanks. And you see this mass movement, guys, down here? See that? When you see that mass movement, you know it's on the orbit. We're going to drill. See this little shelf? I hate that. That looks terrible, right? It's going to get in my way and prevent us giving a nice healed cavity. We can probably put our mucosal flap back now. And it gives you, you know, I'm sure, Ashok and Louise, you've done cases in your lifetime where it was just such an easy case. You know, the anatomy was such that there was a wide pneumatized agonasi, the middle meatus was giant, and you just sort of think, God, I wish all cases could be like that. When you do a Carolyn's window, that's what you're doing. You're converting your unfavorable anatomy into a standard look every time. And everyone just then becomes the same. There you go. There's that little pocket, right? We'll open that puppy up. Okay. Now give me a wash and a stick. And now we're going to close. And I'll show you. The closing's important, right? Because, you know, it's not like taking a submandibular gland out. We're here to create an endpoint for our surgery, right? We want it to be this healthy cavity that's going to be wash-outable, you know, irrigatable by the patient so that because, you know, right now this mucociliary function ain't working very well. And so I'll just put a patty up here. Give me the 60-degree curette, thanks. Do you have a 60, not the 90? Yep, it's a 90. Got a 60? You got it there? If it's not there, it's usually in the standard setup, Lenny. Yep, perfect. I'm just going to put a patty up into that frontal sinus, because you know what? That frontal sinus, Louise, hasn't had any vasoconstriction. And so before we call it a winner, right, I called the maxillary sinus a winner before it wasn't, and then I looked with a 70-degree scope, and there was a big plug of mucus. So one spit and twice shy, right? I'll make sure this frontal sinus looks perfect before we call it done. Now, let's pull the dressings up here, guys, because while that is just baking, you can see our fellow Peter Lee Sachs has made a spacer. You know, there's lots of ones that are pre-made, but I still love making them out of just a Miracell tampon, and we pull that out. Let's go to the second silastic, thanks. 2 silastics, thanks. And I'm going to cut the silastics in a certain way. Do you want to hold that for us, Peter Lee? There you go, have a look on the screen. And just have it vertical, otherwise it's a bit disorientating. Straight iris, thanks. Now, I really love, you'll never regret, in my opinion, doing putting silicone sheets in the nose. You know, it looks great at the end of the surgery, but 2 or 3 days from now, it'll be really inflamed and everything else. So look, I'm really a big fan of leaving silicone sheets in to make sure everything heals well. And I often make this sort of shape. You'll see why in a second. That bit ends up at the front of the nose. You know, you need this sort of shape, and it will cover the nose. Let's coat everything in Bactroban, guys. If you said to me post-operatively, especially in AFS patients, but all patients, Staph aureus is your enemy here. Staph is the #1 thing that colonizes Staph aureus or AFS patients. And I certainly go to a lot of trouble to make sure they don't get, if they are colonized, that they get decolonized in the post-operative period, and that I prevent colonization of the sinus cavity. And that's a lot of the antibiotic regimes we use in sinus, is not to prevent cellulitis or meningitis or prevent an infection. It's about decolonizing a cavity that's really traumatized. The epithelium is inflamed. It's denuded in areas. There's lots of blood around. It just creates an environment to create colonization. And so let's go the shaver on. Thanks if it's not on. I'll trim that up a little bit of that middle turbinate.
There is a question from one of the delegates, Richard, that what would you describe this cavity as in draft terms? Is it called a draft 2B or extended?
I'm so pleased someone asked that. It's called a draft 2C.
C.
And I know that's not a real draft term, but I'm sure Wolfgang would pay it, you know, if he was still with us. I met Wolfgang many times and we talked about it. And we actually refer to it as a draft 2C. It's not something new. It's actually a variation of what Wolfgang even did himself, you know. Do you think I could get that lip a little bit more? Just give me a baby Hoseman and I'll just make sure. No, I'm pretty vertical. I always want to think, can I get more? But here, guys, have a look here at the orientation. See how we can see into everything? That's the vertex of the frontal sinus, just with a 0 degree. Have you done a graph, Peter Lee? Fantastic. Okay, so big wash now. Let's put everything back together, and I'll show you how it all puts in together. And 7 minutes, Jared. So, Blakesley, still got, this is the last one, Lenny, if you want to do a patty count. I think that's the last one. Nope. Big wash again.
The field has been excellent, and you mentioned at the beginning about bradycardic anaesthetic rather than hypotensive. So what sort of numbers do you try and, if the patient can tolerate it?
Yeah.
How bradycardic?
Yeah, no, I'm so lucky. I've got the world's best sinus anaesthetist. Look at this here. So Jarrett's so good. You know, essentially, you know, I just tell him the numbers and then he makes it happen. It's amazing. And we don't go for. I actually asked Jarrett not to do extreme hypotension. I don't want hypotension. I actually want bradycardia, normally with a 6 in front of it. Can I get an up Blakesley, thanks?
Okay.
And or up through cut, yeah. I have an up through cut. And so a 6 is fine. It doesn't have to be 50. It doesn't have to be crazy. But then I actually say to Jared, don't make it like an excessive hypotension. Because if you've got significant hypotension, you potentially are just dilating your systemic peripheral vasculature. And that doesn't help you as a surgeon, you know. If you have a dilated field, like if anyone's operated when someone's had an anaphylactic reaction and everything dilates, it's a disaster. You can't operate. You actually want your peripheral resistance to be tight. And so this idea of having, you know, mild, like what a mean arterial pressure, Jared, what, 90, 100? Seventy, sorry. And you keep your systolic around what? Yeah, 90 and 100 on the systolic and a map of 70. 59 to 65, there you go. Okay, give me the SurgiFlow, thanks. Actually, we'll do the silicon, yeah, let's do SurgiFlow first because I have to do it. Sorry, not primed, all good. So you see this area here? You know how we stripped it all, guys? So we generally make up a very thick SurgiFlow mix. You can just use Spongistan or gel foam. You don't have to use thrombin-containing one, but you know we've just got a fancy thrombin-containing version. And we fill it so that then we place the flap over the top. And it's all about trying to obliterate that space. And so I actually intentionally want this to become obliterated. But like I said, you don't have to do that. You could just use Spongistan. But the whole idea is you're not trying to recreate the floor at the same level. You want it almost there. And you know, Ashok and Louise, I'm sure you've drilled out the silicon sheets, thanks. All the dressings, thanks. Mac and Doe, thanks. I'm sure you've drilled out a papilloma from the maxillary sinus, and where you've done extensive drilling, the whole sinus has contracted. Have you seen that, Louise?
Yes.
So like,
Yes, definitely.
you know, it's only really channeling that sort of experience. Do we use then, you know, this idea of sort of drilling off the bone and mucosa? Now, I probably didn't need quite as big a sheet on the contralateral side, but I just made them the same because I'm used to doing it. But you can't really suture just to the septum. You've got to always suture to a little buttress on the other side. I'm sure everyone does that, don't they?
Yeah.
And then if you just suture to the septum, it just sort of eats through. And I love silicone sheets. You know what? My opinion, you know, Ashok, over the years, I think many people who've been blamed for septal perforations, suture things, it's not their surgery that's caused it, it's the patient picking and doing things at the front of their nose in the post-operative period. Now, I think as surgeons, it's not like we're not part of the equation. We probably create a slightly anesthetic or numb front of the nose from surgery, and so they don't realize the trauma they're doing. But, you know, people who get that little bilateral little crusting and things at the front of their nose on both sides in the septum, that's not some vascular thing going on. That is the patient picking. They may not realize they're doing it, but they're picking it. And over the years, I've seen that, and I have taken patients back even to theatre at 2 or 3 weeks and put silicone sheets on it, and it all heals beautifully. But if you just leave it there to crust and just tell patients to use ointment, then it eventually becomes a perforation because they don't really, especially if you don't educate them about the fact that it's them doing it. Sometimes just finger in the nose after wiping with a tissue. Sometimes it's outright cleaning of the nose. You know, these are the sort of things that we really see that that cause problems, you know. And so that's one of the reasons my threshold for putting silicone in is so low, because it just protects my anterior septum from any problems. Now, next one we're going to do, we're almost done. So this is my next step in getting it all to heal. It's all right. Is my spacer. Now, we usually like to use then the remaining part of our local and tranexamic, because the spacer is like ridiculously hard. The rest of the local things, yep. And you can't really move it in the nose. You can't mold it. It's too stiff. Now, I don't think putting the medicine on the spacer helps, but as I sort of just douche it all, it runs into the sinus cavity. So instead of simply just sticking in saline, I use what's left over of the dressings, and you can see here in a heartbeat.
And what is that that's surrounding the Medicel pack? What have you sutured onto it?
Too long. It's too long. Sorry. It's a glove. It's a finger from a glove.
From a glove.
Oh, okay.
Yeah, 6 glove. And it just means that when you come to take it out, it doesn't stick.
It doesn't stick.
Yeah. And you know what? The nice thing about the spacer, Killian, please, is that you know the smaller one? Yeah, thanks very much. Is that when you take it out, you only need to find this little string. I'll show you this string here in a moment. And when you find the string, you then cut it and just pull it out. And it doesn't matter, Louise, if you've got heaps of crusting and blood and everything else, because when you just pull it, it all just comes. And it's an amazing, very quick debridement. And then whatever's left behind the spacer is often really moist and easy to suck out. And so it sort of makes your post-operative care really straightforward. Unlike my American colleagues, I don't get paid for post-op care. So I don't particularly want to have patients coming in for debridements all the time. I want to make that whole process as convenient for myself and for patients. So, doing that. Everyone who listens to with our American colleagues, the dynamic is different in America. People get paid for post-operative debridements in care. So give me the graph, thanks.
Yeah, we really struggle in the UK and the NHS actually trying to have regular post-op appointments for debridement. It's very difficult. We just don't have the capacity. And so how long do you leave the spacer in for? Sorry.
7 to 14 days. And I've got a couple of other tricks. You want to cut that in half? Curette, thanks. Here's my other little trick. So we never leave raw bone. The frontal curette, Lenny. And where we have any sort of raw bone, we'll cover it with a graft. So we've got a little bit of raw bone there. That's our graft. That's our inferior turbinate it's been thinned out and repurposed here, for the sake of this area. And I can't tell you enough. Like when we first started doing this, you'd think that it wouldn't make a huge amount of difference. Grafts like this take really pretty well. I would say the majority of the time, these sort of grafts take well. And I'll have the pure region here in a moment. So even if you got
what natural healing would you expect for a cavity like this? Is there any natural narrowing?
It should look perfect at 3 weeks. That's what I expect. Not 3 months of exposed bone and granulation tissue. That's what I saw when I was a trainee, especially after Lothrops. And that's why people get problems with stenosis. You get this chronic inflammatory reaction at the site of your healing. And I just wanted to have one last little look.
So you won't expect much of a natural narrowing of the opening.
Very little. And you know what? Even if you get, Ashok, a little bit of blunting at the front here, it doesn't matter. You've had the Carolyn's window. You're going to end up with you've done all your frontal sinus cavity really easily, and it'll leave you still with a giant opening. So even if you've got a tiny bit of webbing at the top, it's still a huge opening compared to what you would achieve with a angled instrumentation. And look, this is
pure region.
Yeah, pure region. I like it. I think especially behind a spacer, it works really well because patients don't wash it out. And then I'm just going to wiggle it up there, and perfect. See it, and now it's sitting across my flap and stuffed up in there, holding my grafts into place. And we're almost done, guys. I'm just going to fold that back. I just want to make sure this is tucked up. I always tuck the knots if I can behind the internal valve so that patients don't actually grab them. And then if I've got a little bit of space back here. If I've got a little bit of mucosa, I'll leave it across this area, and I'll take the Surgiflow, thanks, whatever's left of it. Cover that area, even if it's just going to act as a biologic dressing. That's another area that you don't want to have granulate and heal poorly. Can I get the dead space, thanks? And the nice part about thrombin-containing gel foam, it actually forms like within a day, it's like a little brick. I don't know if you, like mud. Have you ever seen that? It actually, if you've ever gone back in on someone who's had like a thrombin-containing gelatin matrix, it it really does form like a little pack, doesn't it? You got to really make an effort. It's not soft like this. It becomes very stuck together. Okay, fantastic. And then a little bit of Bactroban at the end, and we'll get our next patient who's got a fungal problem, but a mycetoma, and a much more straightforward situation. But we'll talk about very similar concepts. We'll drill open the whole face of the sphenoid, create a very big opening before we then remove the actual fungal ball. And we'll be back soon.
Thank you.
My pleasure.
Ashok, I think you might be on mute.
Yeah, so I think no further packs.
And we'll do all cameras off. Do you want to put up the next brain lab? Yeah. And we'll put up our brain lab. I'll put up the images of our next case. So we'll have those up ready to go. And we'll turn over here is really quick, so we won't be long before we get next person up.
Yeah, sure. So we'll wait for your message. Okay.
Are there any other questions about that case, Ashok? You know, for me, a big one is getting her allergy right. You know, and it not necessarily giving her fungal immunotherapy, but just she's just going to take dust mite immunotherapy. And in Australia, we have oral dust mite agents like Carazax and Actair, and they work really well. So that's what she's going to.
I think there's a question about not necessarily related to this case, but what is the place of navigation in sinus surgery, and when do you use it?
I use navigation when I've got a procedure that's very much directed by images. So if I've got an entirely intradural procedure, where I'm coming externally on a trajectory towards something, that's when I think image guidance is fantastic. Yeah, and obviously, Ashok, from this case, you can see that we didn't use image guidance to tell us where we were. We found anatomical landmarks to really define where we were. And so I'm very much a surgeon who promotes this idea of using anatomical landmarks, because if you're a little bit starting off your career or doing something you're not used to, image guidance is great. It can help you orientate where you are. But, you know, there's no guarantee it'll work. You know, sparks might fly and smoke might come up from the back of the machine. And, you know, if you're sort of relying on it, then it's a real problem. How about yourself? What do you guys do? I mean, how is image guidance used in the UK?
Yeah, I mean, I think it varies. I think the way that I tend to use it is very much like that as well. So I used to use it when I started doing the draft breeze, for example, and I was building experience. I would use it just to sort of almost double check that I was where I thought I was with anatomical landmarks. But actually, as your experience builds, you know, I've stopped using it for that. And in fact, one of the hostels that we worked in, that we did the cases in, we didn't have it, but we were quite happy doing the draftees because we had built up the experience with it. So yes, maybe very far lateral frontal disease, I would maybe put it on. And then obviously the skull-based cases.
Yeah. Little funny lateral mucoceles that you're trying to poke into and things. Yeah, that's often useful. Yeah. But this sort of case here, any sort of standard FES, medial maxillectomy, drilling and stuff, like, it's great to have in the room. It's a great teaching aid, but it's never an absolute essential item. How about you? I didn't open up the posterior ethmoid or sphenoid, you know, and I was speaking to Ashok before about that. I said I was going to do it in a heartbeat if it was tight or I couldn't see, but I think at the end of the day it was probably the right decision. What do you think, Ashok?
Yeah, I think the scan showed all the sinuses were normal, wasn't it? So there wasn't any evidence of any infection. So if it is not, it's not to open it was probably a right thing to do.
Now,
but,
I mean,
some people might.
That said, Ashok, I have done AFS surgery in the past where, in the process of doing the surgery, I've set off AFS in another area in the sinus cavity. So I've cleared it from one area and then it started in another. So I can happen. So, you know, I am a little bit wary of people who would like to do everything in one go if they've got AFS. But I am always temperate about, you know, the fact that that whole back area seems to be functioning fine and it's not expanded and it's not distorted. So we chose to leave it. We'll see how that goes. I'll get back to you.
Right. It's so individual, isn't it? Some surgeons will take a view while you're there on that side, at least particularly on the same side. If you're opening the other sinuses, why not complete the posterior ethmoidectomy and sphenerotomy? So it's really based on their individual philosophy as well.
Yeah, I mean, I think a lot of surgeons, it depends as well where you are in your career, because I think when you start out, you're often very aggressive and you want to do everything, and often you do too much. And then what you start to see, you maybe see complications back from having done something that perhaps you didn't need to do. So I think, you know, reevaluating your practice as you go through your career and gain more experience is important.
That's a good point, Louise. I always say to people who have sinus cavities that are normal, I mean, even though people associate me with being a relatively comprehensive sinus surgeon, you know, I would say when sinuses aren't broke, you know, don't try to fix them. And there's, I always tell the fellows that there's only one direction you can go if you have a normal sinus cavity and you open it up. And sometimes you have to, right, to find anatomy or get orientated. But when you open a normal sinus cavity up, there's only one direction you can go, and that's down, you know? And so it's such an important thing to remember. And so when people have normal sinuses and they're doing a FES on one side and they think, while I'm here, I'll do the OMC on the other side, that's such a fraught with danger. There's only a risk of making it worse, you know, unless you're really convinced there's a problem.
Yeah, absolutely.
That's a great message. It's a very clear message that if it's not broken, don't fix it.
Yeah, don't. And you know, that's not me. That's a Southern US Rod Schlosserism. If it ain't broke, don't fix it. And he might have got it from Fred Kuhn, actually. So I'm not sure where it came from. So I can't claim for that saying. Yeah, so but the mucosal flaps make a huge difference. The little lateral wall flap, we call it, makes a huge difference. All of these things make a huge difference. And I can't tell you, it's doing all those things over the years have really changed my practice. And I really encourage everyone when they do sinus surgery, you know, to move away from concepts of ventilation and plumbing. You know, that doesn't really marry up with our understanding of disease, and think about reshaping sinus cavities. And when you reshape them, always think about covering raw areas with silicone or grafts. Makes a big difference, in my opinion, to healing.
So over the last 10 years, Richard, what is the biggest change in your own practice as far as the frontal sinus is concerned?
Once again, I've abandoned almost all concepts of sinus disease being a ventilatory issue. So I think that plays almost no role for most patients. And, you know, so therefore that directs the type of surgery I do. And you'll see it next time. In the next case, Ashok is a great example of that, and we'll talk about it. But that's a big thing. I'm very aggressive now at modifying the local anatomy so that I can get access there. And maybe I was just a terrible 70-degree surgeon, but you know, I think doing things with 0-degree scopes, your dexterity and your ability to manipulate tissues are so much better. I think once you start working with angled cameras, you become a picker. You pick and scratch at things, and I find that very, very awkward. And then to me, the final one is just the idea of making sure that nothing is sitting in airflow. We shift something like 15 to 20,000 liters of air every day. You cannot have patients use enough saline treatments or ointments to keep it moist. It just never works. And so the idea of making patients irrigate 4, 5, 6 times a day is crazy. You're better off just covering everything with silicone sheets, grafting it, and that actually does really, really well. Like, we use silicone sheets all the time over raw areas. We graft things, we lay flaps back, and that really wasn't drilled into me, you know, when I was a trainee, but something I think's evolved in the last 10 years, you know. And things like, too, Ashok and Louise, like removing the sump of the maxillary sinus. If someone said to me, Richard, do you really need to do that? Do you really need to do it? I mean, you saw what was happening down there.
Yes.
But unfortunately for me, I'm the guy who has to sort out all the problems in Sydney, right? And a lot of the surgery is done really well in Sydney, I'd say. We train really good sinus surgeons. And so these are the sort of things that I'm left with people who've had really good surgery, but then they're still getting crusting on the floor of the maxillary sinus. You know, you've said to me, how do you sort that out? And you've got a patient who's compliant with their irrigations. Well, you need to obliterate the sump of the maxillary sinus. So these are the sort of things that I sadly have to see. And a little bit that's driven some of the changes in my practice, I would say.
Okay, thank you. That was
do you want to bring
useful.
up? Do you want to bring up the next scan, or do you want to break? How do you want to do it?
How far would you need for to prepare for the next case?
Yeah, they're cleaning the room. The next patient will be in here in a moment.
Okay, so we'll take a 5-minute break, and we'll be back. Thank
Fantastic.
you. Can I get studio to play the information video, please? While we take a break. Thank you.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble, and that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly, or certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, And before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know. Where are the blood vessels that supply the eye that can hang down in the nasal cavity so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid artery. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Okay, thank you. I think we can go over to Sydney now. Thank you. Hello. Welcome back. So we're back with Professor Richard Harvey in Sydney. So we just had a fantastic case with the sinus surgery, showing his signature Caroline window technique, approach to the frontal sinus with the frontal graph 2C, so wide opening. So it's a great to see how he performed the medial maxillectomy and cleared out the mucin from the sinus, which was very thick. So we will soon be joining him for the second case. So over to Sydney. Anything else you want to add, Louise?
I mean, I think what you could see from that, the field is so good, the surgery is so efficient, and Professor Harvey makes it look very easy, but it's all these small techniques that he was explaining to us that build up, all these small changes that he makes with each case that give you that end result. It's great to learn all these tips and tricks and techniques to improve your visual field, to improve the efficiency of your surgery, and to improve the overall outcome as well.
Yeah, interesting to see how we minimize any exposed bone. Most of the bone was either covered with the pedicle flap or then free because of the graft. Even the turbinate that was excised to use to the advantage of covering the rest of the bone.
That's right. I think the bradycardic anaesthetic as well, because I think there is a tendency for, certainly in the UK, for hypotensive anaesthetics, but you still often have that, very bloody field, and it can be quite frustrating. So I think that's a very good point.
Correct. And it's not only one thing, it's a combination of all things that together give you the good surgical fit. And of course, needless to say that the better the field is, your outcomes improve with that. So spending a little bit of time, even that reverse Trendelenburg position, that 15 degree, I was so particular about having this 15 degree. Anything less than that is not really very helpful. Again, the extension, patient position, get proper access to the sinuses you're dealing with. So all these little things really mattered. And although he's a great proponent of using knot degree endoscope for ease of access and surgery, he wasn't shy at picking up the 70 degree when it was really needed to check around the corners. And then, yeah, so you can inspect that. So we're back over to, hello, Richard, we're back over to theaters now. Can you hear us? We haven't got a sound. From what can you see here, it looks like a sphenoid, unilateral sphenoid disease with a lot of osteogenesis all around.
It's often something that we question, isn't it? When you see isolated sphenoid disease, you often, these are the things that are picked up incidentally, aren't they? And you get asked about a scan. And I think it's something that I probably would have a very low threshold for taking the patient to theatre and opening the sphenoid sinus up. You know, I've heard people talk about just leaving it, probably non-rhinologists, if they had to do an MRI scan for something else and they pick it up.
Yeah,
but,
true.
you know, I think if you have isolated sphenoid disease, it really can lead to complications further down the line.
Absolutely. And especially the surgical dilemma, it gets worse in patients with a significant comorbidities. Then you're weighing on one hand the risk of the surgery and on the other hand, risk of the disease causing any further problems. And we're talking about asymptomatic incidental finding here.
I had a case
Can you join
recently.
back to?
Oh, sorry.
Sorry, yeah, go ahead.
No, that's fine. It was just if we had a slight delay, I shot, but we'll see if we can get back to Sydney.
Yeah. So let's connect back to Sydney. It'll be interesting to see what Richard does in this case, because often, as we find, just doing a simple sphenoidotomy may not be adequate, because it can narrow down with the recurrence. So how extensive you need to go?
Yes. Yeah. I wonder if you'll do a posterior septectomy and open up the sphenoid into one cavity.
Yeah, absolutely. I have over the years done my lessons in a very low threshold to consider that option, and that really gives, it's almost performing with the Lothrop for frontal sinus surgery.
Yeah. I think it gives you such good access, and actually, you know, once you've done it several times, you really become much quicker at doing it and much more efficient.
Absolutely.
And conditions that you used to have to approach externally, these lateral frontal sinus disease or pathology, that actually, if you do a Lothrop, you can get that access now out quite laterally. without having to do the combined open approach? Because I think certainly in Glasgow, I had a cohort of patients that had open approaches, and they often have quite significant neurological type pains. And it's very difficult because they do have ongoing frontal sinus pathology, but you feel that it's probably not causing their pain.
Yeah, true.
Then you're in
making
a
the
very
distinction,
difficult
where is the neurological pain, which is the frontal, the pain due to the frontal sinus pathology. It's always hard to make out.
Yeah.
And often that again poses a decision dilemma.
They just sent a message saying Richard's out of theatre just for a few minutes. I was just going to tell you about a case recently where there was a young girl had come in with sphenoid disease, and she had a periorbital cellulitis and cavernous sinus thrombosis, and she had been fully heparinized, but actually we took her to theatre, and this, because I think it's always this thought process, certainly in Glasgow, again, probably non-rhinologists, where once the patient had been started on treatment dose heparin, you didn't want to go in and operate on the sphenoid sinus. But again, I would have a very low threshold for that. And, went in, there was no issues with bleeding at all. And that was on somebody who was, fully heparinized for cavernous sinus thrombosis. So I don't know about you, Ashok, but I think if you've got that situation, it is vital that you open the sphenoid sinus.
Yeah. It shouldn't be too long now in Sydney. So after this case, we'll have a bit of a break, and then we'll be joining Dr. Sati Jain from Jaipur in India. So he's got quite a few interesting cases planned up, like angiofibroma, then again some revision phases. So it'll be interesting to see revision phases, because often surgical landmarks is an issue there. So how to navigate through those situations, it'll be interesting to see. And maybe some very different techniques approaching the same thing.
And it'd be interesting to see the JNA, because they deal with a huge volume of JNAs, don't they?
Yeah,
in his practice.
They have a larger tumors presenting, because of late presentations. They could be quite large tumors.
Yeah. Am I right in saying as well, he tends not to embolize the patients preoperatively?
Yeah, that's what I hear. Really interesting to see what is their practice about embolization. We certainly do embolization.
That's right, yes, standard.
Most of the cases.
How were the cases earlier, Ashok, today with Puya and from the US? What cases did you see?
We had a fantastic case. I think it was a case of craniopharyngioma. And it's a wonderful display of anatomy. Initially, they thought it was likely to be a papillomatous craniopharyngioma.
Okay.
And so but then on exploration, it turned out to be a cystic lesion. It wasn't really a keratoma type of epidermoid type of tumor, and they have to aspirate it out. So they have to change the surgical strategy in between. Again, a great learning about being careful in planning your reconstruction, planning your surgery.
Yes.
They had a nasosacral flap. And great to see how Prof. Kara raises his nasosacral flap and really explaining details about various aspects of nasosacral flap, maintaining the structural support to the nose, looking after being careful about olfaction. And then again, they're using the reverse flap to help the healing and minimize the crusting, etc. And then again, very brilliant surgical techniques, dissection around the carotid, around the optic nerve by Danny Provedello. And we went through the tubercle and approached what then thought to be a craniopharyngioma, which turned out to be an epidermoid. And very carefully aspirated all that content of the epidermoid so that anything left behind can cause recurrence. And then reconstruction. So they use the soft gasket technique with Duragen and some spongistrone. It was very similar to what we saw on Monday with Paolo Battaglia, where he used the gasket technique with facial eta and cartilage. So instead, they used the Duragen and spongistrone. And that looked like a very robust repair.
So did they find that the defect that they ended up with was smaller than they had expected because the pathology was different? Or had they opened up, was the approach as big anyway because they had planned?
Correct. I mean, in that situation and that anatomical location, that was probably the widest possible approach at the time. But once realized that dissection, because it was part of it was stuck to the hypothalamus, and then making that judgment call, that is, you're likely to cause more problems and more harm,
damage. That's right, absolutely.
Than the benefit. So it's stopped there.
Yeah. And how old was the patient, Ashok? Was it an adult?
The patient was an adult, 50s.
Yeah.
And that's again, Danny had a good argument that it took almost 50 years for the epidermoid to fully to that stage.
That's right.
So in the hope that another 50 years, it will take another 50 years.
That'd be fine. The craniopharyngiomas, I was just going to mention the craniopharyngiomas, especially the pediatric ones. The defect that you create is huge. It's very difficult to reconstruct, because everything falls back into the space. So it's very difficult to, it takes quite a bit of time to reconstruct that robustly at the end of what's often a very tiring operation.
And the other thing was with these papillomatous craniopharyngiomas, there is now shift in management strategy, and that's the message Danny really wanted to give it out, that no more they're looking at attempting a complete excision, but now it is about getting the histological diagnosis and decompressing the craniopharyngioma. And then further is the medical management, which seems to be quite promising, getting the better outcomes. So that's a good, interesting shift in management strategy now.
Good.
So for a case like this, will you use navigation?
For this case, the sphenoid case? No, I wouldn't, Ashok, no. I think you obviously study your scans, you want to know what's happening around your optic nerve, your internal carotid artery. But I think, your trajectory here for your sphenoid is straightforward. So no, I wouldn't use navigation for this. What about you?
Yeah, likewise, I wouldn't do necessarily navigation in this case. And often in the cases where you use navigation, it is on a standby. We know that it is there if really required.
What I find as a consultant with the navigation, I think you use it at the beginning when you've not got as much experience with certain operations or certain anatomy, and you really are just double checking where you are. You're not using it to know where you are. But then what I've found happening is you then set it up, but you don't use it. You know, so you go through the entire operation and you don't actually pick up the probe. And then you progress to a point where, you know, cases such as this, you're not actually even setting it up.
And what is your antibiotic strategy for the case like what Richard did? Would he give any post-operative antibiotics?
I don't think so. For the allergic fungal rhinosinusitis, the case that we've just seen, I wouldn't routinely give antibiotics.
Okay, yeah. That's mainly the management with the steroids.
Yes, yes. I think that was quite interesting what Richard was saying about 3 weeks, because I think I've maybe been a wee bit overly aggressive. I've probably been giving them for about 6 weeks, but using that sort of maybe 2 or 3 weeks of the higher dose and then tapering off. But I think he's right. You know, you want to minimise the exposure to oral steroids. So that 3-week course with 1 to 2 weeks of the higher dose up to 25 milligrams, I think sounds like a good regime.
Yes.
I think they're almost ready in Sydney. Just the patient's been anaesthetised and being prepped, and then they'll be ready to go.
Yeah.
What do you use for prep? So in a patient like this, would you prep the patient? Would you use diluted betadine or?
No, not at all. So there won't be any compression, just draping the patient. Then, I don't use it within the betadine. And interesting to see how approaches the sphenoid. So whether goes to the sphenoid straight or
yes, like a transnasal approach
transnasal transitoid. The pituitary surgery type of approach. I think while we're waiting and nearly ready, we can play one of the informational videos. Can we play a video, please?
My name is Dr. Abib Agbatova. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant synechiae formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and synechiae formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draft 2B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening. After completion of the draft 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour propel stent in both the left and right neofrontal ostium. However, given our increased access to in-office use for the Propel device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulence, and less bleeding. At the patient's second postoperative visit, the patient was noted to have minimal edema, no synechiae formation, and minimal crusting. The contour propel stents were found to be in excellent position. This was a very interesting case in light of the patient missing multiple postoperative visits secondary to both the COVID pandemic and the patient himself contracting COVID. I truly believe this was an unforeseen advantage. The 2-in-1 mechanism allowing for mechanical spacing and localized drug delivery, I believe may have prevented restenosis, synechiae formation, and the need for potential additional surgeries. At the patient's third postoperative visit, 1 month removed from the surgical date, the patient was noted to have very minimal tissue edema, no crusting, and again, no synechiae formation. There was no signs of any stenosis, and again, the contour propel stents were found to be in excellent position with minimal adjacent crusting. At the patient's fourth postoperative visit, now 3 months removed from the surgical date, the neofrontal ostium bilaterally were found to be widely patent. No evidence of mucosal edema, synechiae formation, or evidence of restenosis. The contour propel stents themselves have been degraded and/or debrided. Chronic sinusitis is a chronic inflammatory disorder. Steroids are immensely helpful. So the idea of us placing an implant that will release steroids over a period of 4 to 6 weeks, but minimizing the side effects of systemic steroids, I think is a significant advantage for patients. At this 3-month follow-up, the patient reported resolution of his sinus headaches, postnasal drainage, as well as his nasal congestion. For patients with chronic sinusitis, with true chronic rhinosinusitis, there are so many different variables in place. We all know it's a very heterogeneous disorder, and so trying to predict how one patient may heal versus another can be very, very difficult. Even in patients with nasal polyps, there's a wide spectrum. So I really like the idea of an implant, a steroid-releasing implant, as insurance in many cases. Anytime I'm doing any type of formal frontal sinus dissection, when feasible, I like placing the contour propel stent because you never know what patient is going to be prone to synechiae formation or stenosis. Some patients may have moderate disease, but may have a propensity for scar formation, whereas others may have very severe disease, but may do very well without placement. And so trying to decide who to place it in can be very, very tough. One of the advantages of now being able to place it postoperatively is that if you don't feel comfortable or if you feel like you would like to avoid placing it in the operating room, you now have the advantage of placing it in the office setting. If you see someone who has increased edema in the frontal recess or increased edema in the ethmoid cavity, or maybe their middle meatus is becoming a little bit more narrowing, their middle turbinate is somewhat lateralizing, now you have the option of placing a propel stent in the office so that we can combat the edema, we can combat the inflammation, and then we can allow for mechanical spacing of the delivery device or of the propel stent. Tissue and wound healing can be very unpredictable in this patient population. We all know that the sinus cavity that's most likely to stenose is that frontal recess and that frontal neoostium. So for me personally, any type of formal dissection involving the frontal sinus, I am most likely going to place a contour propel stent. Whether that's in the OR or in the in-office setting will be patient dependent.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there. And we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patient.
Have you got? No.
Hello, Richard.
Hello, you got me now?
Hi, we're back. Yes, we're back.
We're back and we're ready to go. We're scrubbed and about to start. So we're just finishing up some draping and everything else. Now, so let's put the BrainLab scans up on the panel for you guys. So everyone can see that. So this is a 61-year-old lady who has a 6 to 12-month history of a retroorbital and central headache. So this is a very typical presentation for a fungal ball. And as you go down, you'll see here, like in my mind, I think there can be sometimes a bit of confusion between isolated AFS and fungal ball. Like in the last patient is a young person. Can you hear me okay?
Yes, we can, but there's a bit of an echo there.
It's a young person who's atopic and they have allergy. That's very typical for AFRS. Fungal ball, though, patients are typically in their 50s to 70s. You know, there is an association with having endodontic treatment done, you know, because we think that the endodontic treatment and probably not just the endodontic treatment, but the idea of having periapical, you know, dental disease predisposes you to having mucus stasis in the cavity, and that's why you get problems with fungal ball formation. Try not to leave me with some length here. So, so she's in her 60s, and she presented symptomatic. Now, I acknowledge that actually a lot of people with fungal ball get, I'm getting a bit of feedback. Yeah, okay, yes. No worries. I'm getting so when it comes to fungal ball, it's generally symptomatic over time. So there's been studies that have looked at longitudinal assessment and observation of patients with fungal ball. And during a period of observation, only 20% of them remained asymptomatic. Many of those who present asymptomatically become symptomatic over time. So in 70 symptomatic patients or asymptomatic patients, only 20% remained asymptomatic during a period of follow-up. So when you see someone with a fungal ball, it needs to be offered treatment. And I think this is very important because when you see it and it's asymptomatic, it's all very well to say, listen, I know it's asymptomatic, but patients need to understand, can I get a spinal needle, please? That it's likely to become symptomatic over time and that they should be offered treatment. There should be no rush to that treatment. It should be considered elective, but they should be offered treatment, in my opinion. And I don't think that always happens. I think some people think it's a condition you can watch. And I think it's a condition that's not urgent, but I don't think it's a condition that can be observed. So I think there's a difference between conditions you can observe and conditions that are just not urgent. And I think that gets confused. What's in the UK, if you're 50 and you get diagnosed with a sphenoid fungal ball, would you ever be just told it's okay to watch it? Is that, what's Louise and Ashok, what happens locally?
I mean, interestingly, just talking about it, me and Louise, before you joined in, and I think we both agree that we would certainly be offering the surgery to this patient. Yeah. But some other fungal ball, but often you come across patients who have a unilateral opacification and were completely asymptomatic as an incidental finding. What would you do? And that is that kind of dilemma.
Yeah, but, I tell you what, it's like someone who has a large dental abscess, or periapical lucency. You got to tell them, listen, that tooth's not healthy. We swap to the 25. You're going to need an operation at some stage. And I think that's, just because they're asymptomatic doesn't mean you don't offer them treatment. I think being asymptomatic affects the timing of treatment, how much patients put it in their health priority and when they feel like they need to do it. But it's certainly not something that I would tell patients, it's okay to watch it. Now let's have a look. Let's go now to, so on our radiology, you can see it's got the classic material in it and the classic neoosteogenesis. A big issue here, Ashok, is the lateral recess pneumatization. Fungal ball is not a disease of ventilation and mechanical blockage. It is a disease of mucostasis again. When mucostasis occurs, then it sets the scenario for fungal material to grow in the non-moving biologic material. Hey, let's go now to our endoscopic feed, guys. So I just want to show you then what we're doing here. Tell me when you've got the endoscopic feed up. You got it? Okay, so here we are now. Very sadly, I've got a septal deviation on the side of my fungal ball, which I'm going to have to manage, right? But actually, if I just work past this, I can actually see it here now. Can you see the sort of fungal material coming out of the sinus? There it is there. Can you see that? And what's notable here is that, Ashok and Louise, is the absence of an inflammatory reaction, unlike the last person. Yeah. So yes, this is an example of a fungal condition, but this is a condition of fungal colonization without sensitization. And here we are, of course, we're just in the superior meatus, and we're just going to fracture the superior meatus, so the middle turbinate's being fractured out. There you go. And we've got just a tiny bit of fungal material poking out from that area, right? Now, I'm going to do a quick septoplasty. We'll do it endoscopically. So now we talked about all the things again about preparation, right? So relative hypotension but bradycardic anesthesia, reverse Trendelenburg, systemic tranexamic acid, topical adrenaline, which is 1 in 2,000. And when I inject, even my injection, first of all, my injection is long-acting local anesthetic, not short-acting, like it's got no ropivacaine in it. I don't think we should be using xylocaine in surgeries. It doesn't last long enough. I know it's conveniently mixed with adrenaline, but it's actually not ideal for patients, in my opinion. And then we even put a bit of tranexamic, 100 milligrams in a 10 ml syringe for the injection as well. I'll keep that. Now, we're just going to put some patties now, have some patties on the cheek. So, good time now to bake the back of the nose with some patties. And we'll very quickly raise a little septal flap and some mucoperichondrial flaps through a hemitransfixion. And Peter Lee, I might get you down my sum, yeah, because we'll show the team how I find the things. Now, I on my YouTube channel, Ashok and Louise, I put a little thing just for, registrars and trainees often ask, how do you find the surgical plane in these patients? It's a really straightforward thing when you learn how to do it, but when you're learning, it's actually a bit tricky, right? There's no absolute clear goal as to, how you do it or what's a good sign. And so I'm going to show you just one trick that I often teach trainees to help you find the plane. Yep. I'll go artery clip. I'm just going to set up the last things. We've already done timeout, so we're good to go. So Peter Lee's going to hold the scope here. Like that. Killian, small Killian speculum. Come right in. Yep. See if you can see on the screen. Yeah, it's always one of those ones. The view endoscopic is much better always from above. Injection. And I don't mind, I'll work around you. It's all good. So first thing I do is I put the caudal edge under tension. And then I balloon out the caudal edge with local. And so it's not just vasoconstricting, Louise, it's also tamponading it. Give me the blade. Then, with now my tamponaded front wall, I'll cut straight down. And it might blur out because of the glare. Can you see it? We scratch down. Can you see there? Now what I want to do now is I want to scratch down until I see what we call cartilage dust. And I can feel it just coming up now. Can you see that? See how there's some cartilage dust there? Mm-hmm. Give me the caudal. Now by definition, we are now below the perichondrium. If you see the cartilage dust, you have to be, right? Because once you've got, pull back for me a little bit. Once you've got the cartilage dust, you know that you have to be in the right layer. Because if you're digging out the chondroid matrix, you are by definition below the perichondrium. And you can see, without even a headlight, I can find my way in there, right? And so that's really important. And then, of course, we always must, I still believe in the superior inferior tunnels. So very quickly, you'll raise in the right plane. We'll go back down now. And you want to find the best place to orientate yourself in a endoscopic septoplasty is the sphenoid rostrum. Can you see that, guys? Louise, Ashok?
Yes.
That's the rostrum. So once you find rostrum, then you can find the floor. Mm-hmm. There's your inferior tunnel now. Mm-hmm. Bring your inferior tunnel forward. And then you should be able to see where the incisive nerve and vest, there it is there. See how they're going into that canal? Yeah.
Yes.
Yeah, so we don't want to stretch that too much. That's when patients get a bit of numbness around their teeth. I'm just going to take those out, those patties. I can feel them when I'm dissecting. Now we have to pick a point. You can see where the septum, I'm going to do the world's simplest access septoplasty here, right? So this is about where it bends, don't you agree, guys?
Mm-hmm. Yes.
Yeah, so let's just take this up here. There's our bend up the top. Let's just go back a little bit. And we're well back in the nose, right? I'm right on the bony junction here. This is mainly a bony deviation. Okay, you can see I'm straight onto the plane on the other side. And I'm a big fan of getting all the plane right. And if you don't like the position of the septum, like you can't see the dissection point, just push it away. What am I looking for? Sphenoid rostrum, right? There's my rostrum. Mm-hmm. Push it out of the way so I can get my instrument in. Let's find the floor. Almost. There's the floor. There's your inferior tunnel. And now we're good to go. Little tiny, there, we'll call that my drainage hole then. On that side, got to have one. And there you go. And there's your superior inferior tunnels raised. And I do like the endoscope doing them all, like here. Okay, so let's take out this middle bit. Let's give me a straight iris scissor, thanks. Let's go heavy mayo then, thanks. So you can see I'm right on the bone, team.
Mm-hmm.
Yeah. I love cutting it. Heavy mayo, it's a great instrument for doing that. You can do it with a chisel, obviously. And then, yes, Minji's got our big Blakesley ready to go, but I just need to make sure that this thin bone at the back is released. Just so you can see me fracturing it. You don't have to do too much here. It's really this bit that has to get off.
I think for the trainees, when they see the septoplasty being done endoscopically, it really helps them understand how to do the operation.
Yeah,
I think a lot of them struggle with it because it's often done, if it's done as a primary procedure, it's done with a headlight, and they can struggle with the concepts.
Yeah, it's super straightforward when you see it done endoscopically, isn't it?
Absolutely.
You think, oh, what's all this talk about inferior superior tunnels? It's really straightforward. And you can see up here, see how we've got still a bit of a bend up here?
Mm-hmm.
So I'm going to come in here and have a look and see if I can improve this. Give me a heavy mayo again. Give me a Blakesley, small. Give me a coddle. Where's my coddle? She's taking it. And you can see I've got a tiny little, I don't know if that's a tear. It might be if it was. Recognizing a little tear early and making sure you don't continue it. It's very important. And to me, let's have a look now. Perfect. And that's about as good as I can get an endoscopic septum. If it's a funny bulb here, the high dorsum as you get further down into the support part of the nose, you can't really get that better with an endonasal septoplasty. But you can see how important that was, because it's made this area now so much more accessible. And it's not, when I think about doing access septoplasty, it's not really about just about the time of the surgery. I'm thinking about post-op care, post-op irrigations. How are all these things going to work, for my patient? Now the next thing we're going to do, no one wants to be operating in that whole lot of mucus there, right? That's a disaster. So give me a needle point, thanks. You get the sucker in your hand. So we're going to make a little tiny flap and expose the bony rostrum. Now, normally, I just burn straight down onto the bone, but of course here, we've just taken the bone out of the posterior septum, and so I just want to put a patty in just to protect my contralateral side. I just don't want to be, just in case. Just for a second. Suction to me. Okay. Needle point. I hope I haven't over-tucked that. Yeah, there you go. So you can sort of see where it's coming out of, right? So we're just gently. And I'm going to drop a flap down like this. And if I hadn't done a septoplasty, I just would have gone straight to doing this. Okay, and give me the sucker. Wipe the tip of the needle point, thanks. Now I'm going to go back and make sure that as a surgeon I've cut all the way down to the bone and everything. Perfect. Okay, give me a coddle, thanks. Put the drill on, thanks. Now, once again, I don't want to be messing around here, playing through a tiny little opening, getting all the fungus out. And the other thing too is that this is not a condition of ventilation. fungal ball, we published a little paper, Louise, just recently, a year or two ago, where we just followed up fungal balls treated primarily by rhinologists, where they never had a prior surgery. The surgery was by a rhinologist, where the rhinologist followed them up and really made sure that they had everything was working and doing well. But they had to, they were compliant patients, and we made sure they were compliant, at least they told us they were compliant with post-op care and irrigations. And 20% of them on long-term follow-up had mucostasis in their sinus cavity. And a big group of them, it was symptomatic. And that's because whether the mucostasis is there at the beginning of a fungal ball condition or whether it's acquired along the way, they lose their mucociliary clearance and it ain't ever coming back for some of these patients. And so a little bit, that's in my mind when I think about what surgery am I going to be doing for them. And so the surgery that we're going to be doing for them is one that's about reshaping the sinus cavity, making sure that there's excellent access for irrigation, and where possible, there's dependent drainage under gravity. So things like the retroclival recess, I want to see all disappear. So same story here. Minji's going to get her stylet ready because very sadly, once again, like the Carolines, I'm going to start drilling where I'm using the ball of, like the pole of the drill a little bit. I don't like using the pole, obviously. When you use the pole, it's not efficient drilling, just like in temporal bone drilling. And it's always better, as you can see, when I use the equator, so much better to use the equator of the burr. Now, but you see my mucosa, I do not want to get into that yet, right? Like when we do frontal sinus surgery, I don't want to get into sinus. I want to complete my drilling, and I want to remove all the bone down to the floor of the frontal sinus, the floor of the sphenoid sinus. And you know what? I ain't going to see it on this side, right? So one of the things that I'll do is I'll intentionally go and open up the contralateral side, and immediately, Ashok, it'll give me orientation as to where I am. So we'll see here in a moment. Oh, I don't want to get in on that side. I don't want to get in. Doesn't help. Inner sinus partitions may be slightly off to this side. There you go. Intentionally gone to the contralateral side, right? Because it's going to give me my orientation here. It'll give my superolateral orientation. I'm just blocked, thanks. Leave it, leave it. And probably the biggest place I want to find first is the inferior limit. Because I know superior limit tells us where skull base and brain and everything are, but it's the inferior limit to me that is where we got to drill down to when we do this case. And you got to remember this bone's very, very thick. And a bit like
Sorry.
Yeah, I was going to say, just a bit like we drilled more bone and created less exposed bone in the Carolines by incorporating the intersinus partition. We'll do the same here in a second. Just going to get a wash. It's okay. Come back in. And what's important here is not putzing around, in my opinion, with a kerosene or a punch around the ostium, but really reshaping the sinus cavity so that we're going to be left with a a lovely smooth bowl of a sinus cavity. And you know what? That's sometimes easier in some cavities than others. And it all depends on how thick the bone is, how much neoosteogenesis is formed. And this sphenoid rostrum area, I'm hoping in a moment I can, just with a heavy Blakesley, so a Tilly Hankel, I might just be able to pop out, but not for a while. And so it's no little bit of bone, right?
Yeah,
now, you were going to say something,
Yes.
Louise. What were you going to say?
Yes, sorry. I know. I've got a few questions. So say you were just dealing with type 2 diffuse inflammation. How would your approach to the sphenoid sinus, for example, differ, or would it differ? Would you still be looking for as wide an opening to, ensure that there's dependent drainage? What would be your approach?
Say that again to me. In what condition? So not fungal wall. You're...
Exactly. So you've just got a patient with, diffuse type 2 inflammation, so bilateral inflammatory nasal polyps.
Yeah, so it's like some sort of type 2 eosinophilic disease.
Exactly.
Yeah, so I would normally just do a full house sphenoethmoidectomy. In patients who are going on to biologics and have bad disease, I usually trim the middle turbinate, the transverse section, so you're just leaving the sagittal part of the middle turbinate. And then I will, let me just get myself orientated here. Good. One sec, give me a Blakesley. Just want to get rid of that little bit of bone. It's a bit of bone from my septoplasty, little flake. But I will make sure, I don't normally do like a bilateral drill like this, but in just inflammatory disease, I'll just leave it, don't worry about it. I will normally just make sure that the floor is dropped down so that a straight sucker can get into the retroclival recess, but just through a unilateral approach. And to me, if you said to me, why a straight sucker in the retroclival recess? Well, anyone who's looked after patients with bad eosinophilic disease knows that over time, these patients sometimes get flares, even the ones on biologics, and they get mucus plugging. And one of the things that can really be a problem is mucus plugging in those patients. And so I like to have at least, straight instrument access into the retroclival recess. And that just means that if they ever get a mucus plug, I'm not relying on prednisone alone. I can also just in the room suction it out. I also think that optimizes their irrigation. I think we published a paper maybe about 7 or 8 years ago looking at different sphenoid openings and how that improves irrigation delivery to the sphenoid sinus. So if you make a bigger hole, you get bigger delivery there. And you can see here, like when we did the maxillary fungal, the AFS case, I'm getting to a point now where I might be able to deal with the fungus. But look here, see how I can see that we're not even at the top layer of the, I've opened the contralateral side, so I know that we're not even close to being near the roof yet. But coming up, here we go. Give me big wash, thanks. And oh my gosh, how simple is it going to be now to deal with this ridiculous fungal ball? So there we go. A little bit more. Drill, thanks.
How long do you follow these patients up for? So, in the
at least a year. At least a year. Yeah, at least a year. I don't call it a win until I see him back at a year with a functional sinus. And you know what you need to do as a surgeon? You've got to look into the sinus cavity. I think a lot of people do antrostomies for maxillary fungal balls, and they call it a win, but then when they look in, there's a little pool of yellow secretions in the floor of the sinus cavity. You've probably seen this, and that is not something that's been done wrong by anyone. It's not the sinus cavity open too big. It's just simply a sinus cavity that hasn't got function. It's just not clearing mucus. And it happens, it happens. Let's go bipolar, thanks. You saw here I just picked up a little branch of something. So I think now's the time. What do you think? Should we have a go at let's go back to the, so here you go, we've got a lovely now, it almost looks like the other case we did, right? But it's not the maxillary sinus, it's the sphenoid sinus. So we've got all this tissue here. Let's put a shaver on, thanks. And go heavy Blakesley, thanks. I'll give you a sample here. For formalin, right? Don't people send it away for micro. We don't want microbiologists getting wind of fungus somewhere in the sinuses. They'll want to put my patient on lots of big treatments. Okay, now let's go big wash, thanks. And let's go to the 12 sucker. So I'm having to deal with mucus again, guys. It's not... Give me a look how easy it is, Ashok.
Yeah.
Easy. Fungus just comes out. Big Blakesley. And now all we have to do, guys, is we've got to shape the sinus cavity, and I've got to have a look at our lateral recess. Because the lateral recess, depending on how inflamed it is, if you can get inside the teeth for me, great. I'll pull it. Now, as opposed to AFS mucus, fungal ball mucus is something you can pull out. Don't you agree? It's got a sort of a different consistency, isn't it?
Yeah.
Like old school English fudge, you know, a little bit solid. You can grab it. Big wash. And you can see I haven't even opened the contralateral side in terms of the septal mucosa. So when this heals, it just heals like a nice big unilateral sphenoid opening, that's all. Hey guys, for closure here, 2 silicon sheets, 1 nasopore. Okay.
It's almost very similar, Richard, like the draft 2C you did for the frontal.
Yeah, it's exactly the same. And same sort of concepts. Whereas the previous patient had a problem with hypersensitivity reaction to the fungus, this person, their main problem is simply just mucostasis, right? And so you're going to see it in a moment. We're going to have to really work at understanding what's happening in the lateral recess. So there's a couple of things we'll do first here, guys. So I'm going to expose, you'll see the front face here. So let's pull that back. Let's pull that back. Give me the sucker. We'll go back to the 10 sucker maybe.
So if this patient did not have a lateral recess, Richard, would you still open the other side? Or that is nothing?
Oh, you know, I always open the other side because it's great for making sure that it all heals well and everything else, yeah.
Okay.
I would say, yeah, you know, opening the other side is not about the lateral recess. It's about this idea that these patients, you just want to find an access. Go to the drill now. So there's a couple little things we're going to do. We're going to just drill away the intersinus partition because I don't think it helps us to have it there. Okay. Okay, so I'm not a big fan. You saw me drill away the inner sinus partition in the frontal. It only improves your access and ability to control the sinus cavity, so we will very quickly just get rid of it. Now, in some fungal balls, our current fellow, Christian Merwin, is from Zurich. You know, he's done a little project to show Ashok that actually fungal bore is more likely to occur in the smaller of the sinuses, and that very commonly they have funny little things where, like, they've got a small retroclival recess and other issues going on that probably predispose some sinuses to developing fungal bore. And you can imagine, you've probably been in the retroclival recess in some people, and you see that, you know, really, you know, tiny little clefts and pockets. I think we're out of fluid, or it's come off. big wash while waiting? Just reconnect my irrigation. Just reconnect that. That's all it is. My irrigation popped off. And it's very important when you're drilling in the sinuses, do not use drills without irrigation. The reason people sometimes think that drilling a bone is worse than kerosene it is because of burning. There's no other rationale as to why that would be the case. You know, you just don't want to burn your bone. And especially as we come up to the bit of bone that's going to become part of our final cavity. I'll put a shaver on here and we'll just give it a quick shave because we've got. Now, a little bit like the sphenoid, I don't want her to have little crusts or things in her sinus cavity. So part of me is thinking about the function, right? Let's go shaver. I'll shave that bit of bone at the top, but you can see how that's made a much smoother transition there. You know, less little pockets and spaces for things to collect. And I'm just going to get rid of some of this mucosa before we then have a look. And then we'll drill a little bit of that lateral wall just to see what's happening. There we are there. Give me the drill back. Big wash, might as well. Bit of bone dust around. Let's tidy it up. Now you can still see there might be something in the lateral recess, the drill please. But we're going to now drill the last bit. See this front face of the sphenoid here? Like this would be a thing that we would very commonly drill in pituitary surgery, you know, this wall here. Because, you know, when pituitary operations, you really want access. And you'll come across a little vessel here called the palato-vaginal, or what's another term for it? Parapharyngeal. That's another option for it. It's a branch that comes off the Vidian artery.
Mm-hmm. Yeah.
And it's in a bony canal, and we'll see it here in a moment. It's not the septal branch off my flap. That's even more far forward than where we are.
Yeah. It can be sometimes one of the branches contributing to the blood
and you'll
supply
see
to
it's
GR-ESS and all.
Exactly. It comes off a little right angle to the Vidian canal.
Mm-hmm. Yes.
Yeah, and you'll often pick it up when you're drilling this bit of bone, and it's totally fine. Okay, I've got, there it is. Okay, see it bleeding? On cue. Okay, give me, I'll just drill a little bit more here. Get the bipolar ready, thanks. Okay, I'm gonna bipolar this, and then we'll have the big wash, thanks. Where is it? Down here. There it is. Okay, big wash. Have a sponge to me, just so I don't get wet. Okay, we're going to wash in a stick then. Just make sure we've got hemostasis. We've got beautiful hemostasis, looks good. And you can see I've intentionally kept that wall of mucosa, and I'll show you what we do with it here at the end. A bit of bone dust and things around. Give me another wash, thanks. And actually, I think we've got a little bit of bleeding just from down here. There's maybe the other branch, the other end of it. There you go, give me the bipolar, right? Look at that, diabolical, bit of back bleeding. Okay. Yeah, so you can see I use a lot of these bulb syringes in my cases. Just a great way of very quickly getting mucosa out. Okay, you can see, look, I told you,
Yes.
This is why you come and see a
Very awesome.
rhinologist for your fungal ball, right? Okay, here we go. Give me the wash on a stick. And if you hadn't made the effort to look, the long curve one, you wouldn't have seen it, Ashok.
Yeah, absolutely.
Give me the one with a short right angle. Let's try that one. Now, I was just talking to Peter Lee Sachs, who's our fellow, and I said, see that? Well, look at all that fungus come out. I said, one of the problems here with lateral recesses is that it looks like it's not a bad looking lateral recess on the image, but the bone's thickened, that narrows it down, then the lining's thickened, that narrows it down, and essentially, for the most part, it's a completely occluded pocket. Now, okay, so if you say to me, what do? We're going to do something very similar. Now, look, I wouldn't be against, like if this is not your area, you're not used to being in the sphenoid all the time, you could just end the operation here and just hope the lateral recess comes good. But you go the 90 curette, thanks. But channeling the spirit of what I was talking about before, if you said to me, my practice is all about sorting these problems out, and this is where sphenoid fungal balls often fail when someone's done a really nice operation, maximally open up the sphenoid, they look on, they can't understand why the patient still has a little bit of pain, a little bit of niggling issues. Let's go Patty again on a Blakesley. Oh, I hope I can get that back. I'll have to get my... Let's go again. Curette. Let's go to curette, please, again. And I'll see, I might go to 61 next time, actually. I think this is just a bit too... I want to decongest now the lateral recess and see what the hell is going on out there, how big it is, and we'll get a 70-degree scope and have a look. And like I did to the sphenoid floor, we might just simply obliterate the lateral recess. 70, 60. Yeah, I think it's a better angle, yeah. I thought the 90 would work. Okay, Patties, let's go, keep going. And so I'm just going to pack this off for a second, guys, because you've got to remember, this is the first time this sinus cavity is going to see any vasoconstriction. And it's a good time to do it. Give me my silicon sheets, please, that we were using before. Okay, so I'm going to let that bake for a second. I'm going to very quickly make straight iris things. It's not arts and crafts. I'll make that same shape I did before, because I want it to come forward to protect the front of the septum from fingers and trauma. And also, the nice part about putting silicone on too, Ashok, is that, you know, you don't have to worry too much about whether you beat up the lining, putting scopes and drills and everything else back and forth. You know, it's all dumpy. You have 70-degree scope up here, thanks. You can take that back. Fantastic. And let's go with the curve sucker now, long, thin one. Okay. And Peter Lee, actually, can I get a Metzenbaum, thanks? Give me a Blakesley, thanks. I'm going to take a little graft here and I'll explain it in a moment. My favorite place just to harvest in a low morbidity way is always the soft tissue tail of the turbinate. Can you see that? Can you see how taking that mucosa, I'm not even into the bone or the artery itself, and that area is right at the back of the nose, so it doesn't crust very much. And if you ever want a little bit of mucosa from somewhere, so much better just to take it from this area than, you know, the front of the turbinate, or some people take the inferior part of the turbinate. It's just an easy way to harvest. Okay, give me a Blakeslee. And you can see it's all a tiny operation here. It's about the size of an Australian 20-cent piece. What would that be in British currency? A small procedure. Okay, let's go 70. So let's have a look at it, right? So actually, before we finish, maybe just for orientation for everyone, we should just point out where everything is. So here we are here. Lateral wall on the contralateral side. Roof is just here. I can just see it. I can see roof here, right? But I haven't gone crazy. I haven't, like in a pituitary, I drill all this back. It's not necessary. But I've drilled this back here, so at least there's very little sump between those two areas, right? I've drilled this down, but that's actually level with the retroclavial recess now. And if I'm to drill more here, I'm not really going to achieve more. It's not like I'm going to expose less bone, Ashok. So, you know, that is an area where I might just put a graft on. Now let's have a look. And on the frontal instruments, what do you have? Those frontal probes. Just and we better get, guys, can we get a look at that. So let's get a frontal cups, side to side forward opening, side to side opening cups. And we'll take my, remember I said I didn't think I'd get my patty out, right? That's exactly what happened. So I'm looking at this now though, guys. When I look at it, it's a big looking opening. Mm-hmm. I've got it almost flush with my floor. Yeah. I'm going to inspect it. If I think that the edema is minimal and it's an area that's likely to be washed out with a very nice wide front opening, I'm going to leave it. Because it looks too big for me to simply strip out here through a transnasal route. And actually, I think if I needed to do something here, I'd probably have to come transmaxillary, front onto it. It's such a long, deep pocket. Can you see that? Mm-hmm. And look how beyond V2 there, it disappears well beyond V2.
Yeah.
Yeah.
So it looks clean, isn't it? So
it looks acceptable. It's a bit of edema. Yeah. It's probably going to wash out, and so we're going to leave it. But if it was really thickened and the bone had narrowed it down, so that it was actually even smaller than that, I'd strip it out. But that one there, I'm not confident that I could strip that out and do a good job at it. Not through this angle. I mean, I'm looking with a 70 and it's big. So, but that's all favorable. The fact that it's big means that it's probably going to do well. Can I have the pure region now, thanks? I will take it off this. Yeah, I'm going to put
So again, you're applying very similar principles to frontal sinus surgery. You're using the grafts and all that on the sphenoid.
Yeah, so you bet. You bet. And the same concepts as in the maxillary sinus when it came to function, right? So just a bit of gel, just because I scratched up the back wall there. Just make sure it's 0 degree. Let's put the other one on now. Just suck it back, the pure region, before you decant. There's a lot of dead space in that tube. And I'll go back to the 10 Fraser, thanks. And now we're going to finish up, guys. So I'll show you what we do to finish. And then I've intentionally left the septum for me to close. No one needs to watch me put a mattress suture in and some horizontals. That's... I'll do that when everyone's gone. But I will put silicone sheets on. Okay, so give me the graft. Now, when you put the grafts in, you can see I took it out as a small piece and it's now a big flatbed. That's because my fellows very kindly thinned it out and made it a nice thin graft. Something like that. And that's just great. This is going to help it heal. Give me coat the nasopore with Bactroban and soak it with some tranexamic. Let's make it happen. Bactroban first. Yep, just like we do in other cases. There you go. Now, this is one area where I don't mind nasopore. I think nasopore works quite well. So we've got a little graft there. We're going to fold this back. That folds over that whole area really nice. This is all just the undersurface of mucosa on the other side, Louise. So, you know, once again, we're going to have very minimal
exposed bone.
Exposed bone, yeah. And it's all going to be underneath the lovely nasopore. And then in the back of it, when I do the pure region, I ditch what they sell it with, and I just use an 18 gauge blunt. It just works a whole lot better, in my opinion. This whole middle turbinate was never sitting in a good position because it had the septal deviation there. Give me that gel back, thanks.
That's actually a question that somebody has asked from the audience.
Yeah, what's that?
What you think is a good method to medialize the middle turbinate?
Medialize? The technique I showed you in that first case where we make those little fractures here, like this. Yeah, this one's loose. It's already done. Like you can see gel's holding it open. So, and now that's it, guys. And now what I'm going to do, I don't trust myself in here, right? It looks pretty, but I've been in and out with instruments and everything else. And so I'm just going to coat it with silicone sheet. But I'm going to close the septum first. And so let me close the septum, but that's really maybe let's go a 5-ovacral repeat, maybe and a single tooth. I can take any questions while I'm doing this because this is a little bit boring. No one wants to, everyone's seen suturing happening. Anything else you want to know about that case? And look, that was really straightforward, you know, Louise, in my opinion, and Ashok. We knew where we were, we maximally opened things, we made an executive decision about how to manage the lateral recess. You know, there's no extra morbidity for the patient for moving all that bone. It's only an addition for them, you know, as opposed to just someone who tried to go through the natural os and just scratched around for ages. You know, that there's no extra morbidity for the patient in just doing it. And in fact, I think with a drill, you often get rid of a lot of the thick bone and you can leave almost near mucosal to mucosal edges. You know, not quite, but almost.
And again, like the previous case, you have left other sinuses untouched. You could have easily adopted middle enterostomy and treatment, post-treatment, then to the sphenoid, wide sphenoidotomy.
Yeah.
That was very...
You don't need it, do you? In this case,
exactly. I
think if you've got a papilloma, Ashok, and it's in the sphenoid, and it involves the lateral wall of the sphenoid, I think in that situation, it's really good to open the ethmoid because it allows you to see where the orbit is anteriorly to your pathology. You can find the orbital axis and the orbital wall, but something like this, pituitary surgery, this type of surgery, you know, we open the posterior ethmoid on one side in pituitary surgery, just so we've got a place for the scope to hide. But really, when things are just sphenoid-based, I keep it really simple. Aggressive at where we are, what we need to do, and artery clip, please. And then not aggressive elsewhere. Yeah. Thank you. Nice touch.
And then post-op regime for this case in comparison to the last case?
Very similar. She'll get exactly the same anti-staph treatment, so she'll get some anti-staph antibiotics. I'm not too fussed about what people use as long as it is anti-staph cover. And I like ones that have BD dosing, right? Because when my doctor asks me to do anything more than twice a day, I'm non-compliant. And so I pick Augmentin Duo, doxycycline, cotrimoxazole or Respirem, or Bactrim as it's sometimes called. All these are great anti-staph treatments and are all BD dosing. So I like all of those. They'd be my favorites. Anything in that zone is good. I use mupirocin ointment in the nose, BD, and they irrigate BD. So everything's like a BD regime. They just do BD everything. And I will give her some prednisone, and I'll see her at a week, and I'll probably stop her prednisone. Now, that's optional, but I think giving prednisone in her is going to reduce her edema and swelling and make it more comfortable for her. It's not really about treating the disease in her. It's about making sure that she doesn't think of me too poorly as a doctor. Okay, we're about
again, there is a question about middle turbinate. Some surgeons would consider taking the middle turbinate down, and that is for post-operative surveillance access to the area. What are your views on that?
Yeah, I don't need to. I don't need to. I think you'll see when this is all said and done, you're left with a giant cavity at the back here. You know, it really is a nice big cavity. You can easily get to it. It's not like So when we go down here, we'll have no problem seeing all this. But I will, of course, put my silicone sheet in, right? So I will make sure there's not a single adhesion in this space. You know, it's so common. I see people operating down the sphenoid. They do things in the sphenoid, and it's just a bunch of adhesions between the superior turbinate, and it is amazing, and the septum, or the middle turbinate, the septum. And it's amazing once again how often we get away with that. We get away with it, but you know, in some patients it becomes symptomatic, and so it's really just about making sure that we don't cause those. And having a silicone sheet in the nose over the next couple of weeks, patients barely notice it. They're more affected by the swelling that occurs in the nasal cavity, not by having a 0.5 millimeter sheet. And I don't think it's till about they hit the 3rd week post-op that they sort of can tell that there's even something in their nose, you know.
So what thickness sheet do you use, Richard?
0.5 mil. 0.5 mil with that little extension that comes all the way forward, and then I sew it in with a 4-0 Proline. And I just do one suture. You don't need to do more than that.
Do you use mupirocin rinses a lot?
No. Almost. I mean, okay. I have to say, no, not almost never. But Louise, we all have those patients who've had radiotherapy and they've got a non-functioning sinus cavity and occasionally get mucostasis and bacterial colonizations. Yeah. So that's the only scenario in which I use medicated antibiotic irrigations. You know. And then I must say I use iodine irrigations in those patients. It works quite well. And they're patients in which you just probably have permanently impaired mucociliary clearance, and they have to use irrigation all the time. And occasionally when they, gets away on them, they get a flare, you know. But that's it. Here we go. We'll just double check everything. Get my view up. Once again, we've got lovely anesthetic conditions from my very skillful anaesthetist. You can't see anything down this side, right? It's like we were never there. Never there. Yeah. And then down this side, we've got gel and everything to heal. And hopefully a middle turbinate sits in a relatively nice place. But I don't even care if it lateralizes a little bit there. It was in a lateral position already. And I just want to make sure that all of this looks good. And look, I think it was really worth doing the septoplasty, don't you think, guys? I think I would have I would have really struggled to look after that. Say this all got really crusty and I had to pull it out, I think I would have struggled. So although I think I could have potentially worked around it, it's a benefit in the post-op period. Now that's it. I've only got one more case, which is just a septal turbinate case. So that's it. I think you've got other things on. Is there any other questions?
Yeah. No, I mean, that was wonderful. I mean, it's very good surgical principles, very consistent with in both the cases. So there's a good message there. I certainly learned about using the mucosal grafts on the sphenoid. I never used that before. And I will certainly change my practice. Yeah.
Yeah, I mean, you picked up on my philosophy, Ashok. You know,
Yes.
it's exactly the same. Every sinus cavity, it's the same sort of concepts. Now, but as opposed to the AFRS case, you know, this lady's healing is more about just irrigations and making sure that mucociliary clearance returns to that sinus cavity. And if it doesn't return perfectly, that's okay. We've set it up for a bit of gravity-dependent drainage. Whereas the first patient, immunosuppression because of her hypersensitivity condition is critical, you know, and so she will be someone that I won't have her come off the oral steroid until she's normalized her lining, and then even then she'll be on oral corticosteroids. Yeah.
Okay. Great. So thank you, Richard. It was wonderful to have you, and great cases. Thoroughly enjoyed it by all of us. The
My
recording
pleasure.
of these cases will be available to watch on our channel. So I must say that the case that you performed on one of our last events is still very popular. People do get to it, and the Caroline's signature Caroline's window technique. So it's great to see that again. And thank you to your theater team. Thank you to the best sinus anesthetists in the world that you have. And also big thank you to Jonathan and Steen for making this possible. They worked really hard behind the scene, getting all the technology setup done. So thank you, everybody.
And thanks for staying up for all those in Europe and England. We appreciate it.
Yeah. Thank you. See you.
Thank you.
So, Louise, that was wonderful. It was a great little tips there, and a lot to learn.
Yeah, so many learning points there, and to take away from and then apply to our own practice. Ashok, excellent.
Right, yeah.
2 fantastic cases.
Excellent. So it's now 23:30, so nearly midnight here in the UK. So we'll have a break, and then we will start again at 3 a.m. in the UK. That's where Jaipur in India, Dr. Satya Jain, he'll be starting. He's lined up for very interesting cases. So roughly around 3.5 hours. So we'll see you there. Okay. In the meantime, we'll be playing some recording of the cases that were operated over last 2 days. So if you are from convenient time zone, please or miss those cases, then you can watch them now. Thank you.